आप सभी को बहुत बहुत नमस्कार और धन्यवाद कि आपने अपना कीमती समय निकाला। मैं डॉक्टर अंशुल राय, डेप्यूटी मेडिकल सुपरिटेंडेंट एम्स भोपाल परिवार की तरफ से आप सभी का इस ब्रेनस्टॉर्मिंग वन स्टेट वन हेल्थ स्टैंडर्ड ट्रीटमेंट पॉलिसीज इस कार्यक्रम में मैं आपका स्वागत करता हूँ। हमारे बीच आज के कार्यक्रम के मुख्य अतिथि श्री राजेंद्र शुक्ल जी हैं, जो मध्य प्रदेश सरकार में उप मुख्यमंत्री हैं एवं लोक स्वास्थ्य परिवार कल्याण एवं चिकित्सा शिक्षा मंत्री का भी दायित्व है। मैं डायरेक्टर सर से निवेदन करूंगा कि पुष्पगुच्छ देकर हमारे मुख्य अतिथि का स्वागत करें। प्रेसिडेंट सर से भी निवेदन करूंगा कि सर आप इसके बाद मैं हमारे मुख्य अतिथि महोदय से निवेदन करूंगा कि वे लैंप लाइटिंग करें। बहुत बहुत धन्यवाद सर। मैं डायरेक्टर सर से निवेदन करूंगा कि वे आके इस वन स्टेट वन हेल्थ का अपना इंट्रोडक्शन।
सर्वप्रथम मैं एम्स भोपाल के परिसर और विशेषकर इस सभागार में उपस्थित माननीय उप मुख्यमंत्री श्री राजेंद्र शुक्ल जी का बहुत बहुत स्वागत करता हूं। मैं चाहता हूं कि हम सब लोग एक बार ताली बजा के इसी के साथ मैं एम्स भोपाल के अध्यक्ष डॉक्टर सुनील मलिक का भी स्वागत करता हूं और अन्य सभी गणमान्य महानुभाव जो कि जिन्होंने अपना समय निकाल के इस आज की एक्टिविटी में पार्टिसिपेट किया और उसको सफल बनाने के लिए हम लोग तत्पर हैं। तो मुझे बहुत ही खुशी है माननीय उप मुख्यमंत्री साहब का स्वागत करने में। वन स्टेट वन हेल्थ जो है एक ऐसा कंसेप्ट है जिसमें एक तरीके से जो कि देखिए तीन चीजें होती हैं, ह्यूमन बीइंग, एनिमल और एनवायरनमेंट। जब हम तीनों चीजों को एक साथ मिला के एक स्वस्थ समाज की, स्वस्थ देश की, स्वस्थ लोगों की परिकल्पना करते हैं तो कहीं ना कहीं हम लोग जो है वन स्टेट वन हेल्थ के रास्ते पे आगे बढ़ते हैं। ये WHO ने इसको एक इकोसिस्टम के रूप में डेवलप करने के लिए गाइडलाइन शुरू की थी, जिसपे मुझे बताते हुए बहुत खुशी है कि आदरणीय श्री राजेंद्र शुक्ल जी के मार्गदर्शन में शायद मध्य प्रदेश देश का पहला प्रदेश बनेगा जो इस प्रकार की वन स्टेट वन हेल्थ पॉलिसी पे काम कर रहा है। तो ये एक बहुत ही खुशी का विषय है और मैं खुश हूं कि एम्स भोपाल जो है इसमें सरकार मध्य प्रदेश सरकार का के कंधे से कंधा मिला के काम करने को तैयार है। ये एक कंसेप्ट है जिसमें एक कोलैबोरेशन जो है वो इंटरएक्शन और कोलैबोरेशन एजुकेशन, पब्लिक हेल्थ, एनवायरनमेंट और रिसोर्सेज को लेके होता है। हम लोग यदि एक साथ मिलके काम करेंगे तो कहीं ना कहीं मेडिकल एजुकेशन की ट्रेनिंग, रिसर्च, जो ट्रीटमेंट है और सबसे जरूरी जो चीज है वो वन हेल्थ वन स्टेट में वो है प्रिवेंशन। हम लोग बहुत सारे ऐसी बीमारियां जिनको प्रिवेंट कर सकते हैं समय पे यदि हम डायग्नोज कर ले और यदि हम एक प्रॉपर SOP बना लें तो उसमें हम लोग जो हमारे स्वास्थ्य के डिफरेंट पैरामीटर्स हैं, जिसमें मध्य प्रदेश जो है उतना ऊपर नहीं हुआ है, तो कहीं ना कहीं वो जो है हम लोग इस माध्यम से अपनी जो पैरामीटर्स हैं उनको हम और ज्यादा अच्छे रूप में कर पाएंगे। ये एक सबसे अच्छी बात है कि वन स्टेट वन हेल्थ जो है वो किसी एक संस्था का नहीं है, ये इंटरडिसिप्लिनरी है, जिसमें आयुष भी है, एनवायरमेंटल, पॉल्यूशन, मेडिकल साइंस, वेटनरी, सभी लोग आपस में मिलके एक इकोसिस्टम को तैयार करेंगे। हम लोग इसमें डाटा शेयरिंग, पॉलिसी डेवलपमेंट, एजुकेशन एंड ट्रेनिंग, और एजुकेशन और ट्रेनिंग जो है ना सिर्फ मेडिकल स्टूडेंट बल्कि हम लोगों का नर्सिंग एंड पैरामेडिक पे भी ध्यान रहेगा। हम लोग कोलैबोरेटिव रिसर्च पे एक संस्थान के रूप में, एक वृहद संस्थान के रूप में काम करेंगे। सबसे जरूरी है कैपेसिटी बिल्डिंग। हम लोग जब मैं माननीय उप मुख्यमंत्री जी के पास मिलने गया था, तो मैंने आपको ये बोला था कि हम लोग कुछ ऐसे काम शुरू करना चाहते हैं जैसे कि ई क्लासरूम, जो कि एमबीबीएस के स्टूडेंट के लिए काम करे, ई आईसीयू जो कि हम लोग टेली मेडिसिन के माध्यम से आईसीयू की सर्विसेज को पेरिफेरी के हॉस्पिटल्स में हम दें, और साथ साथ ई कंसल्टेशन। तो कैपेसिटी बिल्डिंग भी हम करना चाहते हैं, और एनएचएम और एमपी गवर्नमेंट के साथ हम वहां के डॉक्टर्स, नर्सेज, पैरामेडिक्स, टेक्नीशियंस सबको एम्स में, यदि आप चाहेंगे तो हम लोग एम्स बहुत खुश होगा हाथ मिलाने में कि हम लोग कैपेसिटी बिल्डिंग कर सकें। सबसे जरूरी है कम्युनिटी एंगेजमेंट। कम्युनिटी एंगेजमेंट जो है वो आउटरीच पॉलिसी जो हमारी होगी, जिसमें हम लोग एक हॉस्पिटल के परिसर से बाहर निकलेंगे और मरीजों के बीच में जाएंगे। हम ये नहीं सोचेंगे कि मरीज हमारे पास आए, बल्कि हम मरीज के पास पहुंचेंगे। तो कम्युनिटी एंगेजमेंट बहुत जरूरी है। और मुझे बताते हुए खुशी है कि इनोवेशन एंड इंक्यूबेशन सेंटर जो एम्स भोपाल ने अभी शुरुआत की है, वो भी अपने आप में एक पहल होगी, जिसमें बहुत सारे नए इनोवेशन मेडिकल हेल्थ में हम लोग कर सकते हैं। हम लोग एक आज जो मीटिंग है उसके माध्यम से एक सिंगल ट्रीटमेंट प्रोटोकॉल बनाने की कोशिश करेंगे। इसका मतलब यह है कि चाहे पीएचसी पे मरीज आए, उसका ट्रीटमेंट भी वैसे ही होना चाहिए जैसे कि एम्स भोपाल में होता है, जिससे कि मरीज को जो समय ट्रांसफर में है उसमें खराब ना हो और उसको अच्छा ट्रीटमेंट मिले। तो हम लोग उस पर भी विचार विमर्श करेंगे। यूनिफॉर्म रेफरल पॉलिसी, किस मरीज को टर्शरी सेंटर में आने की आवश्यकता है, हर मरीज एम्स में ना आए, उसका ट्रीटमेंट जो है वो डिस्ट्रिक्ट हॉस्पिटल में, क्योंकि एमपी गवर्नमेंट बहुत ज्यादा पैसा खर्च कर रही है स्वास्थ्य सेवाओं में, तो उसका फायदा यदि वो पेरिफेरी पे रहें और सारे लोग हमारे पास ना आए और सिर्फ वही मरीज हमारे पास आए जो कॉम्प्लेक्स हो, कॉम्प्लिकेटेड हो, तो हम लोग एक इस प्रकार का इंटीग्रेटेड सिस्टम ऑफ रेफरेंस हम लोग चाहते हैं कि हम लोग शुरू करें। ये हम लोग हब एंड स्पोक सिस्टम के माध्यम से ट्रेनिंग, ई क्लास, ई आईसीयू, ई कंसल्टेशन, सेंटर ऑफ एक्सीलेंस, पीजी ट्रेनिंग, और ये सारी चीजों को हम लोग चाहते हैं कि आज डिस्कस हो। और इस डिस्कशन के बाद जो एक हम लोग व्हाइट पेपर इशू करेंगे, वो मैं माननीय उप मुख्यमंत्री जी को समर्पित करूंगा, जिससे कि गवर्नमेंट के लेवल पे मैं जो है वो हम लोग उसको स्वीकार कर सकें। तो एनएचएम भी मैं चाहता हूं कि एनएचएम के माध्यम से भी एम्स भोपाल चाहता है कि एक डेडिकेटेड पीडियाट्रिक 100 बेड का डेडिकेटेड पीडियाट्रिक हॉस्पिटल एम्स भोपाल में यदि खोले, तो एक ही छत के नीचे सारे बच्चों का जो कॉम्प्लिकेटेड इलाज है वो एक ही छत के नीचे हो सके। उसके लिए मैं अब अपील करता हूं एनएचएम आपके माध्यम से सर कि आप इसमें हम लोगों का मार्गदर्शन करें, और आपके माध्यम से एनएचएम के से हमको यदि सपोर्ट मिले तो हम लोग इसको शुरू कर सकते हैं। और एक नई जो हमने पहल की है, जो कि एडोलेसेंट क्लिनिक और ट्रांसजेंडर क्लिनिक और ड्रोन सिस्टम से दवाइयों को पहुंचाने में, मुझे ऐसा लगता है कि हम अपने एक्सपीरियंसेस को पूरे प्रदेश के हेल्थ सिस्टम से शेयर कर सकते हैं। इन्हीं सब बातों को ध्यान में रखते हुए आज का ये संगोष्ठी हो रही है, और मुझे विश्वास है कि माननीय उप मुख्यमंत्री जी के मार्गदर्शन में हम लोग एक ऐसा सिस्टम तैयार कर पाएंगे जिसमें मध्य प्रदेश जो है वो पूरे देश का एकमात्र ऐसा प्रदेश बनेगा जिसमें पूरे हर पेरिफेरी पे भी ट्रीटमेंट स्टैंडर्ड ट्रीटमेंट मिलेगा और जो एम्स में आने वाले लोगों की संख्या है वो कहीं कम होगी। मैं एक बार फिर आप सब लोगों का बहुत बहुत स्वागत करता हूँ। धन्यवाद।
बहुत बहुत धन्यवाद सर। अब मैं हमारे प्रेसिडेंट डॉक्टर सुनील मलिक सर से निवेदन करूंगा कि वे अपने ओपनिंग रिमार्क्स दें।
माननीय श्री राजेंद्र शुक्ल जी, उप मुख्यमंत्री मध्य प्रदेश शासन एवं मंत्री स्वास्थ्य एवं परिवार कल्याण एवं चिकित्सा शिक्षा, आपने हमारे लिए समय निकाला, ये हमारे लिए गर्व और हर्ष का विषय है, हम आभारी हैं। डायरेक्टर एम्स प्रोफेसर अजय सिंह, डिप्टी डायरेक्टर, मेडिकल सुपरिटेंडेंट, सीनियर ऑफिशियल्स फ्रॉम द स्टेट गवर्नमेंट, और लर्नर डीन एकेडमिक डॉक्टर रजनीश जोशी, फैकल्टी, एस्टीम्ड डेलीगेट्स, एम्स भोपाल की ओर से मैं आप सभी का स्वागत करता हूँ। I start with thanking Shri Rajan Shukla ji and lauding our director Professor Ajay Singh for organizing this brainstorming session on such an important topic. The concept and the topic chosen are indeed very relevant. This phrase, "one state, one health," takes me back to the time when the COVID pandemic started. I had the opportunity to see many things from close. उस समय एक ही राज्य में विभिन्न हेल्थ एजेंसीज के आपसी सामंजस्य की आवश्यकता सबसे अधिक महसूस की गई थी। हर एनालिसिस में यही बात निकल कर आती थी। आज के टॉपिक के अतिरिक्त में एक और विषय मेरे मन में आता है, क्योंकि ये मंच सही है, इसलिए मैं कहना चाहूँगा, क्यों ना हम सभी हेल्थ एजेंसीज मिलकर, चाहे सेंटर की हो चाहे स्टेट की, एक रोबस्ट हेल्थ सर्वेलेंस सिस्टम मध्य प्रदेश में खड़ा करें जो देश के लिए एक उदाहरण हो। Let the Department of CFM of AIIMS Bhopal take the lead. It should engage the CFM departments of all medical colleges of Madhya Pradesh with the government and private in developing this system. Put this system in place, involve all district hospitals, CHCs and PHCs. Let it be a very robust, easy and a very practical system of reporting and importantly staying connected with each other. The endeavor should be spot any outbreak. Mind you, it is not difficult. PHC में जो पहला पॉइंट ऑफ कॉन्टैक्ट मेडिको या पैरामेडिक होता है, उसको सिर्फ एक ही चीज बतानी है कि कुछ अलग हो रहा है। जैसे एक ही बीमारी के बहुत सारे मरीज आने लगे हैं, या एक ही लक्षण के बहुत सारे मरीज आने लगे हैं, या ये इस मौसम में ये बीमारी तो नहीं देखने में आती थी, इस बार जरूर देखने में आ रही है, या मैं जहाँ पहले पोस्टेड था वहां पे ऐसी बीमारी नहीं दिखती थी, इस एरिया में ये वाली बीमारी बहुत ज्यादा दिखती है। इस चीज की सिर्फ वो रिपोर्टिंग करे, उसके बाद सीएफएम डिपार्टमेंट का काम है कि वो अपनी टीम भेजे और जाकर इन्वेस्टिगेट करे। एक छोटी सी बात मैं बताना चाहूंगा, मैं एक न्यूरोलॉजिस्ट हूँ। इंफ्रान्यूक्लियर फेशियल पैल्सी, जिसको कॉमनली बेल्स पैल्सी बोलते हैं, चेहरे पे लकवा जो होता है, मैं महीने में करीब 10 या 15 मरीज औसतन देखता था सालों से। सडनली फरवरी मार्च 2020 के आसपास मैं रोज के 5 से 6 मरीज देखने लगा इंफ्रान्यूक्लियर फेशियल पैल्सी के। मैं आश्चर्यचकित था, क्योंकि 25 साल की न्यूरोलॉजी में प्रैक्टिस में मैंने ऐसा कभी नहीं देखा, जिसके 10-15 मरीज महीने में देखता था, मैं रोज के 5-6 देखने लगा। मुझे समझ में आ गया कुछ अलग हो रहा है, समथिंग डिफरेंट इज हैपनिंग। इतना ही पर्याप्त है। 12 महीने बाद मुंबई से एक बड़ी स्टडी छप के आई। उस स्टडी में ये लिखा था कि कोविड की जो कॉमनेस्ट न्यूरोलॉजिकल मैनिफेस्टेशन है वही यही बेल्स पैल्सी थी। तो वही बेल्स पैल्सी जो मैंने ढेर देख रहा था, 1.5 महीने बाद जो है कोविड का पैंडेमिक शुरू हुआ, मींस द सिम्टम्स वर इन द ऑफिंग। ऐसे ही मध्य प्रदेश में एक एरिया है जो कि भोपाल से करीब 100 किलोमीटर दूर है। वहां से जो भी मरीज आता है, मेरे जब पेशेंट्स देखता हूँ तो मरीज का नाम और कहाँ से आया मालूम पड़ जाता है। जैसे ही मैं देखता हूँ कि उस जगह से आया वो व्यक्ति, तो मुझे पहले से मालूम है कि वो मिर्गी का ही मरीज होगा, और मुझे पहले से ही मालूम है उसकी मिर्गी की वजह क्या होगी, वो न्यूरोसिस्टिक सर्कोसिस होगी, जो कि ब्रेन में कीड़ा होता है, जो कि कच्ची सब्जी सलाद या सुअर का मीट खाने की वजह से होता है। मीन्स न्यूरोसिस्टिक सर्कोसिस इज एंडेमिक इन दैट एरिया। करना क्या है, कुछ नहीं, वहाँ पे जो भी डॉक्टर या पैरामेडिक है, कहीं से तो पोस्ट होकर आया होगा, वो ये पा रहा है ये बीमारी यहाँ पे बहुत ज़्यादा देखी जाती है, पहले तो नहीं देखते थे हम लोग यहाँ पे, मतलब मैं जहाँ पोस्ट करता वहाँ नहीं थी, यहाँ बहुत ज़्यादा है, ही ओनली हैज़ टू रिपोर्ट। रिपोर्टिंग हुई CFM को, CFM की टीम जाएगी और वो एक दिन के अंदर भीतर बता देगी भाई यहाँ तो न्यूरोसिस्टिक सर्कोसिस एंडेमिक। तो दो ही बात बताना उनको, सुअर का मीट मत खाओ, पानी उबाल के पियो, बस दैट इज ऑल। तो व्हाट आई इंटेंड टू कन्वे कि मिलकर हम सब एक जबरदस्त सर्वेलेंस मैकेनिज्म तैयार करें, एक मॉडल तैयार करें जो कि एंडेमिक बीमारी और एपिडेमिक को शुरुआत में ही डिटेक्ट कर ले। और ये आसान है, ये मुश्किल नहीं है। इसी के साथ मैं अपनी वाणी को विराम दूंगा। मुझे पूरी उम्मीद है कि आज जो पैनल डिस्कशंस होंगे, जो वर्किंग ग्रुप्स के ब्रेनस्टॉर्मिंग सेशंस होंगे, दैट विल टेक अस ऑल फॉरवर्ड एंड वी शैल बी सेटिंग एन एग्जांपल बिफोर आवर कंट्री। एक बार फिर मैं आप सभी का धन्यवाद देना चाहूँगा, विशेषकर हमारे माननीय उप मुख्यमंत्री जी का आभार प्रकट करना चाहूँगा जिन्होंने समय निकाला हमारे लिए। धन्यवाद। जय हिंद, जय भारत।
थैंक यू सो मच सर फॉर योर काइंड वर्ड्स। मैं माननीय मंत्री जी से निवेदन करूंगा कि वे अब अपने विचार तथा अपेक्षाएं हमसे साझा करें एवं प्रस्तुत करें।
भोपाल के डायरेक्टर डॉक्टर अजय सिंह जी, प्रेसिडेंट डॉक्टर सुनील मलिक जी, यहाँ पर उपस्थित सभी सम्मानित फैकल्टी मेंबर्स और छात्र छात्राएं, डॉक्टर मधुकर द्विवेदी जी और उपस्थित बंधु। एम्स हमारे देश की एक ऐसी संस्था है जिसको हर जनप्रतिनिधि चाहता है कि हमारे प्रदेश में आ जाए, हमारे ज़िले में आ जाए। ये अपने आप में ही इस बात का प्रमाण है कि हेल्थ केयर के सेक्टर में एम्स ने कितना अचीव किया है और कितना अपनी पोजीशन को उन्होंने बना के रखा है। और इसलिए एम्स के द्वारा ब्रेनस्टॉर्मिंग हो रही है। सिर्फ आप अपना मेडिकल कॉलेज या अपना हॉस्पिटल ठीक से चले इसकी चिंता नहीं कर रहे हैं, बल्कि आप इसकी भी चिंता कर रहे हैं कि जिस राज्य में हम हैं उस राज्य में सुदूर ग्रामीण क्षेत्र में, आदिवासी अंचल में अविकसित यदि कोई इलाका रह गया है तो वहाँ भी हम किस तरीके से उसको अपने साथ जोड़ के और प्राइमरी, सेकेंडरी, टर्सरी ट्रीटमेंट की आवश्यकता जो होती है उसको कैसे हम इस्टेब्लिश कर दें कि हमारे प्रदेश के अंदर कोई भी व्यक्ति बीमार होने के पहले आइडेंटिफाई हो जाए, उसकी डायग्नोसिस हो जाए और फिर टेलीमेडिसिन से या हर्बल स्पोक मॉडल से कैसे हम उनको फ़ायदा पहुंचा सकें, इसके बारे में आप सारे लोग आज यहाँ पर इकट्ठे हैं। और एम्स जब ब्रेनस्टॉर्मिंग कर रहा है इसका मतलब कि जो इस मंथन से अमृत ही निकलेगा और इसका जो फ़ायदा है वो पूरे प्रदेश के दूर दराज इलाके में पूरब से लेकर पश्चिम और उत्तर से लेकर दक्षिण तक पहुँचेगा। मध्य प्रदेश में कई क्षेत्रों में हम लोगों ने बड़ी तरक्की की है। हमने 24 घंटे बिजली देके पावर के संकट को समाप्त किया है। इरिगेशन के मामले में हमने वो काम किया है कि लगातार 7वीं बार कृषि कर्मण अवार्ड एग्रीकल्चर के क्षेत्र में हमको मिला है। स्वच्छता के मामले में भी पहले, दूसरे, तीसरे, चौथे स्थान पर हमारा मध्य प्रदेश के ही कोई न कोई शहर आता है। इंदौर है, भोपाल है, उसमें भी कोई राज्य का कोई भी शहर हमसे आगे नहीं निकल पाया है। इसका मतलब ये है कि यदि पॉलिटिकल इच्छा शक्ति हो और हमारे उस सेक्टर में काम करने वाले लोगों में एक मिशन मोड में काम करने की भावना हो, जुनून हो, तो किसी भी टारगेट को अचीव किया जा सकता है। हेल्थ हमारा अभी चैलेंजिंग सेक्टर है, हमें ये मानना पड़ेगा, क्योंकि जब हम MMR और IMR के आंकड़े देखते हैं तो ऐसा लगता है कि जब हम बाकी क्षेत्रों में टॉप पे हैं तो इस मामले में हम सबसे पीछे क्यों हैं, इसको कैसे सुधारा जा सकता है। तो एक तो वो है जहाँ पे उसका सलूशन हमको निकालना है। दूसरा, मैंने अपने मिनिस्ट्री में ACS हेल्थ और कमिश्नर हेल्थ से कहा है कि हम ये नहीं पता करेंगे कि हमारे जिला अस्पताल कैसे चल रहे हैं, हम तो सिर्फ इसका रिव्यू करेंगे कि हमारे CSCs कैसे चल रहे हैं। जो 348 हमारे CSCs हैं सारे ब्लॉक्स में, उसमें सारी चीज़ें हैं कि नहीं। यदि वहाँ पर जितने डॉक्टर्स होने चाहिए, स्पेशलिस्ट होने चाहिए, रेडियोलॉजिस्ट से लेके एनेस्थीसिया से लेके सारे लोग होने चाहिए, वो हैं कि नहीं है। क्योंकि लोग जिले में आने में उनको बड़ी परेशानी होती है। पंकज जी भी आ गए हैं हमारे, जो कमिश्नर वो MD हैं। तो ज़िले में आने में कभी कभी हमको अंदाज़ नहीं होता है कि वो पहले PSC जाता है, फिर CSC जाता है, फिर वो जिला अस्पताल आता है, और जिला अस्पताल आते आते रास्ते में बहुत सारे लोग इस दुनिया को छोड़ के चले जाते हैं। यदि उनका सब हेल्थ सेंटर PSC अच्छे से फंक्शनल हो जाए, CSCs हमारी वेल इक्विप्ड हो जाए, न सिर्फ इंफ्रास्ट्रक्चर से, इक्विपमेंट से, बल्कि HR से भी, तो फिर क्या ज़रूरत है। क्योंकि आजकल तो सारे लैब्स से लेके, इक्विपमेंट से लेके, OT से लेके सारी चीज़ें तो केंद्र सरकार की योजनाओं में हम कल्पना नहीं कर सकते हैं कि कितना हमको फंड मिल रहा है, कितना सपोर्ट मिल रहा है NHM से। तो हम क्यों नहीं CSCs को जिला अस्पताल की तरह बना सकते हैं। और यदि CSCs हमारी जिला अस्पताल में बन गई तो आप ये मानिए कि फिर हमारा जो MMR IMR के साथ साथ अन्य चीज़ों में भी जो रेशियो ख़राब है, पोजीशन जो हमारी ठीक नहीं है, वो ठीक हो सकती है। तो ये एक चैलेंज है बहुत बड़ा, क्योंकि MBBS करने वाला डॉक्टर, फिर PG करने वाला, उसको PG के बाद ब्लॉक में भेजना कैसे संभव है, ये विषय मैं आपके बीच में छोड़ता हूँ कि आप ये जब अपना रिजोल्यूशन पास करेंगे तो हमें ये ज़रूर सुझाव देंगे कि आखिर ऐसा कैसा अट्रैक्टिव हम ऑफ़र अपने स्पेशलिस्ट को दें। PG के बाद SR शिफ्ट होती है, SR शिफ्ट के बाद फिर वो लोग तो फैकल्टी में आ जाते हैं, असिस्टेंट प्रोफेसर ये सब बन जाते हैं, लेकिन CSCs में कोई जाने को तैयार नहीं होता है। तो ये सारा वेस्टफुल हो जाएगा। जितना 20-25 करोड़ में तो हमारी CSCs बनती है, बिल्डिंग और इक्विपमेंट और फिर उनके रेजिडेंस के क्वार्टर्स और ये सारा मिला के एक तरफ हम खर्चा करते चले जा रहे हैं, और दूसरी तरफ डॉक्टर्स को यदि हम वहाँ पर भेजने के लिए मेंटली कैसे प्रिपेयर कर सकते हैं, क्योंकि वो बड़े बड़े शहरों में रह के और अपनी पढ़ाई करते हैं और उसके बाद एक नया सपना लेके वो आगे बढ़ते हैं। हालांकि हमारे यहाँ 1250 PG निकल रहे हैं हर साल, 2500 से ज़्यादा MBBS हमारे सिर्फ सरकारी मेडिकल कॉलेजेस में, जो प्राइवेट में वाला है। तो इतने लोग मिल रहे हैं, यदि रोटेशन में भी हम उनको CSCs में हम पोस्टिंग दें और वो हंसते हंसते उस पोस्टिंग को एक्सेप्ट करें। हम कभी कभी देखते हैं कि हमारे यहाँ डॉक्टरों की पोस्टिंग हो जाती है, लोग कहते हैं साहब कर दिया पोस्ट। हमने कहा पोस्टिंग इंपॉर्टेंट नहीं है, ज्वाइनिंग इंपॉर्टेंट है। क्या उन्होंने ज्वाइन किया तो मालूम पड़ता है अगर 25 लोगों के ऑर्डर निकाले थे 2 ही ज्वाइन किए। बॉन्ड पोस्टिंग भी करते तो 10 लाख रुपए जमा भी कर देते, लेकिन जाते नहीं। 10 लाख रुपए जमा करने में क्या फर्क पड़ता है। MBBS और PG में मुझे लगता है 1 करोड़ खर्च होता होगा सारा फीस मिला के, 5 साल की MBBS और PG मिला के, इससे ज़्यादा 1.5 करोड़ खर्च होता होगा पर स्टूडेंट। 1 करोड़ 70 लाख उसमें कितना लगता है बच्चों का सब्सिडाइज करता है। तो अब जब उनको 1.5 लाख रुपए की पढ़ाई फ्री में मिल गई तो 10 लाख रुपये जमा करने में क्या फर्क पड़ रहा है। 1.5 करोड़ तो ये सबसे बड़ी चुनौती है हमारे। जब तक हम अपने हेल्थ सर्विसेज को, फैसिलिटीज़ को, ग्रामीण क्षेत्र, हमारा गांवों का देश है, ग्रामीण क्षेत्रों में पहुंचाने में सब, हम कहते हैं PSC में तो बहुत कम मेडिकल ऑफिसर की पोस्ट होती है, 1 या 2। सब हेल्थ सेंटर में तो मेडिकल MBBS डॉक्टर को जाने की जरूरत ही नहीं, वहाँ पे तो CHO और ANM रहते हैं। CSCs में 5 या 6 स्पेशलिस्ट होते हैं और 2 या 3-4 मेडिकल ऑफिसर होते हैं। वो कैसे 1 साल 2 साल 3 साल के लिए, और फिर वो रोटेशन में चल भी सकता है। तो हमें ये भी बताया गया कि साहब वहाँ पर रेडियोलॉजिस्ट से नहीं जा पाते कि उनको वहाँ पर यदि सेंटर चलाने की अनुमति दी जाए तो शायद एक बार वो वहाँ पे जाना शुरू कर दें। एनेस्थीसिया वाले नहीं रहते और सर्जरी वाले हैं भी, तो बिना एनेस्थीसिया के सर्जरी का डॉक्टर यदि है भी तो कोई मतलब नहीं। हमारे रीवा में सुपर स्पेशलिटी हॉस्पिटल में शुरुआत के 3-4 महीने में 22 बाईपास सर्जरी हो गई, क्योंकि वहाँ पर एक संविदा में कार्डियक एनेस्थेटिस्ट थे तो सर्जरी हो गई, और उसके बाद उनका डीएम का कोर्स पूरा नहीं हो पाया और कहीं बाहर इंदौर चले गए, तो अब 1 साल हो गए एक भी सर्जरी नहीं हुई, जबकि 2 CTBS के सर्जन वहाँ पर 2-2 लाख रुपए की सैलरी में बैठे हैं और बड़े दुखी हैं। इसलिए कुछ नहीं है कि उनको काम नहीं मिल रहा है, इसलिए दुखी हैं कि साहब हम बैठे हुए सैलरी ले रहे हैं, हमारे पास एनेस्थेटिस्ट नहीं। तो इस तरीके की जो चीज़ें हैं, गैप्स हैं, वो हमारे, और फिर उसके बाद रीवा से आप जितने भी बाईपास हैं वो सब बाहर जा रहे हैं, रेफर करना पड़ रहा है। कार्डियोलॉजी में ये प्रॉब्लम नहीं है, 2200 ओपन एंजियोप्लास्टी होगी, उसमें 2000 आयुष्मान वाले। तो एक तरफ सर्विसेज, इंफ्रास्ट्रक्चर, और आप कल्पना करिए कि 2200 लोगों की, ये 2000 गरीबों का एंजियोप्लास्टी रीवा में हुआ। यदि सुपर स्पेशलिटी हॉस्पिटल नहीं होता, कार्डियोलॉजिस्ट नहीं होते, तो वो 2000 जो गरीब थे उसमें नागपुर और भोपाल और इंदौर और मुंबई और दिल्ली कितने लोग जा पाते? तो हो सकता था कि उसमें 1000 लोग कब डिग्री छोड़ के चले जाते, मालूम ही ना पड़ता। लेकिन अब उनको मालूम है कि यहाँ पे सुपर स्पेशलिटी अस्पताल है, जाके चेकअप कराया, एंजियोग्राफी कराया तो एंजियोप्लास्टी हो गई। तो एक और बहुत अच्छे रिजल्ट भी हैं, दूसरी ओर चुनौतियाँ भी हैं, और उन चुनौतियों का सलूशन क्या है? क्योंकि मैं हमेशा कहता हूँ कि यदि हमारे पास समस्या का समाधान नहीं है तो हम खुद ही एक समस्या है। तो इसलिए और कोई भी ऐसा समस्या नहीं जिसका समाधान नहीं भी कर सकता है। मुझे आज बड़ी खुशी है कि एम्स में इस बात की चिंता हो रही है कि 1 स्टेट 1 हेल्थ, भोपाल इंदौर में यदि मेडिकल फैसिलिटीज़ अच्छी मिल रही है लोगों को, तो हमारे दूर दराज झाबुआ में और सिंगरौली में और शहडोल में, इन इलाकों में भी उसी प्रकार की फैसिलिटी मिलनी चाहिए। और इसके लिए आपको भी इस बात के लिए तैयार हैं कि हम टेलीमेडिसिन से और आपके ICU भी चला सकते हैं, क्या बताया, ICU भी चला सकते हैं, और सारे वो एक कोऑर्डिनेटेड एफर्ट के साथ हम आगे बढ़ सकते हैं। ये आपका ऑफर है जो बहुत ही प्रशंसनीय है। मेडिकल क्लासेस में भी आप अपना खुद आगे बढ़ के कह रहे हैं। नहीं तो लोग आजकल सोचते हैं कि जितना काम हम कर रहे हैं उससे ज़्यादा काम करने की हमको ज़रूरत है, और हमेशा वो उनका एक अप्रोच जो होता है बहुत पॉजिटिव भी होता है इस दिशा में। लेकिन मुझे बड़ी खुशी है, सुखद अवसर है मुझे कि आप लोग खुद आगे बढ़ के कदम उठा के और ये सोच रहे हैं कि भोपाल एम्स की प्रतिष्ठा तो अपनी जगह है ही, लेकिन जो लोग एम्स में नहीं आते उनको इस प्रकार की सुविधाएं हम पूरे प्रदेश में एक समान दे सकें। इसके लिए यहाँ पर जो लोग बैठे हैं सब अपने अपने क्षेत्र के बहुत ही एक्सपर्ट्स बैठे हैं, और निश्चित रूप से आपकी जो ब्रेनस्टॉर्मिंग सेशन है वो उससे जो भी रेजोल्यूशन निकलेगा वो पंकज जी हैं, हम लोग शासन स्तर पर उसको जो भी डिसीजन होगा करेंगे। और अपने को मध्य प्रदेश को भी हेल्थ सेक्टर में नंबर 1 बनाना है पूरे देश के अंदर। हेल्थ इंडेक्स में जब हम देखते हैं पूरे देश में तो केरल और तमिलनाडु ऊपर आ जाते हैं। जब हम इरिगेशन में और इंफ्रास्ट्रक्चर में और स्वच्छता में सबको पीछे कर सकते हैं, तो हेल्थ में हम क्यों नहीं सबसे आगे हो सकते हैं? क्या कमियां हैं, किसको कैसे दूर करना है, क्या गैप एनालिसिस क्या है, उन गैप्स को कैसे ठीक करना है, बस इतने तो करना है, और कौन तो बहुत बड़ा काम है। और हम अचीवर्स हैं, हम लोग कर चुके हैं। मध्य प्रदेश मतलब एक परफॉर्मिंग स्टेट बन चुका है, वो अपने लोगों के सहयोग के कारण ही बना है। जिस क्षेत्र में जो लोग काम कर रहे हैं उन्होंने कमिटमेंट के साथ काम किया तो परिणाम निकल के सामने आ गया, और हमारी प्रशंसा होती है। लेकिन हेल्थ के मामले में थोड़ा सा नीचे रखना पड़ता है। जब MMR और IMR की बात आ जाती है तो उसमें आपको पीछे रहना पड़ता है, तो उसको सुधारना ही है। इसके अलावा हमारे पास कोई विकल्प नहीं है। और हम लोग IPHS नॉर्म्स के हिसाब से, इंडियन पब्लिक हेल्थ स्टैंडर्ड्स जो 12 का है, उसके हिसाब से हम लोगों ने देखा है कि भाई HR की कितनी कर दी है। यदि हमने CFC को बहुत अच्छा कर दिया, अच्छी बिल्डिंग बना दी, शानदार PM और GM योजना से लेके और सेंट्रली स्पॉन्सर्ड स्कीम और स्टेटली स्पॉन्सर्ड स्कीम से फंड की कोई कसर नहीं छोड़ी। और मेडिकल कॉलेज हम 14 है हमारे, 5 अगले साल शुरू होने वाले और 6 या 7 के अंदर काम करते हैं। तो ये सारे चीज़ें आ गया। उसके बाद और भी जिलों में जहाँ पर डिमांड है वहाँ पर PPP मोड में हम अब खुद शासन इस पर हम लोग विचार कर रहे हैं कि खुद सरकार मेडिकल कॉलेज बनाए, 3-3.5 करोड़ रुपए खर्च करके, और फिर इतना ये हॉस्पिटल में, इससे अच्छा हम प्राइवेट लोगों को भी इन्वाइट करेंगे कि हम आपको जमीन उपलब्ध कराएंगे, आप आइए हमारे यहाँ मेडिकल कॉलेज खोलिए। तो जहाँ पर जिन इलाकों में मेडिकल कॉलेज की आवश्यकता है और नहीं है, वहाँ पर प्राइवेट सेक्टर के कुल मिला के हर लोकसभा में एक मेडिकल कॉलेज खुल जाए, ऐसा प्रधानमंत्री जी की मंशा है। और उसके बाद आवश्यकता पड़ेगी तो हर जिले में खुलेगा। और 14/5/19 के करीब हमारे 5 साल शुरू होंगे। और मेडिकल कॉलेज खुलने से ये होगा कि जो डॉक्टरों की कमी है, क्योंकि आज हम ये सोच सकते हैं कि यदि हम ब्लॉक में कुछ देना चाहते हैं, कोई परमानेंट नहीं जाने को तैयार है, 1 साल 2 साल के लिए भी तैयार है, तो हर साल इतने पीछे निकलेंगे कि हमको घूमते रहेंगे। तो हम लोगों ने देखा कि लगभग 13,000 ऐसे लोग डॉक्टर से लेके पैरामेडिकल लोगों की भर्ती भी हम जल्दी शुरू करने वाले हैं। तो क्योंकि जब आप कोई रोड मैप बनाएंगे तो उसमें इंफ्रास्ट्रक्चर के साथ डॉक्टर भी चाहिए, HR भी चाहिए। और वो यदि शासन के स्तर से तेजी से भर्ती की प्रक्रिया नहीं होगी तो सब कुछ होने के बाद हम कैसे कर पाएंगे। तो इसलिए हम लोग उस मामले में बहुत ही संवेदनशील है, सक्रिय हैं। अभी आप लोगों ने देखा होगा कि 3,500 पैरामेडिकल स्टाफ की भर्ती हो गई है, उनकी पोस्टिंग हो गई है। तो कुल मिला के हम सभी लोग मिलके और इस क्षेत्र को कैसे ऊंचाई पर ले जा सकते हैं, यही मंशा के साथ आपने ब्रेनस्टॉर्मिंग रखी है। और चूँकि आप विजन है, एक्सपोजर है, और किसी जगह पर बैठ के काम कर रहे हैं जहाँ पर किसी भी गंभीर से गंभीर बीमारी का इलाज नहीं हो सकता है, और इंस्टीट्यूशन के लोग तो कह सकते हैं लेकिन आप लोग नहीं कह सकते, नहीं कहते हैं। अल्टीमेटली लोग फिर कहीं नहीं है तो हमारे पास आता है कि आप एम्स में होती है, तो दिल्ली एम्स में बोल दीजिए, फोन कर दीजिए, या भोपाल एम्स में बोल दीजिए। तो ये प्रतिष्ठा भी इतनी आसानी से थोड़ी बनती है। इसके लिए भी बहुत डेडिकेशन, बहुत समर्पण और बहुत तपस्या इस प्रकार की बर्बादी। मैं सभी को धन्यवाद देता हूँ, शुभकामनाएं देता हूँ। निश्चित रूप से जब हम अगली बार यहाँ पर बैठेंगे, ब्रेनस्टॉर्मिंग सेशन जब अगले साल करेंगे, तो पिछले ब्रेनस्टॉर्मिंग में जो चीज़ें तय हुई उसके कहाँ पे थे हम, और 1 साल में फिर हम कहाँ से कहाँ पहुँच गए, और इसकी भी एनालिसिस करेंगे। तो जिससे कि सबका हौसला भी बढ़ेगा, और जो हिंदुस्तान के अंदर सबसे बेहतर हेल्थ इंडेक्स वाला मध्य प्रदेश को बनाना, उस दिशा में कितनी यात्रा करेंगे और कितनी दिशा में। सभी को बहुत बहुत धन्यवाद।
सर
माननीय मंत्री जी, माननीय उप मुख्यमंत्री जी की आज्ञा से मैं 1 मिनट कुछ कहना चाहूँगा। आपने डॉक्टर्स के रूरल एरिया में जाने वाले विषय पर बात की, उसी परिप्रेक्ष्य में मैं आपको कुछ बताना चाहूँगा। शनिवार को एम्स भोपाल का कन्वोकेशन है। डायरेक्टर साहब और मैंने परसों ये निर्णय लिया है कि इस बार चीफ गेस्ट के तौर पे हम लोग डॉक्टर अशोक लक्ष्मण राव कुकड़े जी को इन्वाइट कर रहे हैं। उन्होंने MS की डिग्री प्राप्त करने के बाद 60 वर्ष पहले लातूर गए, जो कि बहुत पिछड़ा एरिया था। एक कमरे से उन्होंने एक अस्पताल शुरू किया जिसका नाम है विवेकानंद हॉस्पिटल। आज वो अस्पताल न्यूनतम दर पर 50,000 मरीज सालाना देखता है। 4 वर्ष पूर्व उनको पद्म भूषण से अलंकृत किया गया। उनकी उम्र 86 साल है। तो वो हमारे चीफ गेस्ट रहने वाले कन्वोकेशन के लिए मैंने डायरेक्टर साहब ने चीज डिसाइड किया। वो हमें रास्ता दिखाएंगे, हमारा मार्गदर्शन करेंगे, साथ में हमारे नए डॉक्टर्स को भी संबोधित करेंगे। धन्यवाद।
बहुत बहुत धन्यवाद सर। सर, ये हमारे डायरेक्टर सर का विजन है कि हम ये ब्रेनस्टॉर्मिंग कार्यक्रम यहाँ पे कर पा रहे हैं। छोटा सा सर 1 मिनट का फीडबैक मैं भी आपको देना चाहता हूँ। मैं 2012 से यहाँ पे मैक्सिलोफेशियल सर्जन हूँ। हमारे प्लास्टिक सर्जन हेड डॉक्टर मनाल खान सर बैठे। हमने देखा उस टाइम से कि रीवा सतना से बहुत सारे पेशेंट्स यहाँ पे आते थे, लेकिन अभी हम डिस्कस करते हैं कि 5 से 7 साल में वो पेशेंट्स आने कम हो गए। आपने कमियां जरूर बताई कि सिटी यूएस वगैरह नहीं हो रहा है, लेकिन आपने खूबियां नहीं बताई। वहां पे ये सारे काम भी बहुत ज्यादा हो रहे हैं और रीवा से पेशेंट्स आने कम हो गए। इवन पेशेंट्स, जी सर, मैं अभी सर इंटरव्यू लेने गया था वहां पे, तो मैंने देखा मेडिकल कॉलेज की किस तरीके से चला गया। मैं 2012 में भी गया था और अभी गया, तो काफी ड्रास्टिक चेंजेस वहां पे हमें दिखे। प्लस पेशेंट्स ये फीडबैक भी दे रहे थे कि सबसे पहले अगर हम रियम्बर्समेंट के लिए बोलते तो शुक्ला जी हमारा रियम्बर्समेंट बहुत जल्दी करते थे। तो सर, ये मेरा छोटा सा एक फीडबैक है। हमारे बीच डॉक्टर पंकज जैन सर हैं, हम उनका भी स्वागत करते हैं। मैं डायरेक्टर सर, प्रेसिडेंट सर से निवेदन करूंगा कि हमारे चीफ गेस्ट माननीय मंत्री जी को फेलिसिटेट करें। आप सभी लोगों का बहुत बहुत धन्यवाद।
time, and it's very heartening to know that to note that I think all our panelists and all our guests are already here in this room. We are also joined by various faculty members from AIIMS Bhopal. We are also joined by various members of different working groups who will brainstorm the various standard treatment workflows throughout the day. I'll first and foremost request for a quick round of introduction for our esteemed panelists. Some of them are in different sections of the crowd here. So, Dr. Pankaj Jain, sir.
मैं अभी मैनेजिंग डायरेक्टर हूँ मध्य प्रदेश पब्लिक सर्विसेज हेल्थ कॉर्पोरेशन लिमिटेड और इसके साथ ही साथ मेरे पास दो एडिशनल चार्जेस हैं स्वास्थ्य विभाग में मेरे पास तो खैर एक ही विभाग हो गया है दो मैं स्वास्थ्य विभाग में अस्पताल प्रशासन में डायरेक्टर के रूप में के साथ मेडिकल एजुकेशन विभाग में एडिशनल कमिश्नर मेडिकल एजुकेशन तो इसमें शासकीय मध्य प्रदेश शासन के कॉलेज या हॉस्पिटल से जुड़े इनसे मेरा इंट्रोडक्शन
डॉक्टर संजय खरे सर, जॉइंट डायरेक्टर डीएचएस।
नमस्कार, मेरा नाम डॉक्टर संजय खरे है। मैं सीनियर जॉइंट डायरेक्टर हॉस्पिटल एडमिनिस्ट्रेशन में हूँ और डायरेक्टर के गाइडेंस में।
डॉक्टर योगेश कौरव, डायरेक्टर हॉस्पिटल।
नमस्कार, मैं डॉक्टर योगेश कौरव, डिप्टी डायरेक्टर हेल्थ सर्विसेज हॉस्पिटल एडमिनिस्ट्रेशन। फिलहाल हम भी गाइडेंस में काम करते हैं हॉस्पिटल एडमिनिस्ट्रेशन।
डॉक्टर प्रज्ञा तिवारी मैम।
Good morning. I'm Dr. Training, Public Health and Medical University Directorate.
Dr. Santosh Bhaskar, yeah, he's there. Yeah.
Good morning. I'm Dr. Bhaskar from. Good morning. I'm Dr. Santosh Bhaskar from Bhopal Fracture Hospital, basically a critical care physician and president of Bhopal chapter of ISC. And ISC is an Indian Society of Critical Care branch of Mumbai.
Dr. Archana Mishra ma'am is Dr. Namita from Dr. Archana ma'am. Dr. Namita Neelkant. Dr. Prabhakar Tiwari, I think is sir is here. Yeah. We also have in the panel number of very senior doctors from Bhopal. I request for their introductions, please. Dr. P.K. Pandey, sir. Hand mic, pass.
I'm Dr. P.K. Pandey. I'm a physician and area of my interest is intensive care. Dr. Anil Bhargav, I'm a physician, General Hospital.
Dr. Puneet Tandon.
Good morning, I'm Dr. Puneet Tandon. I'm the in charge of the blood center in Gandhi Medical College and Hospital. My field of interest besides blood banking is pathology lab services and histopathology.
Dr. Paneet Sharma.
Dr. Paneet Sharma, Assistant Medical Superintendent.
Dr. Abhijit Deshmukh, Professor, Department of Surgery, Chennai Medical.
Dr. Neeraj Rai.
Dr. Neeraj Rai, I'm a dermatologist, cosmetologist,
So we also have various other experts who are part of various panels, and it's a bigger house. These experts include faculty members from AIIMS Bhopal. They also include various uh, medical officers as well as specialists from CHCs and primary health centers. We also have some nursing faculty and some nursing personnel in these panels. So in interest of time, I'll move ahead as far as discussion is concerned, but I'll request anyone who would join in as far as relevant sections of this talk is there, so that we can move ahead as far as discussion is concerned. I'll request Professor Devatis Vishwas, who will be moderating this discussion along with me, to please move to the next parts.
To Dr. Joshi, and we are definitely privileged to have a broadly representative panel, and we actually thought of catalyzing this discussion that we are going to have over the next 45 minutes or so in 4 broad areas. Can I have the next slide, please? So we are going to be the agenda of our discussion. So just to have the perspective to make us all on the same page, we first like to have a discussion on the common health conditions about which we need to have this treatment workflows. Secondly, we will be having a round of discussion because we have many people from the administrative side who are doing this job of healthcare delivery for quite a long time now. So the existing healthcare delivery system that we will develop so that we understand the mechanism based on which is common treatment workflows will be rolled out. Third, we will talk about the concept of standard treatment workflow and the need of having it, because we all have got from different guidelines, we have got different workflows already in place for different treatment conditions. So what is the need of having a common treatment workflow when already the guidelines are available very much in the public domain? So the concept and the need of having a standard treatment workflow. And lastly, and the most importantly, what are the challenges? We understand that it's a very good idea, very utopian scheme, but what are the challenges to have it rolled up in a state as big as Madhya Pradesh and the healthcare system as complex as that of our state, where we have got different tiers of healthcare sector and we have got the public sector as well as the private sector working together hand in hand. So, firstly, to get the discussion going, we would like to have an idea about the common health condition that are here, and who better than Dr. Prabhakar Tiwari to start the discussion. Sir, we would like to know from you and just a few bullets regarding the common health condition that we see in our daily practice, based on which we would like to have, it is important to have common treatment workflows.
सर we start with, अगर हम लोग देखें मोटे तौर पे तो ट्रेडिशनली हम लोग मानते रहे हैं कि हमारे एरिया में जो कम्युनिकेबल डिजीजेज हैं वो सबसे ज़्यादा प्रोमिनेंट है देन अदर डिजीजेज, बट चीज को अगर हम देखें शायद नॉन कम्युनिकेबल डिजीजेज अब ज़्यादा इम्पोर्टेंट होती जा रही है, क्योंकि पहले हम उसके लिए ना तो सर्विलेंस करते थे और ना हम लोग स्क्रीनिंग किया करते थे। तो पहली चीज तो ये है कि जो चेंज हो रहा है कम्युनिकेबल टू नॉन कम्युनिकेबल डिजीजेज, जो वर्ल्ड वाइड हम लोग अगर देखते हैं मॉर्टेलिटी और मॉर्बिडिटी का डाटा, तो कम्युनिकेबल टू नॉन कम्युनिकेबल डिजीजेज जो है चेंज होता जा रहा है। दूसरी चीजें हमारे यहाँ पर जो एक्सीडेंट्स हैं, जैसे डे बाई डे इंडस्ट्रियलाइजेशन बढ़ रहा है, जैसे जैसे ट्रांसपोर्ट फैसिलिटीज बढ़ रही है, एक्सीडेंट्स का नंबर लगातार बढ़ता चला जा रहा है। तीसरा जो अभी थोड़ी देर पहले एक डिस्कशन चल ही रहा था कि बीइंग एग्रीकल्चर बेस्ड इकोनॉमी, हमारे यहाँ उससे रिलेटेड एपिसोड्स में इट बी एक्सीडेंट्स, जैसे आपने देखा होगा थ्रेशर एक्सीडेंट्स बहुत सारे देखे हम लोगों ने जब थ्रेसिंग का टाइम होता है, इसी तरह से जब इरिगेशन का टाइम होता है इलेक्ट्रोक्यूशन के बहुत सारे केसेस हमें देखने को मिलते हैं, और इसी तरह से बीच बीच में हम लोगों को पॉइजनिंग के केसेस बहुत सारे देखने को मिलते हैं। तो ये जो है ये भी एक इम्पॉर्टेंट एस्पेक्ट उसका रहा है। इसके अलावा पिछले कुछ समय में आपने देखा होगा कि स्पेशली जो अर्बन स्लम्स हैं वहाँ पे एनिमल बाइट के केसेस हमें काफ़ी नंबर में देखने को मिलते हैं। और एनिमल बाइट्स जो है वो कुछ बड़े सिटीज़ में एक प्रोमिनेंट चीज़ देखने को आई है। तो इसलिए मुझे लगता है कि ये अलग अलग एक तो जो ट्रांजिशन हो रहा है कम्युनिकेबल टू नॉन कम्युनिकेबल डिजीजेस, इंक्रीज इन एक्सीडेंट्स ड्यू टू मैकेनाइजेशन एंड इंक्रीज मशीनरी, ये सारी की सारी चीजें आ रही हैं। और जो पुरानी चीजें हैं कम्युनिकेबल डिजीजेस और एनिमल बाइट्स अभी भी वो लगातार बनी हुई है, क्योंकि एक तो जैसे एनिमल बाइट्स होती है, इसके अलावा हम देखते हैं बरसात के मौसम में आज के रूरल एरियाज में स्नेक बाइट्स के केसेस, स्कॉर्पियन बाइट्स के केसेस और दूसरे जो इंसेक्ट बाइट के केसेस हैं वो लगातार यहाँ पर मिलते रहते हैं। अगर हम भोपाल की बात करें तो भोपाल में चूंकि रूरल एरिया रिलेटिवली कम है, तो भोपाल में नॉन कम्युनिकेबल डिजीजेस एक्सीडेंट्स इसकी केस मैक्सिमम देखते हैं। थैंक यू।
One extreme of healthcare is actually critical care. Many critical care themes emanate from emergencies which are commonly seen. I would request Dr. P.K. Pandey sir to please give insight, because you are running an intensive care setting in Bhopal with an urban as well as more key intensive care priorities, that if patient reaches you with those intensive care needs, certain things should have happened before this person is referred to your center.
Patient test report. He is in a bad shape, and most of the things could have been done at the level of periphery, which can prevent the involvement of multiple organ dysfunction. And second is non-communicable disease. Like in communicable disease, I would like to mention tropical diseases, respiratory infections, and I mean in last 2-3 years back, we have seen the incidence of the pandemic, COVID pandemic also. And amongst the non-communicable diseases, ischemic heart disease, heart attack, and stroke. These are two important diseases where the primary treatment, if it occurs at the level of periphery, can salvage many patients or at least can reduce the extent of damage to a given patient.
Sure, sir. I think what I'm doing meanwhile is I'm writing down these priorities, which will be very helpful for our working groups to when they work with these priorities subsequently. Dr. Devi.
We have a broad definition of the diseases that we encounter in our daily practice, spanning across individual as several uninvited academic challenges, as well as the silent pandemic and non-communicable diseases that are related to occupations, behavioral accidents, snake bites, which happen to be there, and which is like a big challenge that is not widely addressed. But I think one thing that went unmentioned is the problem of maternal mortality and infant mortality, and further evaluation of artificial to that point also, where we have complete picture of the condition that we see.
Thank you so much. If you look at the scenario of Bank in India, the national average of MMR and IMR have gone down. But looking at our state, our MMR and IMR is part of national average. Those 7 states have achieved SDG goals, but Madhya Pradesh is still striving hard towards reduction of MMR and IMR. Hence, our government always committed towards reduction of these impact indicators and strengthening of maternal and infant care services. And we have our standard treatment protocols which was formulated. This is based on Ministry of Health and Family Welfare guidelines, and our infrastructure If you look at the division of like infrastructure, we have a district of medical college, district hospital, civil hospitals, CHC, BSc, and sub-center. And looking at the service delivery part, we have categorized our institutions as comprehensive emergency obstetric care services, basic emergency, and level 1 services. Now we have sub-centers which have been identified as health and wellness centers. And the maternal health and marketing the services have been factored in our policies also. The focus is not only on curative services but also on promotive and preventive services, because when we look at causes of maternal death, those are preventable causes in Bangladesh. Unlike other developed states, we are still struggling with the problem of anemia and eclampsia, and both can be detected timely and managed timely, and the lives can be saved. LTE of the state, standard treatment guidelines of the state is developed by a team of experts, but time to time it requires revision also as and when the expert at national level change the protocols. We are looking at it, and as I already told you that the state government is working on a comprehensive approach. Infrastructure wise, we have developed our labor rooms and maternity only at state of art, and the quality certification process is on, and our labor rooms and maternity only, one third of them are nationally certified also. We are struggling with the HR part, so the state government is actually looking in the specialists as transform officers into the system. But still, we have challenges which we will discuss later. And we have a special budget also based on the guidance, and we train our staff also based on the treatment.
Yes, sure. Thank you. So I think very important point which came up in this discussion is that there are various levels of care, and as per levels of care, the care is expected to be more complex. And I think that is something where working groups will have to pay special attention, that whenever we are having standard treatment workflows, these standard treatment workflows are attuned as far as different levels of care are concerned. Now I will ask Dr. Pankaj, sir, to please give your views that how state envisages the kind of emergency care, the kind of priorities to be available at different levels of care. Okay. ठीक है, sure. So I think Dr. Sanjay Khare has vast experience in working with different levels of care. तो जब हम स्टैंडर्ड ट्रीटमेंट वर्कफ्लोज की बात करते हैं या फिर एक स्टैंडर्डाइज ट्रीटमेंट की बात करते हैं, तो किस लेवल ऑफ केयर में हम किस तरह का ऑर्गेनाइजेशन और किस तरह का रेफरल या ट्रांसपोर्ट मैकेनिज्म ब्रॉडली एनएसआर करते हैं, सर?
Basically, we starting with the grassroots level. We have HR में completely कम है, और उनको ये मतलब वो responsibility के बारे में they are not aware, they are not as we require from them. उनको कितना कितना क्या क्या करना है, वो नहीं जानते हैं, करना नहीं चाहिए. पहली चीज role and responsibility awareness उस लेवल तक होना चाहिए. The second thing होती है any situation which comes, so first they diagnose it, then a basic treatment which is required for that particular patient or that they treat them. First thing, और then अगर मैनेज कर सकते हैं तो ठीक है, और ज़रूरत हो तो वो टेलीमेडिसिन से कॉन्टैक्ट रख सकते हैं उस एरिया में. तो एक बेस लाइन ऑफ जो बेसिक इम्पॉर्टेंट गाइडलाइंस है, या आप जिसको STD बोलते हैं स्टैंडर्ड ट्रीटमेंट गाइडलाइन, उसके हिसाब से उनको मिल जाए और वो उसको मैनेज कर पाए. इसके बाद भी अगर मैनेज नहीं होता देन दे विल सेंड टू द हायर सेंटर, दैट मे बी स्टेज लेवल 2. स्टेज लेवल आज के सिनेरियो में ऐसा होता है कि मोस्ट ऑफ द थिंग जो स्टेज 1 में हमें मैनेज कर लेनी चाहिए वो स्टेज 2 पर आती है, और उसमें वर्कलोड बढ़ जाता है. वर्कलोड बढ़ जाता है तो हम वो क्वालिटी नहीं दे पाते जो हमें आवश्यक होती है. बेसिक बेसलाइन रोल रिस्पॉन्सिबिलिटी एक लेवल पर ग्रासरूट लेवल है, किस लेवल पर वो काम करते हैं उन्हें पता हो और उसी हिसाब से वो काम करें और फिर रिकॉग्नाइज करें कि हमें ये करना, तभी हम एक अच्छा हुआ हेल्थ केयर सिस्टम विथ प्री जो मैनेजमेंट जो प्रोमोटिव और प्रिवेंटिव चीज़ें हैं उसके बारे में भी अवेयरनेस एक आम जनता को हो कि आज मेरे को ये चोट लगेगी तो मैं यहाँ जाऊँगा, या मेरे किसी कलीग को चोट लगेगी तो इस लेवल तक उसको हम ले जाएंगे तो प्रॉपरली ट्रीटमेंट हो। ये बेसिक चीज़ मेरे ख्याल से होना चाहिए।
Thank you, sir. You made three very pertinent points regarding the readiness of the public healthcare delivery system. A, we need to have the HR in place. Two, we need to have the HR be aware about their roles and responsibilities. And third, we need to have designated referral mechanisms, well-defined referral mechanisms, so that the person who refers knows where to refer to, and the person who is being referred to knows what level of patients, what complexity of patients they will be prepared to take care of.
एक चीज और भी कि हमारे जो पेशेंट हैं और सराउंडिंग जो जनसंख्या है, जो पब्लिक है, उनको भी पता होना चाहिए कि हमको कहाँ जाना है या बेसलाइन से। एक जनरल अवेयरनेस इज आल्सो रिक्वायर्ड फॉर मेडिकल।
So, carrying this discussion forward regarding healthcare delivery system, I would also like to have the private practitioners' perspective. We have very senior physician from Charak Hospital. If you could give your perspective, regarding you also must be seeing different types of patients, different types of patients. Some need institutional care, and the public healthcare delivery system needs to have referral mechanisms from the private sector as well. So if you could tell us about the challenges in that phase or the kind of streamlining that can be done to make the public healthcare system accommodating of the patient being referred from the private healthcare sector as well.
I think there should be a committee in private sector and the government sector, because shifting the patient, there is a lot of problem. To whom to be coordinated? If you shift the patient from private sector to the government sector, most of the time the beds are not available. The life support system, if the patient is on the ventilator, it is not available in the government sector at that time. So there should be a coordinator or there is a quality committee to whom we can talk regarding shifting the patient. That is the biggest problem, shifting the patient.
Yeah, sure. Sir, I think there are a number of learnings which we learned during the COVID when various sectors tried to come together. There was mechanisms that most of the time, even before an ambulance used to leave a periphery, we used to get information that such and such workload is coming. Sometimes there were delays, sometimes there were mismatches, but lot of communication was happening. That when you have to send somewhere or somebody has to come to a tertiary care, there should be a better communication and a better organization. Otherwise, patients keep on moving from place 1 to place 2 to place 3 without knowing where to actually go when such needs are there. In this regard, I would also request Dr. Yogesh Kaurav, who has been involved with health administration, that how can we bridge this gap? That we always would have a number of demands, especially when referrals have to happen from one level of care to another level of care, from public sector to private sector, and sometimes even vice versa. So, with what of these learnings were we able to, or we are thinking of implementing on a long-term basis to help organize at least our emergency care better? So, Dr. Kaurav.
सर सर जैसे आप लोगों ने अभी कोविड का एग्जाम्पल लिया, during the COVID duration we have seen that the referrals were pretty much robust because even on state level monitoring team was in place which had to see that the referred person is getting the right treatment at the right place. Currently सर जो हमें लगता है हम लोगों ने एक अच्छा रेफरल सिस्टम तो बनाया है. हमारा जो रेफरल सिस्टम है वो बेसिकली जैसे डायल यूनिट होता है उसी के तरीके से काम करता है, लेकिन उसमें जो लिंकेजेस हैं सर वो पेशेंट से जो कॉल सेंटर है वो है, और वहाँ से जहाँ पे आपको आखिरी में रेफर करके पेशेंट को डिलीवरी लेनी है, जो हॉस्पिटल पेशेंट को लेना है, वहाँ तक थोड़ा सा कम्युनिकेशन गैप हमें अभी भी दिखता है कि वो अभी भी हमें उसको स्ट्रेंथन करना है। ये वाला पार्ट जब स्ट्रेंथन हो जाएगा तो हो सकता है कि हम लोग इस बेटर ऑफ हो कि हम यहाँ से जब पेशेंट रेफर करें तो हम वहाँ पे इसको राइट केयर टाइमली दिलवा सकें। इसमें एक इश्यू और आता है सर, हमारे एंड पे हमें ये लगता है कि हमारे यहाँ अनड्यू रेफरेंस भी होते हैं। अनड्यू रेफरेंस मीन्स जैसे कि अभी सर ने कहा था, खरे सर ने, कि ये नहीं पता है कि पेशेंट को कहाँ पर जाना है। तो पहला पार्ट तो उसका ऐसा हो जाता है कि वो जो भी नियरेस्ट हॉस्पिटल होता है, भले ही वो तो कैटर कर रहा हो या ना कर रहा हो, वहाँ पे जाते हैं। फिर वहाँ पे जो स्टाफ होता है वो बोलता है कि आज शायद डॉक्टर अवेलेबल नहीं है या पर्टिकुलर इक्विपमेंट या सेट ऑफ एक्सपर्टीज हमारे पास अवेलेबल नहीं है, आपको किसी और जगह भेजना होगा। ये वाला पार्ट पे काम किया जा सकता है सर, कि अगर मान लीजिए पेशेंट सीधे जाता है या फिर रेफर होके जाता है तो उसको पहले से पता रहे कि इसको एग्जैक्टली कहाँ जाना है। दूसरा का जहाँ पर जाना है वहाँ पे भी अभी हमारे पास कोई ऐसी टीम नहीं रहती है जो पेशेंट जो ऑनबोर्ड हो रहा है, आ रहा है, उसको तुरंत ही पहले से कम्युनिकेशन हो कि एक सीरियस पेशेंट आ रहा है, उसको तुरंत लेना है, उसको ये रिक्वायरमेंट है, इस रिक्वायरमेंट के हिसाब से हमारी टीम को हम अलर्ट करके उसको देख सकें। केवल हमारा अभी जो प्रॉब्लम सॉल्व होता है वो ये होता है कि पेशेंट को हम हायर सेंटर में रेफर करते हैं। वहाँ पर उसके साथ क्या हो रहा है इसका फीडबैक भी नहीं आता। इस पर भी सर काम किया जा सकता है। यही है सर, मुझे लगता है अभी फिलहाल तो जो हमें लगता है कि किया जा सकता है।
We now have a broad idea of the health conditions that we need to cater to, and we also have talked about the healthcare delivery system, the public healthcare delivery system in particular, and how it should be accommodative of the patients who are getting referred even from the private sector as well as from lower down in the healthcare tier in the public healthcare system as well. Now, having said that, having understood the need and the areas that we need to address, now the theme of today's discussion is to have common workflows, common treatment programs, common treatment guidelines to cater to these common conditions across the spectrum of the healthcare system. So we come to the third bullet point in the slide, that why we need that, why we need standard treatment workflows, and what is the concept of standard treatment workflows. So we will touch upon both of these aspects in the third bullet point. What is standard treatment workflow and why we need them? And who better than Pragya Tiwari madam? She is in charge of training across the states. So madam would like to have your opinion and your insights on the concept of standard treatment workflow and why we need them.
Thank you very much. So when we are talking about qualitative health service delivery, it's very important that the service providers at all levels, be it the primary level, the secondary level, or the tertiary level, and be it the government sector or the private sector, are at the same page in terms of treatment. So the common man, when he is approaching a center, should get the best of the treatment, irrespective of the fact that he is at which center, be it the government sector or be it the private sector. So as a training in charge, what I see is a need for multi-tier training involving the first responders. So the grassroots level workers, maybe our AIIMS, our ASHAs, our staff nurses who are at the first level of contact with the community, they are to be trained on the basic protocols. And also the service providers at the primary and the secondary level, where we can train them on how to treat people after they have been given the basic care at the primary and secondary level, what is expected, what is to be delivered with the appropriate equipments and infrastructure that is at hand. So there is no longer that paradigm that the government setting is now a low resource setting. We have ample funds, we have ample collaborations with the hub and spoke models, with the diagnostics and the infrastructures in place. The need is now to have reiterative training of the people at hand, and also a continuous mentoring by the tertiary institutions, so that there is no fallback or there is no gap in communication or there is no gap in the training mechanisms. Thirdly, there is also a need to train the administrative staff. You see, what gets monitored gets done. So if the administrative staff or the public health cadre is unaware of the technicalities or the nuances of the diseases that are presenting at the grassroots level, at the various levels, depending on the epidemiology of the region, it is very difficult for the service providers to continue delivering services at par with the standards that is expected of them. So I would say that the administrative cadre or the public health cadre also needs to be trained on the technicalities. Then there is a very important need to design particular course content. So it cannot be one size fits all. The same training content is not appropriate for the grassroots worker, it is not appropriate for the secondary level doctors or the tertiary level doctors. So there has to be multi-tier subject content, course content that is to be targeted at different target groups and the cohort. The pedagogy has to be decided, which is most impactful for the grassroots level. Maybe it will be a more pictorial or a easy way of communication so that it hits on their brain and it is there for a longer time. For the other levels, it can be a different mechanism. Then most important thing is to understand the effectiveness of the training. We do lots of trainings, but what is the outcome? Once the trained staff is posted, is he or she delivering as per the standards that is expected? So we have a redundancy on that part. We are not able to gauge the qualitative outcomes after a training has been imparted. So we have just imbibed 925 medical officers. We are giving them a comprehensive induction training of one month long. And many times we will find that people will say, what will come if we go to this training, and as a faculty, if we are invited, this is a waste of time because these people, they won't understand everything. But that is not right, I feel, because unless and until we hammer on these things repetitively and to the younger person who has just come into the profession, to hit them when the iron is hot, I think is the crux of the matter. And lastly, I would say that post-training evaluation while on work, at job, on site is most important.
Yes. So I think what has happened, I think, over the last many decades is that there were a number of protocols which are well set into national programs, and then we have repetitive trainings to reinforce those concepts, and these protocols are well in place. The greater problem, I'll say, comes for those disease conditions where we don't have national programs, where different protocols are there. But then these protocols have a variation as far as the person who is there, the place which is there, and we sometimes struggle with these things also. And now more and more training needs are coming for out of national program needs, which have been felt by the system that these trainings should be there. I would request Dr. Abhijit Deshmukh sir, who's Professor of Surgery, to also give us an aspect about standard treatment workflows, especially related to different types of surgical trauma, surgical case conditions and trauma, which is usually left out of national programs. But when it comes to burden which gets referred, it may be something like acute abdomen, or it may be an injury to a part of the body, where what's your perspective? You see a standard workflow working, or you think different people will continue to do their own different things?
नमस्कार। सर्वप्रथम तो मैं सर्जन जो सबसे बड़ी प्रॉब्लम है कैंसर मिस कर रहे हैं, उस पर बात करना चाहूँगा। जैसे पता है कि इंसिडेंस कैंसर का काफ़ी बढ़ रहा है और अगले 25 साल में 77% इंसिडेंस बढ़ने वाला है, और मोर देन 70% डेथ्स जो कैंसर पेशेंट की होती है इट्स ड्यू टू लेट डिटेक्शन एंड ट्रीटमेंट। और हमने देखा है कि हमारे मेडिकल कॉलेजेस, जो गवर्नमेंट के मेडिकल कॉलेजेस हैं, उसमें ऑन्कोलॉजी डिपार्टमेंट है, कीमोथेरेपी, रेडियोथेरेपी होती है, बट देयर इज नो ऑन्कोसर्जन, स्पेशलिस्ट ऑन्कोसर्जन होना बहुत जरूरी है, क्योंकि मेन स्टे ऑफ द ट्रीटमेंट, कैंसर ट्रीटमेंट है इस सर्जरी, और हम वहाँ पर मिस कर रहे हैं। तो मुझे लगता है कि मेडिकल कॉलेजेस में ऑन्कोसर्जरी का एक अलग ओटी होना चाहिए और ऑन्कोसर्जन होना चाहिए, और वो ट्रेन भी करेंगे, जो सर्जन पीजी कर रहे हैं उनको भी ट्रेन करेंगे। साथ में हमें एक टर्शरी कैंसर केयर सेंटर होना बहुत जरूरी है, क्योंकि जो मोडालिटीज हैं आज कैंसर ट्रीटमेंट में बहुत ज़्यादा एडवांस हो गई हैं, और जो हमने डेटा हमने स्टडी किया कि हमारे मध्य प्रदेश से बाहर ट्रीटमेंट के लिए काफ़ी लोग जाते हैं, गरीब लोग भी होते हैं और श्रीमंत लोग भी होते हैं, और खासतौर से जो गरीबी के जो गरीब लोग होते हैं वो उनको वहाँ पर जाकर ट्रीटमेंट लेना काफ़ी महंगा होता है, रहना भी एक प्रॉब्लम होती है। क्यों ना हमारे राज्य में भी हमारा गवर्नमेंट का एक ऐसा सेंटर हो जिसमें एडवांस सर्जरी हो, अदर दैन रेडियोथेरेपी, कीमोथेरेपी, स्टेम सेल थेरेपी, रोबोटिक्स बहुत एडवांस हो गया है। तो हमारे पास जैसे भोपाल में हम कर सकते हैं, जैसे जहाँ पर सुल्तानिया हॉस्पिटल, जहाँ पे हम डिस्ट्रिक्ट हॉस्पिटल खोलने वाले हैं, तो मुझे लगता है डिस्ट्रिक्ट हॉस्पिटल है हमारे पास में, तो क्यों ना वहाँ पर एक एडवांस टर्शरी कैंसर सेंटर खोला जाए। तो मेरा ये एक था, और प्रिवेंटिव एक्सपेक्ट भी बहुत जरूरी है, अवेयरनेस। तो प्रिवेंशन और अवेयरनेस के लिए मुझे लगता है कि जो ग्रामीण इलाके में जो लोग अवेयर कर सकते हैं, तो हम आरोग्य मित्र उनको हम एक सर्वे कैसे करना, स्क्रीनिंग कैसे करना हम कर सकते हैं, हम इस पे काम कर रहे हैं, क्योंकि कुछ पैरामेडिक्स भी हैं और कुछ नॉन मेडिकल्स हैं जिनको हम बेसिक सिखा रहे हैं, कि गाँव के परिवेश में वहाँ पर लोगों के बीच में रहते हैं, कैसे स्क्रीन करना, कैसे अवेयर करते हैं, आरोग्य मित्र भी बनाकर लोगों के बीच में जाकर कैंसर का जो बढ़ता इंसिडेंस है उसको हम कम कर सकते
हैं। For bringing in the perspective of cancer, we actually was getting missed out from our discussion. A very important aspect which also needs to be highlighted and brought into the mainstream of discussion, because that's the backbone of all the treatment services that we roll out. That's the blood bank services as well as the investigations. So to bring that perspective, how can we integrate the blood bank in our healthcare infrastructure? How can we incorporate the training related to blood bank in those conditions where that needs to be a part of the standard treatment workflow? I will first invite Dr. Puneet Tandon, who is the blood bank officer from Hamilton Hospital, and then I will like to have the perspective of the radiology, because that also is a very important part in today's treatment protocols. Radiology across the spectrum from X-ray to MRI. So for that, I will invite Dr. Samir Kusanthar, who will be bringing in. After Dr. Puneet Tandon, once he talks about the blood bank perspective, we will also talk about integrating the radiology services into the healthcare infrastructure and make it a part of the standard treatment process.
नमस्कार। अगर हम इंफ्रास्ट्रक्चर की बात करें तो प्रदेश में जितने भी डिस्ट्रिक्ट्स हैं, तो ऑफ द टोटल 55 डिस्ट्रिक्ट्स अबाउट वी हैव गॉट ब्लड सेंटर्स, गवर्नमेंट ब्लड सेंटर्स इन 49 ऑफ दोस डिस्ट्रिक्ट्स। अगर हम बात करें कि टोटल गवर्नमेंट ब्लड बैंक्स कितने हैं पूरे प्रदेश में, तो दे आर 64 ब्लड सेंटर्स गवर्नमेंट। देन अगर हम बात करें कि टोटल प्राइवेट ब्लड सेंटर्स कितने हैं, तो दे आर अबाउट 163। इसमें से गवर्नमेंट के, जैसे मैंने बताया, करीब 64 ब्लड सेंटर्स हैं, एनजीओज के करीब 59 हैं, एनजीओज एंड चैरिटेबल ट्रस्ट के, और टोटली प्राइवेट ब्लड सेंटर्स करीब 40 हैं। अगर हम टोटल ब्लड कलेक्शन की बात करें प्रदेश में, तो गवर्नमेंट और प्राइवेट का मिलाकर के इट इज करीब 3,02,000 के करीब टोटल ब्लड कलेक्शन है। इसमें से गवर्नमेंट सेटअप में करीब 1,88,000 ब्लड कलेक्शन होता है। अगर हम वॉलंटरी ब्लड डोनेशन की बात करें, तो वॉलंटरी ब्लड डोनेशन इज समथिंग जो कि हम एक्सचेंज में किसी को पूछ नहीं रहे हैं। वी आर नॉट फोर्सिंग द अटेंडेंट्स टू गिव ब्लड इन एक्सचेंज। तो वॉलंटरी ब्लड डोनेशन, टोटल वॉलंटरी ब्लड डोनेशन 1.82 लाख है, और उसमें से करीब 1,30,000 के करीब शेयर गवर्नमेंट ब्लड सेंटर्स का जाता है वॉलंटरी ब्लड डोनेशन। अगर हम प्रदेश की बात करें कि इस समय जो सबसे बेस्ट प्रैक्टिसेस क्या हैं प्रदेश के ब्लड सेंटर्स में, तो सबसे पहले तो यह है कि जो सबसे इम्पोर्टेंट चीज है वो है नेट टेस्टिंग। जैसा कि आप सबको पता है कि जो भी ब्लड सेंटर्स में जो ब्लड होता है, दैट इज टेस्टेड फॉर ट्रांसमिटेड डिजीजेस। HIV, हेपेटाइटिस बी और हेपेटाइटिस सी इसमें सबसे इम्पोर्टेंट है। HIV का जो भी इंक्यूबेशन पीरियड अगर अपन माने या सामान्य टेस्ट से जो टेस्टिंग होती है दैट टेक्स अबाउट 1 to 3 months to come out. With NAT testing, 98% of the blood can in HIV patients, the incubation period can be brought down to just 10 days. अगर हेपेटाइटिस बी की बात करें तो it is approximately incubation period is varies from 3 to 6 months. With NAT testing, it can be we can get it down to only 15 days. और हेपेटाइटिस सी जो है उसमें भी 1 से 5 महीने का टाइम नॉर्मली लगता है, जो कि वी कैन गेट इट डाउन ओनली टू अबाउट 3 days बाय NAT टेस्टिंग। तो ये NAT टेस्टिंग फैसिलिटी जो है ये 22 डिस्ट्रिक्ट्स में हमारे यहाँ चल रही है। वो हब एंड स्पोक मॉडल चल रहा है प्रदेश में, और उसमें लीड लिया हुआ है हमारे ब्लड सेंटर गांधी मेडिकल कॉलेज ने, जहाँ पे NAT टेस्टिंग फैसिलिटी अवेलेबल है, और एक MGM मेडिकल कॉलेज इंदौर में। तो अगर भोपाल GMC की बात करें तो हम पे गवर्नमेंट ब्लड सेंटर से जो एडजॉइनिंग डिस्ट्रिक्ट्स हैं, जैसे होशंगाबाद है, विदिशा है, सीहोर है, इवन हरदा, बैतूल और बहुत सारे डिस्ट्रिक्ट्स हैं, हम इनको केटर करते हैं। इंदौर में MGM मेडिकल कॉलेज है, वो करीब 11 डिस्ट्रिक्ट्स वो करते हैं, खंडवा, खरगोन, देवास, उज्जैन। सो आइडिया ये है कि जो भी ब्लड आज की तारीख में सबसे जैसे कहते हैं कि डिजीज फ्री ब्लड की अगर हम बात करें, और अगर विंडो पीरियड में हम किसी को पकड़ नहीं पा रहे हैं, तो गवर्नमेंट ब्लड सेंटर्स का जो ब्लड बैंक का जो ब्लड है दैट इज एनी डे वेरी सुपीरियर टू व्हाट इज बीइंग सप्लाइड इन द प्राइवेट ब्लड सेंटर, क्योंकि डिजीज फ्री सबसे ज्यादा चांसेस यही है कि नेट टेस्टेड ब्लड आपको यहाँ पे मिलेगा। तो अगर हम वन स्टेट वन हेल्थ की बात करें तो इस बात पे सोचना चाहिए कि प्राइवेट के अंदर को भी किसी तरीके से सिस्टम में इंटीग्रेट करा जाए, जिससे कि प्राइवेट ब्लड सेंटर्स का भी जो ब्लड है वो सेम ही क्वालिटी का हो जैसे कि गवर्नमेंट सेंटर्स का। एक सबसे इंपॉर्टेंट चीज है, क्योंकि सिटीजन तो सब एक ही है। सेकेंड थिंग इज कि ऑटोमेशन बहुत अच्छा स्टार्ट हुआ है गवर्नमेंट ब्लड सेंटर्स में देश भर में, और एक वेट ट्रायल लीजिंग के थ्रू इट हैज बीन आउटसोर्स एज अ प्रोजेक्ट इन 18 डिस्ट्रिक्ट्स। तो इसमें पूरा ऑटोमेशन हो गया है, सारे ब्लड सेंटर्स का कंपोनेंट प्रिपरेशन की ऑटोमेटेड मशीन्स लगी हुई हैं, ब्लड ग्रुपिंग क्रॉस मैचिंग की ऑटोमेटेड मशीन्स लगी हुई हैं, इवन केमिकल्यूमिनेसेंस ऐसे की जो स्क्रीनिंग की जो मशीन्स हैं वो भी टोटली फुल्ली ऑटोमेटेड लगी हुई हैं। सारे प्रदेश के ब्लड सेंटर्स में करीब 56 ब्लड कलेक्शन ट्रांसपोर्टेशन वैन्स आर अवेलेबल। तो अगर हम ब्लड ट्रांसफ्यूजन सर्विसेज की बात करें, हर एक डिस्ट्रिक्ट में डेडिकेटेड ब्लड बैंक ऑफिसर्स भी हैं, और सबसे इंपॉर्टेंट चीज ये है कि इस पूरी वर्किंग की मॉनिटरिंग जो है ई रक्त कोष पोर्टल से करी जा सकती है। तो ट्रांसफ्यूजन ब्लड सर्विस का जहाँ तक सवाल है, दे आर रियली लुकिंग अप। और जैसे कि इसमें ऑटोमेशन में आउटसोर्सिंग करी हुई है, जैसे नेट टेस्टिंग में भी आउटसोर्सिंग करी हुई है, तो उससे सिस्टम जो है बहुत अच्छा इम्प्रूवमेंट हुआ है। और अगर अपन आगे चल के क्या इम्प्रूवमेंट चाहते हैं तो इसमें सोचा जा सकता है कि अगर ब्लड इंडिविजुअल ब्लड बैंक है, अभी जैसे भोपाल में गांधी मेडिकल कॉलेज का ब्लड बैंक है, एम्स का ब्लड बैंक है, जेपी का ब्लड बैंक है, सो मेनी टाइम्स वी आर एक्चुअली कंपीटिंग अमंगस्ट आवरसेल्व्स फॉर ऑर्गेनाइजिंग ब्लड डोनेशन कैंप्स। तो बेस्ट सिस्टम वुड बी कि आगे चल के फ्यूचर में कोई सेंट्रलाइज्ड ब्लड कलेक्शन एजेंसी होनी चाहिए, जिससे कि ब्लड कलेक्शन का कायदे से ब्लड सेंटर्स का काम ब्लड कलेक्शन का नहीं होना चाहिए। देयर शुड बी अ सेपरेट टीम ऑल टुगेदर व्हिच शुड बी रिस्पांसिबल फॉर द कलेक्शन ऑफ ब्लड। एंड जैसा कि मैंने बोला था कि नेट टेस्टिंग जो है वो पूरे सारे ब्लड सेंटर्स।
Thank you, sir. So we get three takeaways from what Dr. Puneet Standard said, that there is a robust infrastructure already in place. There is a need to systematize it so that we get the best and equally distributed benefit of this existing infrastructure, which includes NAT testing as well as the automated instruments that we have. And the second point that is said, that we already have a portal where we can have if we get the updated information about the availability of blood in the different blood centers across the state. And the third important point is that there should not be competition within the blood banks to organize camps. There should be a blood collection agency which does it in a uniform manner, well spread out manner across the state, so that we get better numbers and better quality of blood which will be required for the patients. In the same line now, I would like to have the inputs from Dr. Samir to Sarkar sir. Sir, radiology, as you understand, is important. It is required for so many treatment decisions, and it is expensive as well. And we have got diverse facilities both in the government sector as well as in the private sector for the radiology. How best can we integrate the available resources? How best can we make it systematic so that the patient who requires them gets the best of facilities at the least of expense?
Thank you. I am a radiologist practicing cross-sectional imaging, and it is a very important and a very touchy subject. So I will give three pertinent examples. First is stroke, second is cancer, and third is polytrauma. So for all these, there has to be an integrated and very dedicated effort in how the government and private sector communicate with each other, as rightly pointed out by Dr. Stroke. Imagine the plight of a family. Unfortunately, in last 20 years, young age strokes, the incidence of young age strokes has seen a phenomenal rise. And for that, a 35-year-old man, imagine the plight of a family, 35-year-old man, breadwinner of the family, and he suffers a stroke, not taken care of properly, then this patient is bedridden. Ultimately, he will develop all sorts of complications, and he is of no use to the family and no use to the society. So, prevention, early diagnosis of stroke. So there has to be a significant effort for which community training is very important to diagnose, and a patient should come to proper stroke centers. The window period is very important, first 4 to 6 hours. So early detection of stroke on a community educative training, that is very important. It will require efforts of everyone from ground level workers to the subspecialty centers. So that needs to be done in our part of the state, because here the community training facilities we are lacking. This is one thing. Second is cancer. The incidence of cancer is also on a phenomenal rise. And many times in my practice also we see early treatable cancers. So we can design some screening programs for cancer, say for lung cancer. We don't require a contrast enhanced CT. We can have some sort of a screening program at an affordable price to the patient, whereas we can integrate the entire group into that, and that can really serve the patients very well. So there has to be again a very coordinated approach between the private and the government sector to improve or to deliver the healthcare system. And third is polytrauma. In polytrauma, I have seen many patients, head injuries or abdominal injuries, thoracic injuries. They come from various hospitals. And initially, when their investigations are done, when their treatment is done for initial few days, so somehow what happens is it's very unfortunate. Patients, they run out of money, and then they go here and there, and they are somewhere lost in the crowd. So some sort of affordable delivery system at the private sector, that also needs to be done, and there should be proper guidelines which have to be formulated, so that a standard we can operate on the checklist and we can improve the healthcare delivery system to the patient. These were 3 points which I wanted to highlight.
Thank you, sir. So, as we understand, for these 3 exemplary conditions that you cited, stroke, cancer, and polytrauma, the way forward should be to have a coordinated approach so that the resources are meaningfully utilized and the needy persons are prioritized. And second, the standard treatment guidelines, standard indications, and standard workflows need to be practiced across the sector, so that wherever cancer, we get the uniform and evidence-based care. In talking in terms of evidence-based care, we need to take the ICU also in perspective. For ICU, the ICU is where time is of the maximum essence. Patient is critical. The resources need to be optimally utilized so that we have the best outcome-based outcome for the patient to critical care, the ICU. So we have Dr. Santosh, charge of the Bhopal Center for the critical care physicians community, and we would like to have his perspective, Dr. Santosh, on how we can best ICU resources into the standard treatment process so that the patient gets into the ICU only at a determined level of criticality, and then we get the best of treatment that possible in the ICU as the best of treatment.
Thank you, sir. So since we are talking about standard workflows, we need to have it and all. But what I find particularly important is the missing link between the periphery and the ICUs. Or wherever the ICU care is starting from the periphery, if you have a stroke patient in 2 hours distance from you, so if the workflow starts this way, that he has to go to some centers where CT scan at least must be done primarily, then CT interpretation done within framework of time. Like, AHA has recommendation that it should be done within 45 minutes of the patient arrival too. So many a times what we feel is CT scan reporting is not done timely, properly done. Before that, when the patient begins from community, he takes help of 108. At 108, though we say that they are trained, they are retrained, their level of training is adequately, but what we often find is when they start from periphery and they reach to private setup like us, we are often feeling like there is some big gap between. We go to some district hospital and district hospital setting it to, for example, my private setup, Bhopal Fracture Hospital, saying that he needs urgent ICU care. And with that referral letter, we find it at our end, patient is the very low GCS and he has never been intubated when it was actually required. So it is like setting, like when you see a patient and tackle there at your own, then it is the patient himself putting pressures on the doctors and keeping up. But when you are referring, then that pressure is going off. Like we are talking about referral system. When you start from periphery and reach the pointed target, the missing link is that particular person who are in ambulance and the first primary hospital where they have gone. So how to, like in standard workflow, how to improve upon those when the golden hour is actually we are missing on those golden hours at particular point, and then when we have these patients, we are like out of thrombolysis zone, out of many a primary golden hours, and then we are like putting burden to society as a these persons will be now morbid and will not help society and will be a like a loss to all. So strengthening the referral and ambulance system and binding some liability to the referring doctor as well, because referring doctor feels it to refer to higher center, that's all done, but that some responsibility lies with that as well. Like if you don't bind some responsibilities at that end, probably we are again having a burden over all the healthcare system. India will be suffering. So that is my own one point is need to improve upon those. And while I try to find out what's the reason, primary reason behind it, primary reason is not that they are not trained. They are particularly trained, but there is no monitoring system. As we have talked in the morning that we need to monitor, check, as Pragya ma'am is telling. So, and why they are, if you are giving a contract to 108, what I find is those contract people, they turn up to you and asking for arrange one AHA program for BLS and ACLS. They are asking to us that arrange one program for basic life support or advanced cardiac life support, and we need it urgent. We need it done within a 7 days framework because we have lots of burden on us. Now, arranging a program, and it is a costly affair. The answer is probably lying in any LS, as Eunice sir must have, like, we don't have our own Indian program for such life support training. We rely heavily on American Heart Association and other association program, and we just copied what I want is like it should be nationalized program of emergency life support as has been propagated by NMC. NAIMS is that program, NELS, right? National Emergency Life Support. So these programs should replace those American or other origin programs, and this will be not that costly. So this is my second point. Like we need to have further training, and training should not be costlier. So these two points, training and the responsibility with the referral, referral authority or whatever setup. Because what we tackle in ICUs is particularly at the dead end. We are like at times say we can't do anything because the primary time, the golden hour has been lost. Thank you. From getting the photos and the department points out that we need to have clear indications for referral. Point two, once referred, we need to make the best use of the time. It's very critical to go. Number must be used. And number three, treatment side by side monitoring of the treatment. These are the three important lanes that we need for getting and improve the ICU in our family. So now we come to the last leg of our discussion. We have understood what the conditions are. We have understood the delivery model that needs to take care of this condition. We have understood that this is the way to go the standard treatment workflow that will make that will of the best use for the patient. Because regardless of where the patient lands, it is guaranteed to have a level of care which evidence-based and which is quality assured. But it's easier said than done. Challenges and their opportunities. We understand the opportunities, but the challenges probably are also staggering. So now, sir, Dr. Pankaj Chair, sir, I think you have heard a lot about what people felt and what people think, and would like to begin this part of the discussion with.
काफी सुन रहा था मैं मेडिकल फील्ड ही नहीं मेरे डिस्कशंस में शामिल होने का मौका नहीं था पर जो एजेंडा है इसको देख के जो मुझे और आप लोग के और जितना मेरा पब्लिक एडमिनिस्ट्रेशन का कई चीजों में देख के जो अभी तक समझ आया कि इमरजेंसी हेल्थ केयर और जैसा कि मैं जब बात करता हूँ पब्लिक हॉस्पिटल जितने भी हैं जितने हॉस्पिटल उसका जो फेज होता है पब्लिक फेज होता है तो इमरजेंसी कैसे वो टैकल होती है थोड़ी बहुत एजुकेशन लॉस रही है कुछ बहुत एजुकेशन तो जब ओपीडी में पेशेंट आता था इसमें तो इतने तरह के घंटे खा के आता है टाइम हो के आता है कि उसे पता रहता है कि भाई आगे थोड़ा समय लगेगा मतलब ओपीडी पेशेंट्स की ठीक ठाक प्राइमिंग हो जाती थी सेंटर पहुंचते बट इमरजेंसी एक डिफरेंट इमरजेंसी में निकला सुबह और पता चला कि वो एक्सीडेंट पहुंच गया अस्पताल में या क्रिटिकल हो गया इमरजेंसी को कैसे डील करना है इमरजेंसी तरह तरह की हो सकती है मेरी कार्डियोवास्कुलर इमरजेंसी इमरजेंसी मामा की इमरजेंसी रहती है या ऑफ टाइमिंग में ऑब्स्टेट्रिक इमरजेंसी डिलीवरी तरह की इमरजेंसी जो मैंने जनरली देखी सबसे पहला इशू तो यह है और जो आई थिंक इस पूरे डिस्कशन में कहीं नहीं आया है बट गवर्नमेंट ऑफ इंडिया ज्यादा लगी आभा आईडी को लेकर जब रेफरल होता है तो नीचे रिकॉर्ड टाइमली पहुंच को लेके गवर्नमेंट ऑफ इंडिया काफी लगी हुई है आभा आईडी या कुछ स्कैन एंड शेयर जैसे एम्स में स्कैन एंड शेयर ओपीडी पे चालू है बट यदि प्राइवेट टू गवर्नमेंट रेफरल होता है कहीं क्रॉस हॉस्पिटल रेफरल होता है तो जो सारी इन्वेस्टिगेशन हो सकती है वर्किंग ऑन दैट थिंग अभी गवर्नमेंट तो अपनी तरफ से काफी इसको पुश कर रही है और गवर्नमेंट इंडिया पुश कर रही है, एम्स ने काफी लिया है, स्टेट गवर्नमेंट ने भी किया है कि इसको अपने काफी उसमें लाएंगे। प्राइवेट सेक्टर्स के यहाँ बहुत सारे लोग बैठे हैं, भी आग्रह है कि इसको करें, बिकॉज सीमलेस ट्रांजिशन ऑफ इन्वेस्टिगेशंस ये इससे बेहतर हो पाएगा। अदरवाइज आपने एक जगह इन्वेस्टिगेट कराया फिर दोबारा वही इन्वेस्टिगेट करा रहे हैं, पॉइंट नहीं। और जब आपका रेफर हो रहा है एक जगह से दूसरी जगह भी आप ये उसके इन्वेस्टिगेशन बाय द टाइम व्यक्ति एक जगह से दूसरी जगह पहुंचता है या शेयर कर पाएंगे तो वो बेहतर रहेगा। कि अभी भी जो मैंने देखा है कि मेरे पास बहुत सारे कॉल आते हैं, विदिशा में मैं कलेक्टर रहा कुछ टाइम, वो मरीज हमारा एडमिट हो रहा है मीडिया में तो आप बोल दीजिएगा। तो मुझे ये समझ नहीं आता कि जिला अस्पताल से जो रेफरल सिस्टम है वो इस तरह को टेकअप नहीं करता कि ये पेशेंट यदि यहाँ से वहाँ के लिए रेफर हो गया है उसके लिए वहाँ से पहले अरेंजमेंट हो जाए। जनरली हमको अभी भी फोन लगते हैं, कुछ वीआईपी कॉल्स लगते हैं या पहचान के कॉल्स लगते हैं कि आप किसी की पहचान है तो वहाँ बोल दीजिएगा तो पहले से रहेगा। ये हमारा जो मैकेनिज्म है दैट शुड बी इम्प्रूव्ड। स्टैंडर्ड ट्रीटमेंट गाइडलाइन जो आपने बात की, इमरजेंसी डील करना स्किल्स के साथ साथ थोड़ा सा कॉन्फिडेंस की भी बात है। मैंने जनरली अभी देखा कि केसेस नीचे संभालना नहीं चाहते हैं इसलिए कई बार रेफरल हो जाते हैं। ये तो बहुत अच्छा एग्जाम्पल अपने घर का ध्यान है। बेटियां हुई थी तो मेरी वाइफ कलेक्टर था, जब ये हुआ तो सबने पहले बता दी सिजेरियन हुआ कि नॉर्मल लोगों का बड़ा क्वेश्चन रहता है ना, तो समझदार लोगों ने बताया कि आप यहाँ कलेक्टर हो तो सिजेरियन ही होगा। और वही हुआ कि कोई डॉक्टर रिस्क नहीं लेना चाहिए। स्टैंडर्ड ट्रीटमेंट गाइडलाइन तो सब एक तरफ है, अल्टीमेटली लास्ट में बताएंगे कि साहब ये हो जाएगा वो हो जाएगा, 4 कॉम्प्लिकेशन पर आप यहाँ से इंदौर में रेफर करेंगे। और वही हुआ पेशेंट को एज पेशेंट देखा ही नहीं, डॉक्टर को रिस्क बस करनी है, वो लास्ट में 2-4 चीजें बताएंगे। और ये अभी भी हमारे यहाँ इमरजेंसी केसेस चाहे विदिशा में हो चाहे कटनी में हो, अभी भी कटनी में सेकेंड या थर्ड सिजेरियन होना था पेशेंट का और वहां से रेफर कर दिया करते थे कि हमें रिस्क नहीं लेनी है। जिला अस्पताल हॉस्पिटल रिस्क नहीं लेगा। एक दिन मैं उस समय के लिए कलेक्टर था, मैं डॉक्टर को बताया ऐसा नहीं कर दिया, बोले आप कहोगे तो कर दें। यदि ऐसे मेरे स्टैंडर्ड ट्रीटमेंट गाइडलाइन होंगे तो कलेक्टर कहेंगे तो आप कर देंगे, आप रोज भेज रहे हैं। तो ये कॉन्फिडेंस बिल्ड करना, सपोर्ट की कोई कमी नहीं है, बट ये कॉन्फिडेंस बिल्ड करना स्टैंडर्ड ट्रीटमेंट वेरी इंपॉर्टेंट। पता बात करते हैं बट फाइनली इस चीज से बहुत स्टैंडर्ड ट्रीटमेंट गाइडलाइंस को फॉलो नहीं कर पाते हैं। पॉइजनिंग पता चली पैराकीट पॉइजनिंग तब मैंने तो नहीं पढ़ी थी, अब हो सकता है बट हमारे अपेक्स ये है कि नई जो भी इमरजेंसी डील करते हैं जरूर इन चीज़ों को हमारे पेरिफेरिक इंस्टीट्यूशंस के लिए जरूर आप लोग के माध्यम से या पत्रों के माध्यम से या किसी भी माध्यम से आप इसको जरूर पर्कुलेट डाउन करें ताकि इमरजेंसी जो नई आ रही है, मतलब मैं पुराना हो गया हूँ, पढ़ा मैंने बहुत पहले था इसलिए शायद मेरे लिए नया होगा, हो सकता आप लोगों में कई लोग इसके वैल्यूबल। तो इस तरह की जितनी पब्लिक इमरजेंसीज हैं या नई नई चीज़ें हैं और स्टेट एडमिनिस्ट्रेशन की तरफ से मैं जरूर इस चीज़ को बताना चाहूँगा। और आपके कॉन्फिडेंस के लिए इमरजेंसी की मेडिसिन के लिए या अन्य कोई भी पॉजिटिव सुझाव आता है उसके लिए रिसेप्टिव है, बहुत सुनने के लिए भी रिसेप्टिव है। मेरी मेन शिकायत रहती है आप लोग फीडबैक्स बताते ही बहुत डॉक्टर्स को अपने फीडबैक्स ही नहीं बताते, ऊपर पॉलिसी लोग बैठे हैं तो आपके फीडबैक क्लिक करने की जगह उसको बताएं प्रॉपर और सेक्टर और मंत्री जी आपने देखा आए थे जो भी फीडबैक है पॉजिटिव फीडबैक है नेगेटिव और उसको आगे के लिए आगे काम करने के लिए स्टेट गवर्नमेंट की तरफ से आप
the kind of a experienced public figure, he knows the pulse of the system and the pulse of the practitioner. He tells you about the confidence building within the healthcare workers. His VIP culture that is very much there, but we refrain from talking about it public. He brought it the discussion. He brought it about the unprepared patient who happens to have an accident, course of his daily schedule, going to work and coming across with an accident, and how when that patient comes to the healthcare system, what his mindset is. And along with that, he also brings into the discussion something as important as Alpha ID, because that is going to be the basis on which seamlessly health records of the patients get transferred from the referring center to the referral center. And there is an important need for the upper system to encompass the public. So we have also Dr. Samika Madam, she has joined in, the Deputy Director for the NCT, and NCT is one area where we require long-term healthcare, long-term care, long-term healthcare dependence, and there also we need a standardized treatment workflow, because otherwise the treatment that the patient gives is as varied as the number of. Madam would like to your perspective on the importance of having standard treatment, and what are the challenges to enforce such a standard treatment workflow as diverse as we have here.
It's a pleasure to be. Moreover, I have so many professors, those who have taught me different. What sir is asking, what standard workflow, what are the challenges in the work? See, as a state program officer at the state level, there are, I don't feel there are any challenges, as per the implementation of program at the field level, though there are certain gaps, there are certain constraints. We have to, teach orient our staff how to get the things implemented. That is and another thing. And the most important part, the government of India has launched the standard treatment workflow for NCT from the Madhya Pradesh itself at the national level during 8th, 9th, 10th of July. Need to about
Actually, the importance of having diseases like cardiac condition, hyperlipidemia, they are actually a scientific pattern. They require the treatment needs to be uniform and the treatment visible, and the treatment needs to be available, accessible across the spectrum of healthcare. What are your thoughts on the state governments?
See, as for the prevalence rates, which has been present at the national level, if you look at the data, we have Health Profile of India 2020, in which they are mentioning that 80% of the deaths are due to the cardiovascular complications. And what they are including is these stroke, cardiovascular diseases, CAD, major portion. And 24% of the death is due to this STEMI and other things. This is what is the data which India has reflected on the portal. Now, if you look that scenario at state level, what challenges which we are talking about, that a patient is coming for the stroke or CAD or CVD or STEMI, whether these cases are being catered at the peripheral level with the availability of medicine or the logistics. State is making a lot of effort and has been successful get it done at the field level. Like stroke, you need the drug which has government of India has initiated for technical claims that is already available with us, and the CT scans are available at every district hospitals. See, we have made one of the MU with STEMI, which would be implemented by May or something. It would be available with our hospitals. Then one of the projects COPD, recently by our honorable starting the COPD project, identifying the cases of post-COVID, post-COVID, post-asthma, post-TB from the district, and will take those cases on treatment. What things we are implementing, and of course, challenges are always there because training. See, basically, NCT is focusing on the two indicators. One is hypertension, and another is diabetes, and rest of the things are complications. Whatever it is, diabetic retinopathy or whatsoever it is, even we are focusing on juvenile diabetes also. So prevalence of hypertension is in Madhya Pradesh is 23.5%, and diabetes is 13.5% as per the national prevalence NFHS 5. I think at national level, Madhya Pradesh is one of the first states who have circulated the target-wise data for the districts. If what would be the probable or tentative number of cases you have to register, and that is why I don't think we are doing a very good job or something like that. But because of this effort, because of this calculation, we are at RAT 2 in terms of diagnosis national.
Before we close, I think there is one untouched issue which we need to, and that is why we had a specific working group for legal assessment, because we are worried about a lot of health indices in terms of morbidity as well as mortality reduction. But there are a number of gray areas around this, around standardization of our medical legal aspects as well as standardization of how autopsies are performed. That working group. I also believe Dr. Garg from is also there. So I think you have heard all that discussion, but I think this is one specific area I would like your point of view.
I had the opportunity of working in public health system also, previously as a medical officer, beginning of my. So I take very important points from first, as Dr. Bhatt mentioned, we need to fix the responsibility of the referring doctors. Regards to the referral that we are accused of doing undue and unnecessary referrals. Part of that culture is because of the medical legal intricacies which are involved. So, like I thought, when the doctors refer, they usually think इसमें क्या होगा, मेडिकल लीगल इश्यूज क्या इन्वॉल्व होंगे, प्राइमरी एमएलसी मेरे को ही बनानी पड़ेगी, तो आई नीड सम टाइम, मुझे पूरा डॉक्यूमेंटेशन चाहिए. उस टाइम में गोल्डन आवर का शायद उनको ध्यान ये नहीं रहता कि मुझे तो कोर्ट का डर ज्यादा दिखता है, गोल्डन आवर पेशेंट की लाइफ का डर मुझे थोड़ा सा कम दिखता है. ये मेरा पर्सनल एक्सपीरियंस उस समय का था. अभी मैं जब मेडिकल कॉलेज में काम कर रहा हूँ तो आई फाइंड इट मोर एंड मोर रेलेवेंट और ज्यादा ऐसा लगता है. तो चीज को हमें एड्रेस करना पड़ेगा. वी हैव स्टिल हैव द मेडिकल लीगल मैनुअल ऑफ 19 टाइम प्री इंडिपेंडेंस, मतलब प्री इंडिपेंडेंस का ही है वो, मतलब जब काफी पहले का है, तो उसको हमें भी अपडेट करना जरूरी है. मेरा नॉलेज जहाँ तक है उसके हिसाब से तो ये है कि मेडिकल लीगल मैनुअल का शायद कुछ उसके हुआ था, टीम वगैरह बनी थी उसको, पर अभी तक वो आया नहीं है. उसको अपडेशन बहुत जरूरी है. बहुत सारी चीजें हो गई. अभी वी आर टॉकिंग ऑफ मेडले पार्ट, ऑनलाइन मेडिकल लीगल एंड पोस्टमार्टम रिपोर्टिंग सिस्टम, और अभी भी हमारा मेडिकल लीगल मैनुअल इंडिपेंडेंस के पहले का है या जस्ट टाइम का होगा. तो इसको हमें थोड़ा सा टेकअप करना पड़ेगा, मुझे लगता है थोड़ा जल्दी. बहुत सारे स्टेट गवर्नमेंट्स ने ऑलरेडी दे हैव डन इट, तो हमारे पास टेम्पलेट्स हैं, हमारे पास वो है, तो हमें उसको थोड़ा सा अगर कुछ, तो डॉक्टर्स जो ये जो रेफरल सिस्टम में जो डर है उनको कि हमें आगे क्या होगा और हम कब करें, किसको करें, और उसमें मेडिकल लीगल रिस्पॉन्सिबिलिटीज हमारी क्या होंगी, वो एक फैक्टर हो जाएगा. ये मुझे थोड़ा सा लगता था. बाकी मैडम
Thank you. Yeah, we have worked together, Dr. Shashi Thakkar and myself. That's why a few things we share our perspective. But in what looks like very significant to me is कि हमारे जो पूरा मध्य प्रदेश है उसमें जो मेडिको लीगल केसेस का हैंडलिंग है सारे मेडिको लीगल केसेस इंक्लूडिंग ऑटोप्सीज इंजरी केसेस एज एस्टिमेशन examinations, everything A to Z, everything is so much below standard, so much below standard at CHC and PHC level because there are no experts. Because there are no experts, and usually an expert of another specialty has to do this medical legal work in addition to what they are doing. So they are not trained for it. They don't understand that it's a very simple fact of documenting what you see and to what extent you must see and document. It's just that fact which is to be translated. So there are people who end up doing autopsies, who end up writing medical legal reports or giving age on single X-ray, single bone, and this document goes in court, and when it is referred to us at a later stage for a second autopsy is done. So the second person who is doing it will find 100 faults with the person who did it initially and land him up in trouble now. Even if he was having a relatively safe life and he did do something, whatever was understandable to him. Main crux is training of the human resource. There are no mortuaries, as I understand, uniformly in the state. There are no protocols like he's saying of manual, medical legal manuals for doing autopsies. And all cases of homicides, cases which decompose, they are all handled in such a manner that you lose out on so much of reporting, so much of handling of crime, so much of justice, so much of unnecessary pursuance of justice where it's not required because it doesn't get handled in a way that it should be. And I think I was very happy with this approach of one state, one health, where we could actually get on a platform, see what issues are, and from a place like medical colleges and AIIMS, I think it's very right moment to address that issue and finally have short trainings or short video sharings or short conferencing while you are in the middle of something and saying how do we handle these cases and having common protocols circulated. Most of these things of autopsy are going on general unwritten guidelines. We do complete autopsy, and it's so difficult to open the skull at primary health level and community health center level. They often use stone. They often just crush the skull. And when we get videos of custodial deaths, which are considered very high profile, they are opening the body with a single blade, razor blade, and standing up and watching without even putting your hand. Because you're not having gloves on, you're not having a mask, or you're not looking at organs. The whole perspective of autopsy, the whole investigative part is so subnormal, so much below average that it's pathetic when we do see expert opinion. It is the few reference centers, I think it is really our responsibility to see that everyone has because it is a autopsy or medical legal examinations and treatments are supposed to be free of cost. Supposed to be free of cost. And you hear every few months a survivor with multiple injuries or paralysis struggling to find treatment at places and then getting admitted and then feeling very relieved for getting treatment. Too late, but then free. So you have a lot of gaps. Hopefully, like with sexual assault victim, we do have Ministry of Health and Family Welfare protocol in a form. But so many people unaware of how to go about it, how to write it, what to do about it. which is of mine, not very resource demanding, but training or skill demanding, which is not too complicated to like surgeries, robotic surgeries, laparoscopic surgeries, or ICU services. It's not that that skill demanding. Can be easily translated. I hope this.
Maybe at the beginning, good. We will have the random thoughts.
इस बीच में इतनी सारी जो बातें हुई हैं, 3 वर्ड्स हैं, उनके बारे में मैं चाहता हूँ क्या हम लोग में से कुछ लोग जानते हैं? PR, HFR और EDAR, especially from private persons. Health Facility Registry, Health Professional Registry और Electronic Detailed Accident Report. और सबसे मजे की बात यह है कि जितनी भी प्राइवेट फैसिलिटी है वो हेल्थ फैसिलिटी रजिस्ट्री में ऑलरेडी रजिस्टर हो चुकी है, क्योंकि भोपाल की जो फैसिलिटी है उनको मैं रिन्यूअल ही नहीं देता इससे पहले कि उसमें रजिस्टर कर। हम लोग तब से गोल्डन आवर की बात कर रहे हैं, हम लोग इमीडिएटली सर्विस प्रोविजन की बात कर रहे हैं। गवर्नमेंट ऑफ इंडिया ने ये दोनों चीजें 2 साल पहले चालू की थी। हमारे भोपाल की जितनी भी प्राइवेट और गवर्नमेंट फैसिलिटीज हैं, ऑल आर रजिस्टर्ड इन हेल्थ फैसिलिटी रजिस्ट्री, और गवर्नमेंट का एक प्लान है कि ये सब ऑनलाइन अवेलेबल हो, जिससे जब भी किसी को इमरजेंसी में जरूरत पड़े तो उसे ये पता चल सके कि मेरे नियरेस्ट कौन सी हेल्थ फैसिलिटी है, उसमें कौन कौन से हेल्थ केयर प्रोफेशनल्स अवेलेबल है और कौन कौन सी सर्विसेज। तो हम लोग सरकार की तरफ से तो बहुत सारी हमने कमियां गिना दी। अभी भी मैं बता रहा हूँ कि जिन लोगों की मैंने हेल्थ फैसिलिटी रजिस्ट्री कर दी है उनमें से आधे लोगों ने अपने यहाँ की, क्योंकि वो फैसिलिटी खुद ही करनी है, उन्होंने हेल्थ प्रोफेशनल्स की रजिस्ट्री। तो सबसे पहले तो हम शुरुआत अपने आप से। मेरे पड़ोस में जो दोनों लोग हैं वो लीडर्स हैं, डॉक्टर संजय खरे, डॉक्टर योगेश गौरव, और मुझे इसका ध्यान आया जब डॉक्टर पंकज जैन ने हम लोगों से आभा की बात की। आभा आईडी क्रिएशन के लिए हमारे जितने भी प्राइवेट और गवर्नमेंट के रजिस्ट्रेशन काउंटर से उन सब जगहों पर फैसिलिटी अवेलेबल है, और इसके बावजूद मुझे पूरा भरोसा है कि हमारी इस गैदरिंग में कम से कम 10 लोग जरूर निकल आएंगे जिनका खुद का आभा आईडी नहीं बना। मैंने भोपाल में अपना आईडी बना के अपनी शुरुआत की। तो हमें सिर्फ नई चीजें, स्टैंडर्डाइजेशन ऑफ ट्रीटमेंट के लिए बिल्कुल एम्स के लीडरशिप की जरूरत है, उसके बगैर हम आगे नहीं बढ़ सकते। और इसलिए भी जरूरत है क्योंकि अब जैसे जैसे एम्स डिसेंट्रलाइज हो रहे हैं, लोकल लेवल की जो डिजीज पैटर्न है, एक्सीडेंट पैटर्न है, वो सारे अलग होते हैं, और इसलिए हम चाहेंगे कि एम्स इसमें लीड ले और उस तरह का स्टैंडर्ड ट्रीटमेंट गाइडलाइन बनाए जो हमारे एरिया के लिए, मैं स्टेट भी नहीं कहूँगा, एरिया के लिए, सेंट्रल इंडिया के लिए रिलेवेंट। बट उसके साथ में मैं ये भी जरूर कहना चाहूँगा, मैं तब से संतोष भास्कर साहब की बात सुन रहा था, नीता अरोरा मैडम की बात सुन रहा था। एक और चीज मैं कहना चाहूँगा कि गवर्नमेंट में वो दिन गए जब रिसोर्सेज की कमी हुआ करती। पिछले से 6 साल से 5-6 साल से मैं खुद अलग अलग डिस्ट्रिक्ट्स में CMHO हूँ, एंड यकीन मानिए कि गवर्नमेंट हमें कभी मना नहीं करती किसी भी चीज के लिए, किसी भी चीज के लिए। बस आपको उसका रेलेवेंस बनाना बताना पड़ता है कि मेरे लिए, मेरे एरिया के लिए, मेरे इस इंस्टीट्यूशन के लिए, मेरे इंस्टीट्यूशन के लिए ये रेलेवेंट है, और गवर्नमेंट उस पर हमेशा विचार करे। तो ये 2 पॉइंट मैं जरूर आपके ध्यान में लाना चाहता हूँ। इसमें से एक जो रजिस्ट्री है being led by आयुष्मान भारत ग्रामीण, and the other one is होम डिपार्टमेंट जिसको पुलिस कोऑर्डिनेट कर रहा है। तो मैं ये चाहूंगा कि हमारे जितने भी स्पेशली प्राइवेट सर्विस प्रोवाइडर्स उसमें जरूर रजिस्टर करवाएं, ये उनके अपने फायदे के लिए है और प्लस पब्लिक के फायदे। थैंक यू।
Before we end, any other thoughts? Can use the mic.
A very good afternoon to all. Dr. Shahraj Khan, HK Emergency Medical College. So very rightly discussed about all the emergencies that they tackle at the periphery, and then they are referred not in a very good condition to the hospitals. Sir, one little question. We are all medical teachers, most of us. How many of us can vouch कि हम जो एक मेडिकल ग्रेजुएट प्रोड्यूस कर रहे हैं, पेशेंट को बेसिक लाइफ सपोर्ट दे training module in the medical college where in MBBS we train our medical students with a basic life support. I'm not talking about advanced. So number two, when interns come to their postings, especially when they come to me in emergency medicine, they actually ask me, ma'am, why are you not taught these basics? Because in the skill lab, with the way AIIMS is teaching us in the BLS, I definitely second Dr. thought that we need an indigenous program in India. So let us focus on the PG again. In the surgery PG, evaluating the trauma patient as per the A, B, C, or is he straight away jumping to D? Is he forgetting the A, B, and C? So why are surgery PGs not able to tackle a trauma patient with their graduate, postgraduate, periphery पे जाकर के trauma patient की ABC कर पा रहा हो? So this is the time that we also that is the training given in our colleges as per the standard. What I want.
I think that's fairly pertinent. Although different modules and different skill labs and there is, I think that's the burning question not only for the students. There are already thoughts that internship training should be more focused and move PG entrance exam beyond that to next. That's the better. That is the reason why we need to conduct so many trainings, even about standard workflow, because even when a medical graduate passes, a medical graduate or even a postgraduate is not able to do what that person might have or might not have learned. Many times we do realize that there are many things they ought to have learned, but they have not learned. And I say it's a collective failure of us, not a collective failure of the system, because medical education is a system which has been created by medical teachers. Government has one part to play as far as infrastructure is concerned, but it is a collective failure for all of us that our own MBBS graduates and even PG graduates, and I will say sometimes even DM and MCH graduates, are not able to fulfill expectations which general public have that they will be able to do, and they need more training. Also because patients have become more aware, and also because we are failing somewhere.
But I want to add something, sir. You rightly said that somewhere it is our failure, but sir, NMC has incorporated basic and advanced courses in PG teaching, and we have been posting our postgraduates for advanced training in Department of Anesthesiology. So it is there in our curriculum, according to NMC.
Hello.
I am practicing actually, all things I think covered. I am background from dentistry and oral health. I also want to add oral health is also important put in this agenda, so that I think the number of patients of the oral disease like oral cancers, jaw lesions, and the other dental issues also consider at the PhD level, because the PhD level there is no any dentist. All the dentists are in a cities, either in a town or either a big city. So how we can ensure the oral health at a PhD level? We should also consider this. The second, in this thought, I also want to actually technology, by using the technology, we can solve many problems. Because we have as an Indian, we have a poor documentation and the things. Poor documentation may be due to the कितना कागजी काम कैसे करे क्या करे. लेकिन if we should make a improved software and the user friendly software, and that can be used in, I think in Denmark, I think all the investigation in only one click, even from private or even from the government. ऐसा गाइडलाइन दे देनी चाहिए गवर्नमेंट की तरफ से, वो भी इन्वेस्टिगेशन ऑनलाइन है, क्योंकि प्राइवेट वाले इन्वेस्टिगेशन देते नहीं, प्राइवेट रख लिए, इसकी वजह से हमें दोबारा कराना पड़ता, पेशेंट का टाइम भी ज्यादा जाता है और खर्चा भी ज्यादा होता है। और तीसरा जो मेरे को सबसे, जो मैं एम्स में, मैंने एम्स दिल्ली में 8 साल काम किया है, और उससे मैंने ये पाया मोस्ट ऑफ पेशेंट हमारे पास लेट पहुंचते थे और टाइम भी नहीं पहुंचते थे। उसका मेन रीजन था कि पेशेंट एजुकेशन बिल्कुल कम है इंडिया में, बिकॉज ऑलरेडी एजुकेशन कम है। आई थिंक वी शुड वर्क ऑन द पेशेंट एजुकेशन अवेयरनेस एट एवरी लेवल बाय डूइंग, जो मैडम ने बोला कि आप बिल्कुल ऐसे अंडरस्टैंडेबल फ्लो डायग्राम्स या इस टाइप की पेशेंट एजुकेशन में अपन काम कर सकते हैं, लोकल वर्नाकुलर लैंग्वेज, दैट इज आल्सो इंपॉर्टेंट। तो समटाइम्स अपन टेक्निकली इंग्लिश में लिख देते हैं, किसी को समझ में नहीं आता बेसिक। तो ये मेरे गुड पॉइंट, वी नीड बोथ डॉक्टर एजुकेशन एंड द
मैं चाहूँगा कि ये ऐसा कोई ऑनलाइन मीटिंग या जो यंग डॉक्टर्स हैं गाइडलाइन प्रोवाइड की जाए कि मैनेज या कॉन्फ्रेंस है, इंफॉर्मेशन इज मोर रिक्वायर्ड फॉर पर्टिकुलर थिंग्स। तो कई बार ऐसा होता है समझ में नहीं आता तो अपने आप भेज देता है।
Sir, we also considered antibiotic stewardship. I have seen in private even patient go for MI, they will start one monocephaly. So that is also very important, antibiotic stewardship. We have to in standard policy. This is the most important. Where we have to also make the policy a private player don't give the medicine of antibiotic from the counter, like many Middle East countries, so many are. Yeah. Oh, thank you.
My only concern is the benefits of health systems. Fully, there is no forgiveness. If we recognize that, because eventually it is public sector which becomes private sector and so we have to work on antimicrobial stewardship, work on better administration, better doctor education. But I think collectively we can work if we consider all factors.
Thank you very much, everyone, to all the participants who participated so lively. Thank you for making it very, very interactive. Thank you for bringing up all the challenges. It's more of challenges than of the things that are in place. And now it's the time to get into the working groups and see how we can address some of these challenges and make a beginning in this direction. Thank you.
We would like to thank all the panelists who have devoted their time, and number of panelists were more and so topics were broad. We also apologize for any inconvenience to anyone during the inauguration. Thank you all the panelists. Now we will proceed for working group discussions. I will be telling the working group leads and members of the working groups. Even others. Yeah, panelists can leave because honoring your time, we have kept you in panel discussion. If you are interested in working groups, still welcome. We are splitting now in working groups. There are 7 working groups. Emergencies and critical care. Dr. Saurabh is lead for emergencies and critical care. We request Dr. Ashita Rajpur, Dr. Jaiprakash Sharma, Dr. Pooja Thaure, Dr. Patel, Dr. Rashmi, Dr. Rishi Katia, Dr. Santosh Bhaskar, Dr. Sarika Katia, and Dr. Tahir to be in emergency and critical care group. Then trauma and injuries, this group, emergency and critical care group, will go to faculty launch 2nd floor. Then trauma and injuries group, they will stay in this room only. These are Dr. Pratik Behra, Dr. Amit Priyarashi, Dr. Anil Baduke, Dr. B.L. Soni, Dr. Hariom Gupta, Dr. Kamlesh Devpujari sir, Dr. Relish Srivastava sir, Dr. Rahul Dubedia, Dr. Rakesh Kumar Khare, Dr. Saurabh Singh, Dr. Vidya Verma. They will stay in this hall only. That is a trauma and injuries group. Then general surgical conditions group. This group will go to CFM boardroom, which is on second floor. Dr. Shamlal is working group lead for that. Dr. Ajit Pratap Maurya, Dr. Anand Kale sir, Dr. Arpit sir, Dr. Ashwin sir, Dr. Gyanendra Singh Argal sir, Dr. Ishant Kumar Chaurasia, Dr. Kanti Batam, Dr. Manal, Dr. Rakesh Kumar, Dr. Sandeep Jain sir, and Mr. Kumar Swami. They will go for general surgical conditions group, which is on second floor. Then maternal conditions working group, Dr. Modi Madam, Dr. Ajay Haldar, Dr. Avantika Gupta, Dr. Deepak Padalia, Dr. Juhi Madam, Dr. Shirish Raghuvanshi Sir, Dr. Shraddha Madam, Dr. Sunita Kamble Madam, and Nasima Madam. They will go to second floor CMET room. Modi Madam will escort them to CMET room, second floor. Pediatric working group. It will be in second floor skills lab. Dr. Bhavna Madam will be lead. Dr. Girish, Dr. Mahendra Sir, Dr. Mamta Madam, Dr. Manjusha Madam, Dr. Neeti Madam, Dr. Purva Madam, Dr. Priya, Dr. Rajesh Tikka Sir, Dr. Rakesh Bhargava Sir, and Dr. Yogendra Singh. They will go to skill lab lecture hall on second floor. Dr. Bhavna will take them there. Medical legal group, Arvind Madam, Dr. Amit Ganesh Mathur, Dr. Manish Nigam Sir, Dr. Manisha Mittal Madam, Dr. Niranjan Sahu, Dr. Rajendra Sir, and we will request Dean Sir Satna also to be part of working group. They will sit on Dean's boardroom, first floor. Then general medical conditions group, Dr. Vaibhav Ingle will be the lead. Dr. Alka Chaturvedi Madam, Dr. Anand Kumar Sharma Sir, Dr. Ankit Chaudhary, Dr. Anurag Bhai Patidar, Dr. Devendra Singh Sir, Dr. J.P. Agrawal Sir, Dr. Josna Jain Madam, Dr. Manish Sharma, Dr. Mohammad Ilyas Sir, Dr. R.K. Bairagi, Dr. Sagar Kadanga, Dr. Simi Dubey Madam, Dr. Snehil, Dr. Tamud, and Dr. Vaibhav Dubey Sir. All of these will go to CMET hall, second floor. Dr. Vaibhav will take them. And rest of the people who are still here, they can join the relevant working group as per their speciality. So now we will split. Thank you.
trauma emergency patients. Now I'm shifted to the main department. So over to Dr. Bhopal.
I'm a Dr. Babula Soni. I'm an assistant professor in trauma and emergency medicine at Bhopal. Previously, I did work in the Apex Trauma Center at AIIMS Delhi. Was 2 years in exclusive and 6 years for overall experience of the Apex trauma. And currently, I am working with the maxillary faculty and investigation and trauma.
Good morning, everyone. I'm Dr. Vidya Verma, Associate Professor, Department of Ophthalmology and Bhopal. I'm looking after in our department comprehensive ophthalmology, cataract and glaucoma.
Morning, I'm Dr. Kamlesh Devgari. I'm orthopedic hospital.
Hello, once again, I'm Dr. Shehtaj Khan, head of the emergency medicine, LN Medical College, Bhopal, also a surgeon.
Good morning, everyone. Myself, Dr. Amit Pildashi. I am a assistant professor in trauma and emergency medicine in Bhopal. I have done my MS General Surgery from Patna Medical College, Patna. Then I moved on to the JPN Apex Trauma Center in New Delhi, where I did MCF in trauma surgery and critical care, and then joined here in trauma and emergency.
Morning. Myself, Dr. Sumit Raj. I'm working as an academic professor in the Department of Neurosurgery in Bhopal. Previously, I worked at many institutes at Delhi also. I worked in AIIMS New Delhi, Trauma Center, CTV Hospital, Apollo Indraprasth, and I joined AIIMS Bhopal in 2017.
So, while there were invitations to other experts, so if everyone is comfortable in Hindi, then I will start the dice rolling by saying that about 2 weeks back, this working group arrangement made, and I was made a part कि आप meeting करो. First meeting जो हुई थी उसमें ये था कि one state one healthcare concept बोला गया हमें कि because we are seeing on the tertiary level, और कई सारे ऐसे patients को probably जो आ रहे हैं ऑलरेडी मिसमैनेज स्टेट में है, जैसे मैनेज होना चाहिए वैसा आइडियली हुआ नहीं. और हम ये चाहेंगे कि एक ऐसा मैकेनिज्म हो कि ग्राउंड जीरो से शुरू करके टॉप लेवल तक में यूनिफॉर्म पैटर्न ऑफ ट्रीटमेंट रहे, जो कि आइडियली होना भी चाहिए. और जब वो ट्रीटमेंट चले तो एट द एंड कहीं पर भी वो पेशेंट रहे, उसको वहां से फर्दर ट्रीटमेंट मिले, ना कि एक स्टेप पीछे जाके क्या हुआ था, क्या करना था वो पता. जैसे कि पहले भी पूरा डिस्कशन हुआ है, प्रभाकर सर ने भी कहा कि ट्रॉमा इंजरीज का पैटर्न ग्रेजुअली चेंज हो रहा है, और उस पैटर्न को मद्देनजर रखते हुए हमने जो मैं उस प्राइमरीली मिला ऑर्गेनाइजिंग टीम से वो ये था कि आपको 4 से 5 ऐसे ट्रॉमा एंड इमरजेंसी रिलेटेड कंडीशंस आइडेंटिफाई करने हैं जिनको आपको लगता है कि एक्यूट रिक्वायरमेंट है कि हम उसको स्ट्रीमलाइन कर पाए फ्लो ऑफ पेशेंट्स, ट्रीटमेंट ऑफ पेशेंट्स. और उसको हमने आइडेंटिफाई करके मल्टीपल स्पेशलिस्ट्स हैं हमारे साथ, जिनके साथ के गाइडेंस पे एक सिंगल पेज का एल्गोरिथम बनाने की कोशिश की है, व्हिच इज सिंपल टू अंडरस्टैंड. तो अब हमने तो जो बनाया है टेक्स्ट बुक से है, हमारे एक्सप्लोरर से है, हमारे प्राइमरी ये प्रेजेंटेशन का ये था कि जो एक्सपर्ट है वो हमें फीडबैक देंगे कि वेदर जो हम बनाए ये करने लायक है कि दिस नीड्स टू बी फर्दर अपग्रेडेड. और तो इस कंटेक्स्ट के साथ देखेंगे तो ये प्राइमरी ऑब्जेक्टिव था. पहला एक एक करके ग्रेजुअली कुछ ऐसे एल्गोरिथम बनाने हैं जो कि ओवरऑल सारे ट्रॉमा कंडीशंस को कवर करते हैं. दूसरा है जो कि टाइमली रिकॉग्निशन, टाइमली रिससिटेशन एंड देन टाइमली रेफरल. और ये होने के बाद इजी एल्गोरिथम, और मोस्ट इम्पोर्टेंट इसको लेकर के लोगों ने अलग अलग लेवल पे अपनी आशंकाएं व्यक्त की, वो है कि रेफरल टेस्ट. तो अब फर्दर मैं ये स्पेशली मैडम और कमलेश सर का कि जो हमने कुछ प्रोटोकॉल के जैसा बनाने की कोशिश की है, हम एक एक करके जो जिन्होंने बनाया है प्राइमरी उनको मैं इनवाइट करूंगा कि उन्होंने किस कॉन्टेक्स्ट में कहाँ से क्या सोच के उसको बनाया है और जो बनाया है whether it is doable at different levels. Doable in the sense कि क्या PNC के लेवल पे ठीक है, CNC में ठीक है, और अगर हाँ या ना उसमें कुछ मॉडिफाई करना है तो कैसे। तो मैं सबसे पहले बुलाऊंगा डॉक्टर अमित को कि वो जो स्टार्ट करेंगे वो है कि जो ओवरऑल फ्लो ऑफ मूवमेंट हम पेशेंट्स का सोचते हैं कि ट्रॉमा पेशेंट का कैसा होना चाहिए, उसको डॉक्टर अमित अपने पॉइंट्स बताएंगे और मैडम सर से प्राइमरी फीडबैक होगी। एक्चुअली हम लोगों ने इंटरनली थोड़ा डिस्कस किया हुआ है, तो आपका इनपुट हमारे लिए ज़्यादा जरूरी है। थैंक यू।
First of all, I have made this very like flow chart at different levels of healthcare facility, like PHC, what is the entry level, and then the CHC or the district hospital, and then the medical college or the AIIMS. तो सबसे पहले हमारा सोल पर्पस अगर अपनी जितने पेशेंट हमारे पास पीएचडी में आते हैं उसके प्राइमरी सर्विस एंड मैनेजमेंट बेसिक हो, because we all know about the ATLS protocols and primary service, secondary service, that will be analyzed by basically. तो हम चाहते हैं डेफिनेटली ABCD स्टार्ट हो जाए, हम सेकेंडरी सर्वे फोकस नहीं करें पीएचडी पे, क्योंकि सेकेंडरी सर्वे आता है डेफिनेटली डायग्नोसिस। चाहते हैं कि प्राइमरी लेवल पे हमारा सिर्फ लाइफ थ्रेटनिंग इंजरी को टैकल करे, ऑक्सीजन से मिले, IV फ्लूइड मिले, पेन किलर मिले और एंटीबायोटिक्स से रिक्वायर्ड है वो मिले, एंड देन जस्ट प्राइमरी लेवल पे एक चीज में ध्यान रखें कि प्राइमरी पीएचडी लेवल पे कोई पेशेंट डिस्चार्ज नहीं हो। अगर पेशेंट को हिस्ट्री ऑफ ट्रॉमा है तो दैट मस्ट गेट केयर एट लीस्ट सीएचसी और डिस्ट्रिक्ट हॉस्पिटल लेवल। क्योंकि प्राइमरी लेवल पे आप बहुत सारी इमेजिंग नहीं कर सकते, एक्सरे नहीं कर सकते, बहुत हुई अभी तो पेशेंट का ऐसा 17 पे है, बाद में सिग्निफिकेंट फाइंडिंग कराएंगे, तो इन्वेस्टिगेशन प्रॉपर है नहीं किसी को, किसी ने कोई भी डिस्चार्ज या डिस्पोजल नहीं रहता, तो सारे पेशेंट को बस बेसिक ट्रीटमेंट देके रेफर करेंगे सीएचसी या डिस्ट्रिक्ट हॉस्पिटल। देन एट द नेक्स्ट लेवल ऑफ केयर एट द सीएचसी और डिस्ट्रिक्ट लेवल वहां पे morning sir, we welcome you. Can you introduce yourself? Actually, we have just started this.
Sorry to meet Dr. Lali Srivastava, ophthalmologist come and get me text. Return of the biggest as well as the secretary of the United Doctor.
We have just started with the slides that is the objective of this working group. And then this is our basic level of flow of the how the patient get flow from the entry level to the from the entry level of PhD to the CHC or the district hospital and then to the apex to the medical board. तो हमारा सोल पर्पस सर कि जो पीएचसी पे जो पेशेंट आते हैं उनको एटलीस्ट बेसिक मेडिकल केयर मिले एंड इमीडिएटली उनको रेफर करना है। वहाँ पे पेशेंट का कोई टाइम वेस्ट नहीं होना, कोई सेकेंडरी सर्वे नहीं, कोई डेफिनेटिव इन्वेस्टिगेशंस नहीं, जस्ट ऑक्सीजन मिले, पेन किलर मिले, एंटीबायोटिक मिले और एक IV फ्लूइड मिले और देन इमीडिएटली रेफर द पेशेंट टू द सीएचसी और द डिस्ट्रिक्ट। तो जब हम डिस्ट्रिक्ट हॉस्पिटल में आते हैं वहाँ में प्राइमरी के साथ सेकेंडरी सर्वे स्टार्ट करते हैं, क्योंकि कई बार डिस्ट्रिक्ट हॉस्पिटल वेल इक्विप्ड होते हैं, बहुत सारी इन्वेस्टिगेटिव फैसिलिटीज है, हमें डायरेक्ट एक्सरे है, सीटी स्कैन है, रेडियोग्राफी यूएसजी भी बहुत सारी जगह अवेलेबल है, और वहाँ पे जो पेशेंट टैकल होने लायक लाइक एक्सीडेंटल इंजरी है या फिर अगर कोई माइनर इंजरी है अगर जो इन्वेस्टिगेशन में आता है तो दे विल मैनेज एट देयर ऑन लेवल। और वहाँ पे जो पेशेंट वहाँ पे देखिए हीमोडायनामिक स्टेबल है या नहीं, अगर पेशेंट हीमोडायनामिक स्टेबल है तो फिर आपको जो कंटिन्यू द रिससिटेशन एंड जस्ट रेफर टू द पेशेंट टू द नेक्स्ट लेवल। अगर आपके पास पेशेंट इमीडिएटली ओटी अवेलेबल नहीं है तो आप मेडिकल कॉलेज रेफर करो पेशेंट को, तो पेरिटोनाइटिस है, एक्टिवली ब्लीडिंग है और बट ये सारे रिफ्लेक्स है जिसकी आ रहा है, और अगर फिर आपका हीमोडायनामिक स्टेबल है तो फिर आप वहाँ पे उसको इन्वेस्टिगेशन करा सकते हैं, like chest X-ray, pelvic X-ray, CBC, KFT, PTNR, these are basic investigations. And in trauma imaging, the CT scan mainly important the NCCT head, C spine, plus minus the facial injury suspect. और एक इम्पोर्टेंट चीज है कि हमारे पास मैं चाहता हूँ कि डिस्ट्रिक्ट हॉस्पिटल का CT scan अवेलेबल है तो वहाँ पे CCT टॉर्सो हो, दैट इज चेस्ट एब्डोमेन पेल्विस, बिकॉज़ कई बार हमारे पेशेंट्स आते हैं NCC एब्डोमेन करा के, तो ट्रॉमा की स्टडी में एनसीसी की कोई सिग्निफिकेंस इसलिए बिकॉज हमें ये नहीं पता वेस्टर्न इंजरी है या नहीं है, सॉलिड ऑर्गन इंजरी है या नहीं, लीवर स्पिन कुछ भी उसका इंजर्ड है या नहीं है, तो हमें दोबारा कुछ कंट्रास्ट देना पड़ता है, इमेजिंग निकालनी है। तो हमारा एफर्ट फुल है। हम चाहते हैं कि डिस्ट्रिक्ट हॉस्पिटल अगर सीटी कर रहे हैं तो कंट्रास्ट दे के सीटी करें, और उसके बाद अगर कुछ मेजर इंजरी है तो हमारे पास रेफर करके प्रोटेक्टिविटी इन्वेस्टिगेशन में मैनेजमेंट है, और अगर नार्मल या माइनर इंजरी तो वो टैकल कर सकते हैं, तो फिर अपने यहाँ पे डिस्क्लोज कर लेंगे इन्वेस्टिगेशन। तो इन द बेसिक लाइक आइडिया फॉर द पेशेंट फ्रॉम वन लेवल टू द
सर मैडम सर एक बेसिक प्रॉब्लम है कुछ
You are absolutely right what you spoke. I also agree with what Madam said a few minutes back. कि जिस तरह से हम लोगों का स्टेटस ऑफ अफेयर है पेरिफेरी से रेफर करने का, यूजुअली आस्क माय जूनियर्स whenever they join the institute as an intern, first question I throw on them is एक पेशेंट रेगिस्तान में पड़ा हुआ है, आप इत्तेफाक से रेगिस्तान में जाते हैं, and that fellow is suffering from a major fracture, may it be a fracture of scapula femur or may it be a fracture of scapula humerus. How will you ship that patient to me, to an orthopedic surgeon? And to my utter surprise, those guys fail to answer. जबकि हमारे यहाँ जो 108 सर्विसेज है उसके जो AEMTs हैं, they are practically not बारहवीं pass, but they are told this is not a question related to medical or it is related to first aid, and they fail to answer this question कि वो सबसे पहले it's an arbitrary question, just like सलमान खान मूवी कि आप वहाँ दिमाग घर में छोड़ के जाइए और वहाँ जाकर देखिए और एंजॉय कीजिए, तो वो ये नहीं बता पाते कि विदाउट स्प्लिंटेज वो इस पर आ जाता है कि स्प्लिंट देना जरूरी है, then what are the complications of patient shifting without giving splint, can a patient die of fracture, lot of questions are there associated with this question, but एक एवरेज मेडिकल स्टूडेंट क्योंकि उसको शुरुआत में बुकिश नॉलेज जितना जैसा मैडम ने बताया दिया जाता है, it should be taught at the primary level in the medical college itself, because they feel stranded when they are exposed to practicing such tradition. So you are absolutely right. But I had an opportunity of working in periphery 30 years back, and I know that I have seen not many patients shifting from primary health center level without oxygen, without IV fluids, just making a referral and getting rid of the patient and the condition. हमारी गला डालने वाली बात है, तो although people are blaming us nowadays, and I feel very bad that colleagues sitting in judicial, in administration who are IAS and were doctors earlier, they are also blaming us, but we are definitely कुछ ऐसा हिस्सा है जिसमें हम लोग गलती कर तो रहे हैं, और बाकी ये ठीक है आपका कि जो आप लोग फ्लो चार्ट बनाए उसके I do agree. मैडम will add something.
Ma'am, please.
Start from the start. Airway. Have we done anything for the airway anywhere? The airway is threatened. There is any maximum injury for the patient. That be able to make the patient release. And breathing. If the patient has tension in the back, only one needle decompression. That patient is not. In this algorithm, all that we are focused on is C, circulation.
No.
Hemodynamics.
Overall picture.
Yeah.
So
We segregated the patients on the basis of hemodynamics and why don't vital stability? Why not respiratory?
actually, like what you are saying that is, I thought it will completely come under the primary survey management. So primary survey, we will discuss in the second slide in detail the primary survey. So in primary survey, assume like airway and breathing will be taken.
We talk about primary survey and management. We go way beyond oxygen, IV fluids, analgesia, plating and breath. Go way beyond that in management. Airway and breathing management at PHC will require a challenging task.
Might be.
Instead of hemodynamics, it should be vital stable. Vitally stable. And secondly, I think that totally not thinking about the by the time the patient reaches the next,
Very bad. Very bad.
But I
got the primary survey in German के अंदर सारे कुछ है airways, spine, running, like injury will be taken in the primary PhD.
Right? It is nothing. But it is only
No, just continue the investigation and revise the primary survey if anything has gone wrong.
where we have written refer. PhD refers case. That gives an indication where it is who can run. You just put on oxygen.
Kind of.
We are not segregating patients at the
No, not
we are not segregating. We are not segregating. Actually, why are we not segregating? Because people at PhD level are not able to manage.
Exactly. That's
They are not able to manage the airway. Not go beyond CS. So see the link between the PhD. Distribution of airway of breathing going to reach. Hemodynamic unstability, you put it airway or breathing.
हमें ये नहीं पता कि लाइक पीएचसी में एयरवे टेकअप कर पाएंगे नहीं कर पाएंगे बिकॉज़ वी डोंट
तो एटलीस्ट ए बी सी एड्रेस कराए ठीक चलेगा
ये तो चलेगा
प्राइमरी पे क्या प्राइमरी पे जो ए बी सी कर
हमको ओपीए सिखा सकते हैं
yes.
It will come under like recommendations like for last manpower training.
बोलना चाहता हूँ NLC and NPU. NLC should be reported at PHC and patient keep NPU. मोस्ट ऑफ लोग हैं डॉक्यूमेंटेशन करना भी चाहते हैं हमारे जीआर भी NLC नहीं बनाते मेरे को रेकमेंड अगर तुम डॉक्टर्स वर्किंग these are very much improving now for very bad ads and they are taking UK. ये कह रहे थे तो है लेकिन वो नहीं रहा सो दैट हम प्लान करना नहीं पर हम काफी बहुत अच्छा हमारे प्रिंसिपल सेक्रेटरी थे मिस्टर प्रवीर कृष्ण सीनियर आईएएस जबलपुर से एक बार विजिट करके भोपाल आ रहे थे रास्ते में उन्होंने काफी वैसा हॉट एरिया था वहाँ बोर्ड लगा हुआ था कि अस्पताल में तो डिस्पेंसरी उस डिस्पेंसरी में अंदर गए थे डॉक्टर अग्रवाल वाज देयर ही वाज पोस्टेड देयर तो उन्होंने वहाँ देखा कि बड़ी अच्छा काम होने ये लगा इसने फर्जी डॉक्यूमेंटेशन किया उन्होंने अपने लोगों को जासूसी करने के लिए भेजा गाँव में लगा के बढ़िया है पूरे समय यही रहते हो काम और ऐसा लग रहा था कि यूएस की किसी छोटी डिस्टेंस थी वहाँ पर और वहाँ पे एसी जो लगे हुए थे वो पेशेंट के लिए सर ने लगा दिए थे डॉक्टर में बैठे हुए 42 डिग्री में डेडिकेटेड लोग एक हमारे मिनिस्टर साहब थे उनका 20 साल पहले उनका आया कार्डियो अस्पताल के पास उसको लाइट का मोटरसाइकिल से हेडलाइट उसकी टकरा गई वो गिर गया और उसको चोट लगी कार्डियो में उसको क्लिनिकल एक्सपीरियंस की बात है देन रेफर टू हमीदिया हॉस्पिटल वहाँ पर उसके वाइटल्स ठीक थे कुछ समय तक फिर वो डिटोरेट होने लगे हेमोडायनामिक्स उसका गड़बड़ हुआ प्रोफेसर रामनीकर बॉस थे उन्होंने देखा कि जाके तो उन्होंने सिंपल का एक वाइट बोर्ड नीचे लेके आओ एब्डोमेन में डाला मुझे वो याद है कि क्लिनिकल एक्सपीरियंस अपना इंटरेस्ट इन्वॉल्वमेंट बहुत जरूरी है झगड़े वही होते जहाँ हम लैकिंग ऑफ लापरवाही कर वो पार्ट बहुत अच्छा हो हमारा कहना नहीं चाहिए लोगों के पास बहुत अच्छे हो गए, फैसिलिटी अच्छी है, लोगों को वहाँ पे एम्बुलेंस वगैरह का व्हीकल की बहुत अच्छी डिमांड्स हैं, लोगों में इंटरेस्ट आ रहा है। और यहाँ से डिमांड नहीं पड़ा कि डिमांड कम हो, कोई इंटरेस्ट नहीं पड़ा, बहुत अच्छे से
नेक्स्ट इमेजिंग करा के पेशेंट को अल्टीमेटली हम डेफिनेटिव ट्रीटमेंट देंगे मेडिकल कॉलेज एम्स। So the next slide is for the AIIMS, the private service. This is the all very well known. So I will just move on to this. So we take a revise the primary survey and the secondary survey. AIIMS is fine. Oxygen intubation, survival is fine. As well as the breathing and ventilation will take care of. Like monitor the respiratory rate, to check compression is positive or negative, and the rate decompression and the treatment for hypertrophy if required. The application average control, like they check heart rate, BP, and rate compression test, and extract at least 1 liter phlebotomy test. So this all should be at the bare minimum should be done. The disability we will just write down the GCS on the hyper and the pulmonary reactions. And then the exposure environmental do just prevent hypothermia. The patient should not be like traveling 4 hours to the next level of care without with the hypothermia. And then these agents are like chest exercises, they are like level or not level at the primary level. If the facility is not there, then just refer permission. Then in the secondary survey, just empathy, like medication, mental illness, the last mental events during the incident. And then the head-to-toe detailed examination and check all the peripheral processes. Very, very important for the purpose of the through exam. Check for the peripheral vascular injuries and log out to examine the back in the agent. And agent will be entered against only in the district hospital or if the facility is not available, then immediately refer the patient to the next. Don't waste the time in investigation if you don't have the facility. Then this is a basic rapid assessment of the trauma patient. At least the 4 hours to be followed. This is just for the bare level AC level. Just to recognize the patient which needs a better level of care, one needs to be transplanted. Like recognize the patient with the history, like endothelial injuries, there, loss of consciousness, vomiting, seizure, and ENT bleed, like which indicates some of the significant head injuries, or the severe chest abdominal pain. And in the physical examination, like a normal vital of the patient is like whether stable or not. And the check compression test, but findings, if there is significant derangement in all the examination findings, then immediately refer the patient. Check if fast, if these are the level. Don't waste the time. Purpose don't waste the time at the initial level in the investigation if you don't have the facility. Then the our purpose is patient को basic PhD के level पे इतना restriction तो मिलना ही चाहिए. इसके बाद patient next level के लिए refer हो. At least oxygen मिलना चाहिए, fluid मिलना चाहिए, analgesic, antibiotic if required, and the PPI and injection रहता है. Effective bleeding is there, and the splitting and all that obviously may not be missed. And these are the very few red flag signs. If the red flag signs are there, then immediately refer the patient to the apex level of symptom. Like if the patient morale is unstable, deterioration in GCS or respiratory distress, signs of peritonitis of the actively bleeding. So, हमारा मैम इसमें any correction like just a brief snapshot for the PhD level. I will prepared like this. Kind of, basically. ये PhD level के लिए है. Exactly.
Box format, take the cross. Checklist. Patient आया. आप सबसे पहले A में ये चेक. Guideline है. फिर आप B में ये टिक. तब वो checklist हर जगह होगी. Yes. Any point. एसी वाला जब रिसीव करेगा पेशेंट को अपनी चेकलिस्ट में टिक करेगा. पेशेंट का ऑक्सीजन लगा हुआ है कि नहीं, ट्यूबेटेड है कि नहीं, क्रिक हुआ हुआ है, पेशेंट का रिसीविंग यस एंड नो चेक. Stop numerical service. Then again, just on this, red flag की बात करें तो हम
I think we can get into first. Right. मैं आपको presentation
Just sort of each level. Just do the bare minimum configuration.
Yes.
Yes. Thank you.
Eventually, some like
See, actually, we have been told that we have to just formulate a single slide in which a person at a PhD level can identify the problem, recognize what are counseling the patient family. It is a very important part. If you don't counsel the patient properly, he will land up to a next center and start fighting. That we हमें तो नहीं पता, हमें तो भेज दिया, अब आप देखो क्या करना है. So it is like that. So it is always better to counsel the patient regarding all the problems, the pros and the cons, the thing which has happened to a patient and the difficulties which the patient can encounter into. So MLC report comes the next part. If it is after the counseling part, in fact, you go on to the MLC. So if it is possible, as no sir suggested, Dr. Professor sir, that MLC can be done at PSC level. So you go on to the MLC part, and after getting all these things, then after doing all the resuscitation, then the third thing is whether the investigation like CT scan is available at PSC. If it is not available, at CSC, you direct refer to the district hospital or the tertiary center. You don't just direct refer from PSC to CSC, because if you know if your patient is having head injury and you are referring to a CSC, you are losing an important word, which is very important. Right? So to do all these things, try to do within short time as possible, and then refer the patient to the next possible best available feature which can help the patient. So that is what you will do is valuable input from your side.
Lunch will be ready by 1. If you are done, you can proceed to the lunch on second floor, still you have pantry.
We just had the slides for the new trauma part. Any changes process to be involved? Me and Dr. Alvin treatment and algorithm for maxillofacial surgery and dental injuries. Actually, maxillofacial injury is formally managed by the maxillofacial plastic surgery in a corporate and government hospital. So we think usually managing this dental trauma is most of by the dentist, either dentist, any pediatrician or either from maxillofacial. So we make this joint management algorithm how we should address the maxillofacial trauma from PSC to the tertiary area. So in the beginning, in PSC level, actually there is no dentist even available, no maxillofacial, even no plastic surgeon. So most of the MBBS are available, or they don't know what to do with any other facial injuries, dental injuries, and with the head injury even. So that my ultimate goal, just we will give 2-3 clue idea कि कब जब maxillofacial injury मान लो आता है तो आपको क्या देखना है. When the maxillofacial injury or dental injury should be considered as a secondary to the any life-saving injury. Like might be the head injury है तो पहले head injury हमें address करना है, या फिर chest trauma है, pelvic trauma है, या उसको पहले address करना है. Secondary we can maxillofacial, but at maxillofacial में emergency क्या है? 2-3 emergency से वो it should be addressed. Like due to the maxillofacial trauma, there should be the profuse bleeding. तो ब्लीडिंग की वजह से एयरवे कंप्रोमाइज हो सकता है, या फिर सम टीथ माइट बी द ब्रोकन, आइदर सम जेनेटिक पेशेंट माइट द डेंचर गेट ब्रोकन. सो क्लीनिंग ऑफ द ओरल कैविटी इज इंपॉर्टेंट वन थिंग. एंड द सेकंड थिंग, द एनी फ्रैक्चर टूथ यदि है तो उसको रिमूव कर दो, और कहीं से भी ब्लीडिंग हो रही है यू कैन जस्ट गिव ए स्टे सुचर. इंट्राओरल सुचरिंग लेना थोड़ा फिजिशियन के लिए डिफिकल्ट होता है, बट ये चैलेंज है. हम चाहते हैं कि इसको हम ट्रेनिंग दे देंगे थोड़ा, तो कहीं भी इमरजेंसी हो तो एटलीस्ट इंट्राओरल सुचर एमबीबीएस ले पाए. द सेकंड थिंग, एक्स्ट्राओरल यदि ब्लीडिंग हो रही है तो देयर आर 2 थिंग्स, आइदर स्टे सुचर ले लो या कुछ पैकिंग कर दो, ड्रेसिंग कर दो. थर्ड चीज इजीली जो उनको सिखा सकते हैं कि एटलीस्ट यदि जॉ फ्रैक्चर है तो उसका पैथोग्नोस्टिक साइड है कि पेशेंट के दांत बराबर नहीं मिले, तो हम ये सिखा सकते हैं कि पेशेंट के दांत बराबर नहीं मिले और कहीं कहीं हड्डी फ्रैक्चर है. एक क्लू दे सकते हैं उनको जो इजीली वो सीख सकते हैं. फोर्थ थिंग्स हम ये बता सकते हैं कहीं भी नाक टेढ़ा हो गया, कहीं भी डिप्रेशन हो गया है कुछ भी फेस में, तो हम एक सस्पेक्ट कर सकते हैं जॉ के अलावा भी कुछ फेशियल बोन फ्रैक्चर होगी. तो 2 आइडेंटिफिकेशन के लिए हम उनको ट्रेन कर सकते हैं, जो इजीली एक लेमैन भी कर सकता है, एमबीबीएस तो इजीली कर सकता है.
तो हम ये वहां से ये एड्रेस करेंगे आइदर दी पेशेंट का यदि कॉन्शियस लेवल कम है तो हम उनको बोलेंगे कि अकॉर्डिंग टू एबीसी चलना है, एडीजी सस्पेक्ट हो सकता है, उसका जीसीएस कम है, सर ने जो बताया उसके अकॉर्डिंग उसको मे भी इंटूबेट करना है, इंटूबेट नहीं कर पाए तो एलए में मास्क डाल के उसको जल्दी से जहां भी फैसिलिटी है जहां कोई इंटूबेट कर सके वहां ले जाया जाए। तो वहां से हम ये कर सकते हैं। यदि सीएससी लेवल पे कई बार डेंटिस्ट भी अवेलेबल होता है, इवन मैक्सिलोफेशियल भी अवेलेबल होता है। यदि उस केस में मैक्सिलोफेशियल या डेंटिस्ट अवेलेबल है या फिर कई बार शायद प्लास्टिक सर्जन भी कहीं कहीं पोस्टेड होते हैं डिस्ट्रिक्ट हॉस्पिटल में, तो वो हम ये एड्रेस करेंगे हु आर द प्रेजेंट इन दिस टीम, आइदर डेंटिस्ट, आइदर मैक्सिलोफेशियल, आइदर प्लास्टिक सर्जन, दे शुड इनका रिव्यू करा सकते हैं। क्योंकि एट द डेस्क में तो आई थिंक जो फिजिशियन होता है इमरजेंसी में उसमें डायरेक्ट वो नहीं बैठे होंगे, ना प्लास्टिक सर्जन बैठा होगा ना डेंटिस्ट बैठा होगा, तो वहां में इंटरनल रेफर होना चाहिए, इंटरनल कंसल्टेशन जरूर कराएं जब भी कुछ फेस में इंजरी है, जब भी कुछ वेडे इंजरी है, ये कर सकते हैं। दूसरे हमने कुछ रेड फ्लैग बताया, वो डॉक्टर राहुल बताया कि कब सीएससी और सीएससी से पेशेंट को हमें आगे ले जाना चाहिए, उसके बारे में डॉक्टर राहुल विल एक्सप्लेन।
Yes, he can take.
Yes. I forget to mention. I forget. Yes, right point. Then sir, we will also like this. Even orthopedics in animal, sir. Even in the maxillofacial branch is the orthopedic. It is some from orthopedics से निकली है। पहले सब joint में सब orthopedics में, उसके बाद में
We have to look at the following red flag signs in the patient with suspected maxillofacial trauma. कोई भी पेशेंट जिसका जीसीएस लो है और जिसमें आप सस्पेक्ट कर रहे हैं कि हेड इंजरी है, उसको आपको रेफर करना है। कोई भी मैक्सिलोफेशियल ट्रॉमा का पेशेंट जिसको एसोसिएटेड अदर इंजरीज हैं ऑफ द बॉडी लाइक ऑर्थोपेडिक ट्रॉमा, चेस्ट ट्रॉमा, एब्डोमिनल ट्रॉमा, यू हैव टू रेफर टू अ हायर सेंटर। Any suspected, any patient who is having a facial wound which is exposed and the bones are exposed, you have to refer. Any patient in which there is facial or skull trauma, in which there is a loss of tissue, like there is exposed bone, तो मैंने पिछले पॉइंट में बोल ही दिया, जिसमें loss of tissue उसको भी आपको रेफर करना है। Any patient which is having the penfacial fracture, means there are multiple bony fracture of the facial skeleton, उसको आपको करना है, और that the patient is unable to open his jaw or close jaw, then you have to refer the patient. कोई भी पेशेंट के फेस से वुंड से कहीं भी कंटिन्यूअस डिस्चार्ज हो रहा है या ब्लीडिंग हो रहा है फ्रॉम द नोज, ईयर, माउथ, यू हैव टू रेफर द पेशेंट. Any patient which is having a direct ophthalmic injury, Dr. Vidyavan will explain about the ocular injury. We have to अपना रेफर करना है पेशेंट्स को. किसी भी पेशेंट में जिसमें भी आप सस्पेक्ट कर रहे हैं डेंटल और मैक्सिलोफेशियल ट्रॉमा और आपको लग रहा है कि यहाँ पे उसकी प्रॉपर केयर नहीं हो पाएगी, you have to refer the patient to the higher center. During the transportation of this patient, following points should be and must be taken care of. That we have to always call and inform the team to whom we are sending the patient on priority basis. Keep the patient on oxygen mask, possibly with intubation or ventilator, which of the things are available in the ambulance. Always escort the patients with a medical professional guy like a nurse or a doctor, which can be able to monitor the patient while escorting. If you are suspecting that the patient is not in a good GCS condition, then we have to administer Ray's tube or a Foley's catheterization should be done, and continuous monitoring of the patient vitals should be necessary. And we have to give intravenous fluid like normal saline or ringer nitrate, whichever is indicated, at a maintenance dose, and always try to refer the patient with proper documentation on all the investigation to the referral center, so that the referral team don't waste any time and they treat the patient accordingly. Thank you.
Actually, any maxillofacial modulated trauma, penfacial, should be intubated if possible at least 5 minutes at one time. It should be, because even GCS very high, because bleeding की वजह से वो aspiration वगैरह कर सकता है. These things in the right time.
Now I invite Dr. Vidyavan to
any input.
it down and maybe orange. The patient color behind the color
So, if we have a patient with ocular trauma, as we have discussed, first of all, we have to take vitals and we have to explain at the PhD level and CSC level. First, try to save life, then focus on the eye. So, if there is ocular trauma, first we have to take quick history and initial assessment. In quick history, we can assess, document about the signs and symptoms of the patient. In the symptoms, we can ask about the eye pain, tearing, photophobia, foreign body sensation. We should take medical history, allergy history, and in injury cases, we should take thickness history also. And after that, we have to do initial assessment as well. First, we have to check visual acuity. Then inspect the periorbital tissue thoroughly, eyelid examination, then open the eyelid and check the red reflex pupillary reactions. Then we have to ask about the diplopia, extraocular movement, and evaluation of anterior surface of the eye for the corneal tear. Slit lamp examination. If slit lamp is available at the district level or CSC level, we can do slit lamp examination. Intraocular pressure, we can assess if NCT is available there. If not available, further we have to refer the patient, and we have to if at the district level we can do direct ophthalmoscopy to evaluate posterior segment of the eye, and if there is a trauma case, we should consider bedside ultrasound, B scan we can do, and if there is a CT scan available, we should do CT scan for trauma cases to rule out any foreign body, and contraindication is MRI as if there until we rule out any metallic foreign body, we should take a picture of the trauma at whatever the level, PSC level or community level. So further, we can realize what is the status at the first presentation. And further, then we have to decide if there is eyelid trauma, we can suture at the CSC or district level eyelid trauma. But if there is a marginal tear, tarsal plate tear, or at the laceration, canalicular laceration, then further we have to refer for the further repair. And if there is a tear due to the dog bite, cat bite, so first at the PSC level, we should do copious irrigation of the wound. We have to update tetanus immunization and rabies immunization, and prophylactic antibiotic we should have to prescribe. And for eye, we have to always prescribe antibiotic eye drops and lubricating eye drops. If there is eyelid burn, we have to prescribe topical and systemic antibiotic and topical lubricating eye drops always. And if there is an orbital trauma case, then we have to, if we suspect about the orbital fracture, we have to advise CT scan and consultation with the neurosurgery and maxillofacial surgeon. We have to refer for the same. And if there is orbital hemorrhage, CT scan should be done, and IOP assessment with the NCT, non-contact tonometer. And vision, if there we suspect any diminution of the vision or vision loss, there may be papilledema occur, there may be optic nerve compression may occur there. So we have to give IV steroid under supervision and acetazolamide to decrease IOP, and urgent referral for the further management. If there is we are suspecting orbital foreign body, so CT scan we should do. Again, MRI on contraindicated until we rule out metallic foreign body. And further, we have to refer in higher center for wound exploration. And if there is mechanical injury of the globe, like penetrating trauma or ruptured globe, penetrating globe injury, always we have to refer higher center. If there is a non-penetrating trauma, abrasion like corneal abrasion, foreign body laceration, linear laceration, edema, blowout fractures, or if we are suspecting any foreign body, we have to leave embedded foreign body there if it is deep. If there is superficial foreign body or slit lamp is available, then we can remove at that district level. We have to prescribe at the trauma case antibiotic eye drops, mainly broad spectrum chloramphenicol or ciprofloxacin eye drops too early, and antibiotic IOIMS. And we should do eye patching if there is a mild corneal erosions or so in 1 day 24 hours patching with the lubricating eye drop and antibiotic eye drop, we can heal it. And systemic analgesic, antiemetic, symptomatic, and supportive treatment always we have to prescribe. And in case of the injury from the organic material like vegetative material, there may be fungal infections. So we also should also prescribe antifungal, systemic, and topical medications. We should avoid steroid eye drops if we are suspecting infectious cases. But if there is a if there is a sterile inflammation, we have to prescribe steroid, like in high fever cases, or in if there is a contusion injury without infection suspect, so we can prescribe steroid, systemic, and topical eye drops. We should always update about the tetanus immunization. When we refer, we should apply eye shields and immediate referral to ophthalmologist for further management. If there is chemical injury, acid burn like battery fluid and chemical lab solution, and we have to do irrigation. In alkaline burn, it is more dangerous than the acid burn as it penetrates deeply, like tuna injury or a cement cleaner, drain cleaner injuries. So always we have to refer, but initial at the PSC level and district level, we have to do eye irrigation with the normal saline or ringer lactate until pH is not normal, and means pH is 7. So to test the pH, we can use litmus paper, and then further we have to urgent refer to higher center for further management. So there are some indication for urgent referral if there is globe rupture, if patient is unable to open the eyes and we are suspecting globe rupture. If there is visual disturbance related to ocular trauma and high FEMA, if there is extraocular movement disturbance and patient is complaining about the diplopia and foreign body, if we are not able to remove them, then we have to refer. If there is absent red reflex, means there is a posterior segment injury like vitreous hemorrhage, retinal detachment, etc. So we have to further refer. If there is we are suspecting papilledema or optic nerve compression, so we have to refer. If there is a retinal hemorrhage we are suspecting, then we have to urgent do refer. Thank you.
Well, sir, I think Madam has provided a comprehensive background. So I would like to request whether this is okay or we have to modify and take notes.
Our first thing is to maintain that. Secondly, prevent the infection. We have to taught them to handle the situation. Secondly, in chemical injuries, as you said, that we have to inform that we have to learn, irrigate with the normal saline and oak milk जो होता है हुआ तो बहुत इंजरीज मिलती है फार्मर्स में लोगों में. सेकेंडली अभी जो है होली के समय काफी इंजरीज बैलून का इसका मिलता है. Our aim is to maintain to prevent the infection in the radicals.
Slides are fine. Thank you. Next thing is something. So this is for an open fracture. Why I am having, because very commonly patients will come from this level, even page, all sorts of grass, dirt, bone, dangling out, stones, etc. The ABC of resuscitation is going to be the key step, first step. So once the patient has come, either from a roadside injury or from a direct impact, fall, or as told in the morning by Dr. Prabhakar, farm injuries, which are very common. So if there is clinical features of any fracture, we first stabilize the patient, then we address the limb. And if there is an obvious wound, we have to ensure that the person who is dealing is not getting distracted. So after we have found that there is a wound, we have to recognize that there might be an open fracture. So then we have to provide some description of the wound, whether there is the bone which is poked out, size, whether there are any pulses, vascular injury, or if there is contamination with different type of contaminants. At that time, the aim, once the patient is hemodynamically okay, we control the bleeding. Second important thing is washing of the wound, which is invariably lacking in the peripheral centers. And then the patient, after washing, we apply a saline soaked sterile gauze dressing and administer whatever antibiotic is available. We are not at present discussing what should be the ideal way, but yes, whatever antibiotic is available, plus analgesic tetanus prophylaxis, followed by splintage of limb, and then refer the patient in appropriate manner to a center where there is a specialist. So suppose if there is a CNC, like Dr. Sumit also told, that if there is specialist care is required and the CNC no specialist is there, and it is known to the person in that area, so they must be made aware, then they have to directly send to a district hospital. Then the X-rays investigations are to be done at the facility if there is a specialist available, instead of wasting time in between for getting different X-rays and investigations. Rather, take to the facility where a specialist is there, and then CT scan, instead of being, because we came to know recently that there are PPP model CT machines set up in different district hospitals, and that many times people are asking for CTs without actually requiring, actually needing that. So we have to emphasize at all levels that the decision for a CT has to be that of a specialist, not any MO. The specialist has to take the call. And after that, we have to continue the different management. The management is not going to stop. Once the patient even reaches at the specialist level, the dressing, IV fluid and antibiotic change plus splintage needs to continue. In between, what is important is that we have to emphasize the don'ts at the PHC level. Importantly, we should not, because we have said wash, that does not mean that you use running water or any other water which is able to wash. And tight bandages have to be available, and the transfer should not be without a proper splintage. After that, once we have specialist available, the specialist is capable enough to take care of the management as per the protocols available. So we let the decision at the level of specialist, either CHC, DHC, DH hospital. In case there are issues, primarily requiring super specialist care, especially a vascular surgeon or a plastic surgery team for coverage, or if the fracture is such bad that the level of expertise required is probably not there, then in that scenario, instead of wasting time, once we have ensured the splintage and other management, we can refer the patient. So this is the overall snapshot which I thought could be there for managing open fractures. So Kamlesh sir.
And it's a very comprehensive and very good chart. 4 seconds.
Yes.
The next slide so far covers everything in a flowchart manner, also gives us a red box, says don't do this. I think this should be the role model for all the slides that we need. Whatever we have covered, not to say that they were not good, something that a person at each level can actually understand. Follow the arrows. From here you go here. This is the red box. Don't do this. This is how we go ahead. Let us try and make slide all the levels, like A, B, everything in this manner. The referral slide.
First thing that we've already discussed throughout this session is about saving life and saving limb, right? Once this is done, I will be focusing on isolated injuries in the limbs, the upper limb and the lower limb, especially the upper limb in children. So when we have a child with a limb injury who presents to any health center, whether it's the primary health center or the CHC or any private sector, first is it is important that there's a lot of soft skills that is involved in evaluating a child. And it is very important that we are able to determine where the injury is and how severe the injury is. And that is why I put reference numbers, because I had made a small Word document which I have not attached, which will help in determining where the injury is. So if the child is of talking age, more than 2 years age or 3 years age, no, if we first is to make the child comfortable, the child stops crying, and then we ask the child, "बेटा ये बताओ चोट कहाँ लगी?" he will pinpoint exactly where the injury is. Because the common symptom is the child is not moving the upper limb. Lower limb mein to chalo, he is not walking, he is not standing, that is there. But for the upper limb, he is not moving the upper limb. But where is the injury? We don't. So that is one of the most important pointing features. Then we move forward and come to all the classical signs of injuries or fractures, the deformity and all. So the clinical evaluation and the soft skill is very important, and that needs to be propagated down. Then we go for the X-ray of the isolated part where we have determined the injury is supposed to be, and then we make a diagnosis, right? So secondly is pediatric orthopedics is now a super specialized branch which is now taking birth from orthopedics, and we need to understand that they have special needs, and there are special treatment. There are different treatment methods for different conditions. So once all these children have to be seen by an orthopedic surgeon. So whichever is the first point of contact with the orthopedic surgeon, the child has to reach there, and when the child has to reach, he should be splinted. For transportation, splintage is very important. And for splintage, I have mentioned POP slabs, wooden splints, or cardboard splints. So if the person is not trained or not comfortable using plaster of Paris, maybe he can use a wooden splint. If wooden splints are not available, each center has cardboard. That is for sure, because all saline bottles, every equipment is transported to the hospital in cardboards. Wherever I had any problem securing plaster of Paris or wood, I have always used cardboard splints. And the best part of cardboard splints are they are rigid. You hardly ever end up in a tight bandage, right? So, use of cardboard splints can always be advocated. And once the child is seen by an orthopedic surgeon, he has to determine whether this child can be treated by him, or the facility is available. Even if the surgeon is proficient, many times there are anesthetic concerns and other concerns related to children and their post-op care at district level. So whenever such concerns exist, they should be referred to the medical colleges. And in the red flag signs, I have listed very specific concerns that should be referred to medical colleges, I believe. Those are any open fracture. Secondly, any neurological deficit or vascular deficit, because expert level care is required. Reconstructive care might be required because that can be limb preserving, limb saving. Secondly, compartment syndrome. To identify compartment syndrome in a child is a little different from identifying a compartment syndrome in an adult. And again, soft skills come in there. Has to be identified because the sequelae of a compartment syndrome are horrible. There is permanent disability or loss of. So compartment syndrome needs to be identified, and the child or the patient needs to be treated at the earliest to resolve it. Then coming to physical injuries, fracture dislocations, and trash lesions. So physical injury is again an injury that needs an expert level of care. It can be treated, all fractures will unite, but the burden of disability which we are going to send into the society, that has to be taken into consideration. If the child is not referred to an expert level care at this point, he will eventually turn up to the expert level care later on. But the results of surgery and the results of treatment will never be the same. And instead of requiring one surgery, he will end up with 1, 2, 3, or I don't know how many reconstructive surgeries with very poor outcomes. So maybe some injuries like these, like the physical injuries or fracture dislocations, will very easily get missed, especially injuries around the elbow. Because in children, the ossification centers of the elbow are so diverse, they are so different for different age groups that it is very difficult to even identify the injuries. Then the trash lesions come there, right? You get an X-ray done, X-ray looks okay, but the child is not moving the limb. The symptoms are so severe that he is crying, he is not, there's a lot of stiffness that is developing. So these are the injuries I think that we should not miss. These are the patients that should be identified and referred to higher centers so that we are able to catch these injuries and make sure that we send as little disability into our growing young population as possible. Thank you. If there's any comments or any advice on this, please.
So we have discussed these few conditions. Plan is to in the next probably the next intermediate meeting to develop other specific conditions, especially if there is a thoracic trauma. Then probably that will start not from the PHC level, but rather PHC and DH level, because that will be from a super specialty point of view, something related to cardiothoracic surgery, even your urology. So this is what after this, the last two important slides. So this is what Dr. Amit came up with while going through different referral protocols, and that whenever we are referring a patient, then these at least these should be the minimum required details which must be provided. So if the panel thinks that these are okay, or if you have to add some more other relevant information before referral. So the common thing is that ABC S bar. So after this evaluation, the S bar stands for situation, background, assessment. So this is what is to be. If the panel thinks that this we are missing out on something for the referral detail. So the referral form we are proposing to make one referral form. Then probably that will help in either, like there were concerns from even the private sector. So probably the same referral form can be used not only by the PHC, CSC, but rather the private sector also. So the last slide will be, yes.
This form can be added to each website.
Yes, yes, definitely. Definitely. So
everybody will see that.
yes, correct. Yes. So that information can be disseminated through different social media platforms, and the referral form can be uploaded. So we'll try to get it done through the channel, proper channel for the website. Dr. Babulal is here, so he is the website in charge also. So I think Dr. Amit can directly provide the referral form. We can, as a panel members, we can vet the referral form, and that can be uploaded on the website. So in the end, so these are the few things which have been asked for by the organizing committee, that what are the next steps. So this is what I have written from what I could gather. I would like the experts to please add on to these. And the recommendations, I have added the suggestion provided by ma'am about the checklist. They have also shared a checklist with me just now. So I will share the checklist with my other colleagues, and we can get it modified accordingly. And like Dr. Amit pointed out, the implementation of Good Samaritan law, which we all theoretically know, but practically nobody follows. So probably that needs to be taken into consideration. And last but not the least, the closed loop referral system, where you inform the proper referral detail, and then you have to also contact the expected hospital where you are actually going to refer. So if I may just give one example, so people were talking about something related to maternal and child health. So I was resident in PGI Chandigarh. My wife was doing senior residency there, and then they had a strict referral policy for gynae patients. I'm not talking about orthopedics. So if a gynae patient was referred without a prior phone call or without prior details, they can simply call back, shout at them, and rather even inform their superiors that the referral is not happened. So the referral policy, because it was strict, and this was at the tertiary level, so gradually it percolated down very well. And in there, most of the patients were well informed. The doctors were well informed about the situation before referral. So some basic homework could be done, especially arranging blood and all. So this is about closed loop referral system. Now I will invite the experts to suggest what can be the next step for this panel for furthering the concept of one state, one health, and about the recommendations. Dr. Kamlesh, sir, please. Yes, sir, Dr. Lalit, please.
मेनली अभी जो हम लोग देख रहे हैं आउट ऑफ द रिकॉर्ड की बात करें, जो डॉक्टर्स ट्यूशन करके आ रहे हैं, हम सबको पता है कि प्राइवेट कॉलेज में क्या स्टाफ नहीं है। हमारे हॉस्पिटल्स में जो अभी कॉन्ट्रैक्चुअल जो आते हैं डॉक्टर्स, अब ये सरकार की पॉलिसी में कैसे हम उसको इंडेक्ट कर रहे हैं, ये मिनिस्टर लेवल की बात है। उनका एक ट्रेनिंग प्रोग्राम आपके इंस्टीट्यूट में हमारे मेडिकल राइट टू ज्वाइन देयर सर्विस करते हैं। उस पब्लिक प्रेशर बहुत है, पॉलिटिकल प्रेशर बहुत रहता है, जो भी इंजरी जाते हैं इससे जाते हैं असिस्टेशन वगैरह काफ़ी बहुत प्रॉब्लम्स है। अगर मजबूरी में वहाँ नौकरी करते हो रहती है यहाँ से कि मेरे सिर पर बात ना आ जाए, फिर कोर्ट में भी उनकी बहुत नॉलेज का डेफिशिएंट और सिचुएशन से डरते हैं। बहुत ही प्रैक्टिकल एस्पेक्ट है, उसको हमें डेलीकेटली टैकल करना चीज ठीक हो जाती है। तो अगर हमारा पूरा ये जो बनाया है इसको हम इम्प्लीमेंट कर पाएंगे। बहुत हमने जो पेरिफेरल प्रॉब्लम देखी है हमारा, मतलब ऐसे डॉक्टर्स भी वहाँ पे हैं कुछ अच्छे जो काम तो बहुत अच्छा करते हैं, सिचुएशन इतनी awkward होती है कि उन्होंने वहाँ से नौकरी छोड़ के एनाटॉमी फिजियोलॉजी वगैरह वहाँ, हालांकि सीन पहले से इतना नहीं है डिमोरलाइज करना। ये जो नया स्टाफ आ रहा है ट्रेनिंग मॉड्यूल बना भोपाल के कॉलेज जैसे हैं जिसमें और पेशेंट्स ही नहीं है, टीचिंग स्टाफ ही नहीं है। एक लड़की दतिया मेडिकल कॉलेज गई, गवर्नमेंट मेडिकल कॉलेज, डॉक्टरेट पैथोलॉजी के सर वहाँ को एक वो भी इंटॉक्सिकेट। मैं वहाँ कहता करूँ पापा आप बेटा ज्वाइन कर लो, करते हैं। फिर हमने उनको मिनिस्टर दे दिया था कि ऐसी चाहिए। मैंने कहा डॉक्टर नहीं बनते, धीरे धीरे टेस्ट हुआ, चीजें नहीं हमारी मैंने कहा फिर मेडिकल कॉलेज में क्यों क्या है का जो कोई हाल है। ये हमें ठीक है, वो एक अलग पार्ट, हम नहीं कुछ कर सकते। जो बच्चे उनको रिक्रूट करते हैं जॉब में, उनका ट्रेनिंग मॉड्यूल एम्स में या गांधी मेडिकल जो भी कंसर्निंग टर्शियरी केयर हॉस्पिटल्स हैं उनको तभी हमारा पूरा सिस्टम उसमें लाए हैं। हाँ बहुत जरूरी, कुछ बहुत अच्छे हैं, काफी 20% बहुत अच्छे हैं, 80% बहुत गड़बड़ है।
कंपल्सरी एक छोटा सा एक कैजुअल कोर्स
आगे let us see what is in the unit. Let us see हम कैसे क्या कर सकते हैं। इन जगह और उस करके कार्डबोर्ड है तो ऐसे घूमना है, ऐसे बांधना है, ये पीएससी अब कुछ भी आ जाता है यहाँ तो सब आप यहाँ बैठ के बोल आखिर यहाँ से ये अपनी टीम को
ज़्यादा बेनिफिशियल बायलैटरल होगी बात जैसे both of the things are quite agreeable. एक तो जैसे हम एमबीबीएस में आजकल इंडक्शन प्रोग्राम कर रहे हैं, वैसे ही नौकरी का इंडक्शन प्रोग्राम प्लस क्या क्या डेफिशिएंसीज मिली, मॉर्निंग हाफ आपने रख लिया कि डेफिशिएंसी के लिए, सेकंड हाफ आपने ट्रेनिंग के लिए, प्रोबेबली दोनों को मिक्स एंड मैच कर लिया। नहीं वही बता रहा ना, आप हर साल नहीं कर रहे हो, आप तो हर साल 2 साल में यू आर मेकिंग ए सरप्राइज विजिट जैसे होता है, तो मल्टीपल टीम करना पड़ेगा उसमें। इसमें हम पहले इम्पोर्ट टू सीएससी हम उनको ट्रेनिंग देंगे, मॉडल बना के हमारा हैंड्स पर सब हमें पीएससी को पीएससी का काम को करना है, सो दैट वी विल अरे तो 500 पीएससी का ऑर्डर नहीं करना, ये all empower we will only empower the expert at CSC and DA, हमारा पीएससी का हमारा काम वो जाएंगे पीएससी सो दैट ऐसे मॉड्यूल अपने सॉल्व करते हैं तो ये विजिबल लगता है ऐसा हमने एनएसएफ में 10 कोर्स करवा दिए करवाने में फिर 2 इयर्स 10 में 10 के हमने 20 यूनिवर्सिटी को आइडेंटिफाई किया और उसमें हम बीएलएस भी सिखाते हैं एसीएलएस भी सिखाते हैं 3 दिन का कोर्स होता है कंप्लीट इवन उसमें 4 और 5 के नर्सिंग के साथ बाकी सब
I'm very much agreeing with Dr. Babulal, but I would also like to say that जब वो आता है वो एक चीज में निकाल देता है then probably
the field needs to be somehow tackled. हम ये नहीं कह रहे कि एम्स की टीम जा रही है. We are thinking in the line of tertiary care, all medical colleges and AIIMS all together. ऐसा थोड़ी कि एम्स का डॉक्टर जा रहा है ऐसा नहीं है. But exactly, correct. तो आपने correct. Yes. Okay. So एक बात ये हुआ था कि ट्रेनिंग तो करा देते हैं but we are not evaluating this. follow what एक important point है जो ये चीज है जो फीडबैक वाली बात है प्रोबेबली उसको हम एक बार तो नहीं कर सकते प्रोबेबली ओवर ए पीरियड ऑफ टाइम इसका जो पैटर्न है आपको अपना लाइसेंस रिन्यू करवाना पड़ता है इंडिया में वो आएगा अगर वो अपने आप ही आपको अपने आप को ट्रेन और अपडेटेड रखना पड़ेगा. I think we should conclude because now it is already 1:30. Proceed for lunch. I would like to thank everyone for the participation. I would request Dr. Sumit and rest of my team to escort the participants to the lunch area. I will just make minor modification because these recommendations have to be presented now. So I will make more changes in which. मैं बोल बताना एक अपन ना एक काम और कर सकते हैं ही मतलब फॉलो हम डिस्ट्रिक्ट हॉस्पिटल पीएचडी पे करा सकते हैं फॉलो जो ट्रॉमा पेशेंट का फॉलो पेशेंट यहाँ नहीं है छोटा मोटा स्विचर खुलवाना है ना ये चीज हमको रिकमेंडेशन है.
एक डॉक्टर प्रदीप मैं एक एडिशन देना चाहता था कि एवरी ईयर देयर इज दिस डॉक्टर प्रदीप तिवारी ने भी डिस्कस में बताया था कि देयर इज अ कोर्स नोन एज इंडक्शन कोर्स फॉर ऑल द मेडिकल ऑफिसर्स. Everybody has to go through that exam induction course in which they teach all of us finance और budgeting और दुनिया भर की चीजें बट उसमें मेडिकल पार्ट नहीं रहता. इसका अपन लोग आज जो भी ब्रेनस्टॉर्मिंग कर रहे हैं इसका अगर बढ़िया पीडीएफ बन जाए और वो पीडीएफ अपने में से कोई भी जैसा आपने कहा कि नॉट फ्रॉम द पीपल फ्रॉम एम्स एनी पर्सन हु इज ट्रेन्ड इन दिस एक्चुअली व्हाट द माइंड डजंट नो आई डजंट सी. और मैडम का जैसा कहना था कि प्रैक्टिकल अप्रोच बहुत जरूरी है ना. when I say you are there is a case of fracture humerus and you want to shift the patient to a center where he can be managed and you don't have any split, you are in a Registan, so what will you do? So no one knows कि उसको शरीर से भी बांधा जा सकता है, एक लोअर लिंब में उसको दूसरे लिंब से भी बांधा जा सकता है. तो ये चीजें क्या होता है जब हम बताते हैं तो सब वाले को समझ में आता है कि हाँ ये भी हो सकता है. तो इसका एक बहुत बढ़िया पीडीएफ बनना चाहिए और इसका एक कोर्स का मॉड्यूल बनना चाहिए. 1 घंटे का आधे घंटे का लेक्चर होना चाहिए और उसको इंक्लूड करना चाहिए गवर्नमेंट के इंडक्शन प्रोग्राम में एवरी ईयर. ये एकेडमी ऑफ एडमिनिस्ट्रेशन में होता है प्रोग्राम, उसमें ये क्लास होनी चाहिए.
जो पीडीएफ है वो डेफिनेटली बन रहा है रादर जो ये सिंगल पेज एल्गोरिथम इज गोइंग टू बी अकम्पनीड बाय टेक्स्ट फैसिलिटी. तो प्रपोजल यही है क्योंकि ये 2 वीक्स का ही टाइम था तो एसओपीज बने हुए हैं रिफाइनिंग फेज में. डेफिनेटली वो हमारे रिकमेंडेशन में आई विल ऐड टू दैट. उसके बाद फिर जो नेक्स्ट 2:30 पे मिलेंगे further request you to put this point further again for the entire.
Yes, sir. The list of essential equipment and medicine is also very important. Put in that video. हमको बताना आपके बेस में ये essential equipment होना चाहिए ये होना चाहिए ये भी एक निगम
child triple R. He told about this about 3 days back in the morning. And this is what is, I think, should be the gist, that we have to train people for proper recognition of the condition, proper resuscitation, and whatever level they are working at. That resuscitation level might vary. For a PHC level, it might be different. For a CHC level, it is different, and it should be different for district hospital. And then after that, it has to be referred properly. And this is what we also discussed about important algorithms. And these are the algorithms which we discussed, and they were active inputs from our subject experts. And based on those, we have actually thinking in line of recommended movement for trauma patients at different healthcare levels. So this is what we discussed, that not only is proper movement important, but medical legal documentation at proper level is also important, and ensuring that if a person requires some sort of surgery, then the nil oral status has to be maintained from a level where once he reaches that ideal location where he can be operated upon, he can be probably directly wheeled into the theatre rather than waiting for his NBM to get complete. So Dr. Amit brought about these details of how we should be teaching our staff as well as students about primary and secondary survey. These were based on the ATLS protocol, but we have tried to break it down into smaller pieces for the ease of understanding. And then the concept of along with that are 3 R's, one more R of red flags. At what time we should be referring the patient, and we should actually be knowing and judging about our own competencies and then referring at the appropriate time. So then Dr. Sumit actually came up with the details for head injury patient management. Again, the same concept of appropriate recognition, resuscitation, and referral. And that instead of, if the person we have already identified has a head injury, then instead of sending the patient to the next higher level, the idea should be to send the patient to the next higher level where you have appropriate specialists and care facilities. So if somebody is in the PHC level, he should not be sending the patient to CHC. Rather, if it is known that in that area, the neurosurgeon is available in medical college, the patient should ideally be directly referred to the medical college, not in between. So the transfer after proper stabilization is important. And Dr. Babulal and Dr. Rahul Dubepuria, they came up with the management protocol for maxillofacial injuries, again, which emphasized that the medical training, even the level of MBBS, the dental part should be in the form of a small capsule so that the Indian medical graduate is not afraid of dental components also. And that if and when required, they should be able to manage some component of dental injuries, because at present the two are completely different, the dentistry part and the medical education part. Then the ocular trauma aspect was detailed by Dr. Vidya, and she primarily brought about the aspect of injuries to the patients with blunt object, sharp object, as well as different type of burns with chemical objects. So the overall algorithm for this was prepared. So this open fracture algorithm was made by me, and this we actually emphasized as to how and when should a patient be referred, so that we don't leave a patient to be disabled for life. The same goes for pediatric injuries, which Dr. Saurabh made, and that appropriate at present the pediatric orthopedic fractures are also important to manage, because over a period of time pediatric orthopedics is developed into a super specialty subject, and Dr. Saurabh is the MCH in pediatric orthopedics. So he knows the challenges of how patients can have issues, especially young children who can be disabled for life. After this, we actually came out to this information that referral is important, and that referral has to be in the form of a closed loop. So we may say that yes, we have to refer, but how should we refer is important. And this know-how for referral is that we have to first stabilize the patient. Ideally, any patient who is unstable, not only hemodynamically, but from the perspective of airway and circulation, that patient should not be referred. So ideally, there should be some efforts made to stabilize the patient before referral. And once we have stabilized and referred, then these are the basic details that must be provided in the referral form. So these were the next expectation from the working group, that what were the next steps. So the next step was that we have to identify other pressing needs, those conditions which require further management.
Plus, we have to involve clinicians from all level of hospital for training outside of this room for implementation of this one state, one health protocols. Then the AIIMS team actually came up with these few recommendations, of which the second checklist recommendation was by Dr. Shahtas. Instead of just simply saying we have to refer in this pattern, we can create a checklist primarily in the form of yes and no, and that checklist has to be made available at different levels. That needs to be tailor-made for a PHC, CHC, DH, and medical college, and that the person who is expected at the level of PHC should be taking up the basic details for before the patient is shifted. Then the implementation of Good Samaritan law in the by furthering the information dissemination about this law among all the different people needs to be emphasized. Then finally, an important aspect is the referral system needs to be closed loop. That means even with the information, prior information needs to be provided as to when and how, where a patient is going to be referred, and the center where the patient is getting referred should be made aware before the patient is shifted. Something which Dr. Joshi in the morning emphasized regarding which happened during COVID times. So we believe that this referral mechanism not only should involve the PHC and CHC, but rather the private practitioner also, because if those who were present during the panel discussion, they must have heard about the issue raised by the practitioners regarding the non-uniformity of referral pattern. So this referral pattern needs to be strengthened, and this needs to be implemented all across the board. So our team of experts, they came up with few recommendations. Important thing was that we have to incorporate this concept of one state, one health module right at the time of induction of medical health services, those graduates and those postgraduates who are the inductees into the health services. Like it was told in the morning, that they actually have an induction session where they are taught about the administrative aspect. But I think it is important that we also incorporate the medical aspect. Second thing, a task force may be developed, and this task force should not exclusively be consisting of AIIMS, rather of other medical colleges also. So the task force should have the three mandate. One is to implement the training of the healthcare worker at their place of work. So this task force can visit the PHC, have an assessment of what their difficulties are at that level, and then train them. This can be a 1 day or 2 day session for the task force members. After that, we can the task force should also be involved in periodic assessment and feedback of the status of implementation of whatever one health, one state, and one health module has been implemented. Finally, appropriate remedial measures and reinforcements have to be intermittently and periodically intervened, because without this feedback reinforcement, the entire program will go into collapse. Last but not the least, we propose to upload a comprehensive checklist of the referral form, and also a checklist of what items have to be filled up after developing in AIIMS Bhopal, and I have requested Dr. Babulal to take it in this in his list of works. So these were the recommendations. I thank the experts, and I would like to ask the House for their opinion if we have missed out on something, or if there is something which they want to add on to it. Thank you very much.
Any feedback, any suggestion, or any correction that we will go ahead with the
This one or the first one? Yes. Okay, sir.
It's not only medical. We have to include all our training of high standards.
Okay.
So if there are conditions on that,
All agree?
एसओपी का इम्प्लीमेंटेशन के लिए कैसे अपन मॉनिटर करेंगे?
First, I think we will be selecting few selected centers. We do a pilot kind of thing, understand whether it is feasible to do it or not. If feasible, what all challenges they are facing, what all logistic requirements. Maybe to begin with, if we can validate all these models in all tertiary care and medical college, and step-wise we can scale our health will be better.
मैं कुछ इसमें ऐड करना चाहूँगा। मेडिकल ऑडिट होना चाहिए हर लेवल पे, वीकली, स्टेशन लेवल, एग्जामिनेशन लेवल, ट्रीटमेंट पार्ट, ठीक है, रेफरल पार्ट, ठीक है, पेशेंट कहाँ जा रहा है, टर्शियरी लेवल पे जा रहा है, प्राइवेट जा रहा है, सारी चीज पे, ड्राइवर कहाँ ले जा रहा है, ये ऑडिट होना चाहिए हर एक प्रत्येक डिपार्टमेंट में, ठीक है, और काउंसलिंग भी होना चाहिए कि कहाँ कमी आ रही है, सुबह कम्युनिकेशन से।
We can take into geospatial thing conclusions. We can do live monitoring where the patient is coming with. Even the ambulance has those. We can use that.
Thank you.
critical care. So a very good afternoon to all of you. Asked for the group to deal with emergencies and critical care. So first of all, I want to thank all my team, Dr. Pooja, Dr. Rashmi, who helped me in making these slides, and valuable feedback from Dr. Rishi, Dr. Sarika, Dr. Santosh, and most importantly, one of the names which is not mentioned, he specifically entered our group and gave us a very good suggestions. He is Dr. Sanjay Khare. He is presently joint director in hospital administration and has been a CMHO at Vidisha. So basically, he knows what is working at PHC, CHCs, and how these emergencies can be managed there. So, you know, the emergency spectrum, morning it was that the emergency phase hoti hai, अस्पताल की, and I think so Dr. Yunus is smiling, so he knows. So what we can't take all emergencies. So what basically we talk about chest pain, stroke, acute respiratory infection, snake bite, and poisoning. So what I have done is like, what can be done at district hospital, what can be done at CHC, what can be done at a PHC, and ultimately how the patient should be referred. So we discussed all these 4 or 5 algorithms, and then we have made a take-home slide. So as you can see, regarding the chest pain, so basically what we have focused on, it's basically MI. तो पहली चीज जैसे डॉक्टर संजय से बात हुई कि पीएचसी में क्या हम एमआई डायग्नोज भी कर पाएंगे, कहेंगे सर वहाँ ईसीजी मशीन ही नहीं होती है, फिर क्या करना है? तो पीएचसी में एस्पिरिन दी पेशेंट को नेक्स्ट आपने सेंटर में पीएचसी में ईसीजी मशीन मिल गई तो क्या ईसीजी को डायग्नोज कर पाएगा कि स्टेमी नॉन स्टेमी है? फिर वहाँ टेली आईसीयू, टेली कंसल्टेशन, कमांड सेंटर, फाइन। देन व्हाट एल्गोरिथम सेज कि अगर एमआई का पेशेंट है, डायग्नोज हो गया, तो पेशेंट शुड बी मैनेज्ड इन अ डिस्ट्रिक्ट हॉस्पिटल। फिर आया पीसीआई फैसिलिटी है या नहीं? पीसीआई तो किसी भी डिस्ट्रिक्ट हॉस्पिटल में नहीं है, मेडिकल कॉलेज में भी आई थिंक सो अभी प्रॉब्ली कमी मेडिकल कॉलेज हैं। सो थ्रोम्बोलिटिक्स का हमने ओपन एंड कर दिया, व्हाट द गवर्नमेंट सेज, इसमें क्योंकि स्ट्रेप्टोकाइनेस भी दे सकते हैं, आप टिश्यू प्लाज्मिन एक्टिवेटर्स भी दे सकते हैं, बट व्हाट वी फोकस ऑन की ईसीजी की एबिलिटी, एंटीप्लेटलेट्स की एबिलिटी एंड द ट्रांसफर ऑफ पेशेंट टू डिस्ट्रिक्ट हॉस्पिटल। स्ट्रोक वही कहानी है, स्ट्रोक पता कैसे चलेगा? इस्चेमिक हेमरेज है, सीटी स्कैनिंग नहीं होगा, कहानी खत्म। तो stroke should be managed in a case in a district hospital. At least CT scan ho, and luckily I think so they were saying कि stroke के now CT scans Vidisha hospital there are the CT scan available. उसमें उससे पहले आप PHC CHC में stroke के लिए क्या करना है? तो उसमें अभी वही जो fast algorithm है कि patient elevation, का आपने देख लिया, फिर timing of stroke देख लिया, slurring of speech, and sugar at least check हो गई, पेशेंट को लेफ्ट लेटरल डिकोबिटस कर दिया, एंड अगर सीजर्स आ रहे हैं तो इंसेट की वहां एंटीएपिलेप्टिक में मिडाजोलम और फेनिटोइन रहते हैं, तो ये 3-4 दवाएं होनी चाहिए। फिर हेमरेजिक स्ट्रोक के लिए अमित सर के पास आएगा पेशेंट, न्यूरोसर्जन, और अगर इस्केमिक स्ट्रोक है विंडो इट्स इंपॉर्टेंट वी हैव पुट इन एल्गोरिथम। हमें भी पता है कि 4:30 के अंदर कितने स्ट्रोक आते हैं, पेशेंट सो जाता है सुबह एक बार काम कर रहा है, पता ही नहीं चलता 4:30 से कितनी ऊपर हो चुकी है। तो दिस इज दीज आर प्रॉब्लम। स्ट्रोक में सबसे इंपॉर्टेंट है जहां सीटी स्कैन हो वहीं स्ट्रोक का मैनेजमेंट होना चाहिए। एक्यूट रेस्पिरेटरी इलनेस कोविड ने आई थिंक सो वी अडॉप्टेड द कोविड एल्गोरिथम, उसमें सिंपल रखा है। ओनली थिंग था कि रेस्पिरेटरी रेट का वो कितना रखना है, तो हमने क्या करा कि सैचुरेशन लेस देन 90 एंड रेस्पिरेटरी रेट मोर देन 24, पेशेंट हैज टू बी रेफर्ड टू अ हायर सेंटर, वहां बेसिक उसको ऑक्सीजन मिल जाए एंड एंटीबायोटिक्स मिल जाए। फिर उसमें डिबेट हुई कि बीटा लैक्टेन लेना है, एजिथ्रोमाइसिन, हमने कहा ओब्लिक डाल दिया जो व्हाट इज अवेलेबल। फिर हमें पता चला कि एमॉक्सिक्लेव एजिथ्रोमाइसिन इज अवेलेबल इन दोस सेंटर। Level 2 में जैसे X-ray is available, then at level 2 you can get a X-ray, and at level 3 at least the AVG should be done, monitoring in ICU and advanced respiratory support like mechanical ventilation. हर red flag signs जैसे डॉक्टर प्रतीक ने कहा for आपके निमोनिया के लिए हाइपोक्सिया, hypotension, confusion technique, the patient has to be referred to a level 3 center, that is district hospital. Snake bite again. PhD में आप स्नेक बाइट में क्या मैनेज कर सकते हो? ओनली थिंग इज यू कैन रिकॉग्नाइज दोस रेड फ्लैग साइंस। कोई स्नेक बाइट के पेशेंट को टोसिस हो रही है, वीकनेस हो रही है, कोई ब्लीड कर रहा है स्नेक बाइट का पेशेंट, सो और कंपार्टमेंट सिंड्रोम बन रहा है। आई थिंक सो डॉक्टर श्याम लाल इज आल्सो देयर, वी रिसीव लॉट ऑफ डॉक्टर अजीत इज देयर, सब कंपार्टमेंट सिंड्रोम के साथ आते हैं, सो दे हैव टू बी रेफर्ड टू लेवल 3 सेंटर। लेवल 2 के लिए आप लेवल 1 में आप एसी दे सकते हैं व्हिच इज नॉट हार्मफुल, लेवल 2 में एसी दे सकते हैं। फिर डिबेट था कि सर एसी के साथ रिएक्शन हो जाए, तो हम लोगों ने कहा कोई एक स्टेरॉइड और आप एंटी हिस्टामिनिक्स भी ऐड कर दीजिए। डायलिसिस की जरूरत है जो स्नेक बाइट में, दे हैव टू बी रेफर्ड टू लेवल 3। पॉइजनिंग इज अ ओपन एंडेड सब्जेक्ट। पॉइजनिंग में वी बेसिकली फोकस ऑन ओपी पॉइजनिंग, एंड चाहे पीएचसी हो, सीएचसी हो या डिस्ट्रिक्ट हॉस्पिटल हो, एबीसीडी हैज टू बी फॉलोड इन केसेस ऑफ पॉइजनिंग। यहां दो पॉइंट ऑफ कॉन्टेक्शन है, वेयर वी कैन डिबेट इज हमें गैस्ट्रिक लवाज कितनी देर में करनी चाहिए। आई थिंक सो पीएचसी इज नॉट सूटेड फॉर डूइंग गैस्ट्रिक लवाज। राइस ट्यूब कहां जा रही है, कौन चेक कर रहा है, कहीं और ही चली गई, फोर्स वॉमिटिंग शुड नॉट बी डन, तो वहां डोंट्स आ जाएंगे। लेवल 2 में गैस्ट्रिक लवाज अगर विद इन 4 आवर्स कैन बी, एंड एटलीस्ट ओपी पॉइजनिंग का टॉक्सिड्रोमी उनको सिखा दिया जाए, तो एटलीस्ट एट्रोपिन शुड बी गिवन। लेवल 3 basically mechanical ventilation and higher support. So what we have done is we have made a summary of all these algorithms. PHC में क्या करना है, CHC में क्या करना है, DH में stroke में recognition, CHC में it's recognition, check sugars, DH में you get a CT scan done. MI में अगर ECG हो जा रहा है तो get a ECG done, at least antiplatelets दे दो। CHC में भी again ECG recognition and at least antiplatelets दे दो, और DH में एक thrombolysis has to be there. हमें पता है अपने DH में अभी PCI centers नहीं है, so thrombolytics to be given. Acute respiratory infection at PHC or ambulance level, at least saturation, oxygen, antibiotics can be given. Same at CHC, and X-ray can be done. And at DH, you know, all these culture facilities, if available, blood investigations, chest X-ray, and all these high-flow NIVs are now available at each district hospital. Snake bite, again, recognition is important. Red lines are important. At PHC level, and ASV can be given. At CHC also the PSV can be given. And in DH, mechanical ventilation is needed for these patients. Poisoning, at least we can teach them toxidrome syndromes like sludge and all these things. At least they recognize, at least atropine, Lasix, these drugs should be there for dealing all these poisoning. You know, 90% of poisons के कोई antidote नहीं होता. It is basically the ABCD which works. Next slide, what we have done, sir, is like what availability of equipments we need for various next step and recommendations, as Dr. Avjit has pointed. Training of healthcare professionals, I think so, it has been focused since morning, train at all levels. Dr. Amit also added. And what we have done is availability of equipment and drugs at each of these facilities. Stroke है sir, at least PSC में glucometers हो, midazolam हो, anti-epileptic हो, CHC में glucometers हो, DH में at least CT scan हो, detector base की जगह we will do it tissue plasminogen activator, we will not be a drug specific. MI में at least PHC पे ECG, antiplatelets, heparins हो, CHC में at least ECG, यहाँ आपने thrombolytic agents, and one of the people of our group pointed like defibrillators should also be, at least AD should be there at PHC and CHC, and DH at least manual defibrillator should be there, and echocardiography machine should be available there. Regarding ARI, PHC में pulse oximeter तो हो, फिर तो saturation पता चलेगा, and then
azithromycin, augmentin, oxygen, they are available there. CSC पे at least chest X-ray. For DH, NIV, mechanical ventilation, ABG, CT scan ठीक है, वो अगर brain के लिए भी हो रहा है तो यहाँ भी use हो सकता है. For poisoning, at least at PSC, atropine, Lasix, oxygen, rice tube, palm, if available, and activated charcoal. Similarly at CHC and DH, at least mechanical ventilation and dialysis. Snake bite, we should have ASPs, able hydrocod. Similarly at CHC and district hospital facility for mechanical ventilation. So these are our recommendations which we have posed. Like these things could be asked for the state government to arrange these things, which will help in proper linkages of these emergencies. So this finished.
BLS program training should be all
Take done. Take. Good.
At least BLS.
Done. Take. Good point. Yes. What we missed, I think, so ambulance plays a very important role. जैसे कहा, so what we have done is PHC oblique ambulance ही कर दिया है कि at least ambulance should be fully equipped and at least उनको training होनी चाहिए. Good point.
The thing is, when we are discussing on the audience,
yes, sir.
Which we want that PSC people should do. Yes, sir. If you do audit, whether those audit signs patient had for how long,
okay,
we can make some anticipatory measures take in the community level, so we can further reduce the long-term rather than identifying like the transient is giving slow signs of patient weakness. If the high-risk group of patients, those who are not diabetic, they are aware of their signs, they can present early all levels of diabetes. Identification of snake, I think that is very important also. It's poisonous, not poisonous type of.
Doctor अभी की बात. So snake का identification हम तो नहीं कर पाते. Snake is snake बस.
That is the victim.
Warm good afternoon to everyone. So, on behalf of the General Medicine Group, I would like to thank all my colleagues who had participated in the preparation and the evaluation of the algorithms for general medical issues. So, the issue we had selected was actually febrile illness, and the second issue was a psychiatric disorder, which was taken under the guidance of Dr. Modak. So, first half I will discuss, and the second half on psychiatry will be discussed by Dr. Modak. So, so we had three objectives which were kept in the working group. One was the recommendation for treatment of acute undifferentiated fever for various levels of medical care. Second was for acute encephalitis syndrome, and third was for developing algorithm for recognizing and treating depression at various levels of community care. So basically we had only taken up two arms of the acute fever. So one was the acute undifferentiated fever. Basically we want to highlight in the algorithm that what group of patients of acute undifferentiated fever can be treated at the county level without being referred to higher centers empirically with minimum investigations. And second is a part of a syndromic fever, which is acute encephalitis syndrome, which invariably actually needs referral to higher centers. So then first, So we had for developing this algorithm, we had inputs from Dr. Joshi, Dr. Prashant, Dr. Sagar, and other members of my team. I'm thankful to all of them. So in this protocol, basically we just we want at a CSC, PSC level uh, what were the red flags associated with if associated with fever should be referred at a higher referral center, and if what are the comorbidities which should be kept in mind when a patient with fever comes for evaluation. So if those are there, then probably they should be referred to a higher center for further management. While if those are absent, uncomplicated acute undifferentiated fever should be managed on the flowchart as we have just displayed. So one of the things was unanimously agreed was that malaria should be ruled out in all the fever algorithms, even at the PHC level itself. And because other investigations for example, Vidal serology and, for example, serology for Scudder or Leptospira are even not available at the DS level. Some are only available at a referral center. So empirical management obviously has a role for acute indifferentiated fever. So I'm not going to details of the exact antibiotic protocols, but the theme was to enable maximum treatment of patients who are uncomplicated and to recognize the complication early and to refer them to higher centers. Second part was about the acute encephalitis syndrome, which actually in general terms implies acute onset fever with repeated sensory or a new onset seizure. So basically, we have submitted on this algorithm about the what are the mimics which can of this medical condition, and what should be done actually at the CSC and PSC level is the recognition of means hypoglycemia. First inspection should be done at PSC and CSC level where there should be where the hypoglycemia should be ruled out, and ABC we already know that should be stress, so airway circulation should be assessed first, and then if feasible, then IV access should be obtained, and if possible, then empiric treatment should be started for acute encephalitis syndrome, even at the CSC level. And second part was that what empirical antibiotics can be given and before referral. So as per the deliberation, we have considered that injection acyclovir and injection can be given stat before the obtaining an IV access before the patient is to be referred to a high center like DH or medical college. And basically we wanted to promote early empirical treatment at the PSC and CSC level and not directly referring the patient to DH without giving any first care, and not to lose time in because LP will be composition will be done only at the DS level or higher, and most will need some imaging. So very significant time should not be lost in just referring the patient. Some empirical treatment can be started, which might improve the prognosis in the long term. So thank you.
Thank you, Dr. Ingle. I'm very lucky that I have Dr. Naveen Kumar, eminent person in community psychiatry, wants to guide us as far as the depression guidelines are concerned. What we understood is that out of all these illnesses that has to be treated by the medical officer at the CHC or the PH, he doesn't really have time to recognize and treat depression. So we have tried to keep things as simple as possible. So as far as treatment for depression disorders goes, what we are recommending is that we use a 2-item scale called the PHQ-2, which is free of cost, accepted globally, with a time modifier to just screen as many people as possible for depression. And it's rather sensitive, quite sensitive, and only people who respond positively to that screen, the medical officer interviews the patient to diagnose depression. And then we have some red flag signs. severe illness, suicidality, catatonia. People with these red flag signs, they go to the higher levels, district hospital, district mental health program, wherever psychiatrists is available for better management. People who don't have these red flag signs, they can be treated on an outpatient basis. CHC. What we have also done is that we include educating the patient as well as the family members as part of the treatment protocol to ensure people continue to take the medications even after they become symptomatically better. And treatment response is based on single question assessment of whether the patient has improved on treatment. If the patient has improved with treatment, he continues the treatment at that level for 6 to 9 months. If the patient does not improve, again, patient goes to the higher. As far as the treatment modality is concerned, what we are recommending is that the primary health centers, they have all the medications that are recommended as far as the national list of essential medications go, which includes 3 SSRIs and one SNRI. And to deliver some low-intensity non-pharmacological management, it can be delivered either by the doctor or the telemedicine. Of course, this will involve certain other steps to be taken in the future, which we will discuss. I'll just read you. So, what our group felt is that every cadre of the health facility must have a fever clinic, and these fever clinic must be equipped with point-of-care tests and modalities for timely referral. For acute encephalitic syndromes at the BHC, early identification is important and timely referral to the higher levels of care. For as far as psychiatry is concerned, we already have a comprehensive telemanagement program by the government of India. What it's lacking is integration of this telemanagement with the physical facilities available. For all these illnesses, there must be practical implementable treatment and referral pathways to the various levels of care. Now, what our group also felt is that for delivering some of these treatments, there must be some additional training offered. This is particularly true for psychiatry, is in that people often have forgotten identification. So some institutes are there like AIIMS as well as the AIIMS, which offer online courses for refreshing those skills, and that must be made on a periodic basis. Right. So non-psychiatrist doctors particularly must be able to identify depression, and integration of the various facilities that are providing similar kinds of care. There must be an approach to deal with that effectively. Right. Thank you, and it's from the audience.
When we are discussing the thing, we should be able to have something once at the start of this program. Suppose some patient comes to the PHC or any level of contact, we see some patient, maybe stable. We should be able to tell in our guidelines, if you see certain, you can always come back and seek the medical attention again. Suppose an elderly patient comes to is conscious, but after some time develop vomiting or some other kind of thing. Somewhere we have to incorporate these findings to help all our colleagues to manage the condition and to avoid the litigations in future. When we are asking them to take more responsibility, little bit more education, I think all of the feedback will be important.
Sir, working group का यही understanding था that schizophrenia management must be done by a psychiatrist who If it is available at a PHC, it's fine. If it is not available, the at whatever level it's available. The initial treatment, continuity of care, that is allowed in the Ayushman Bharat.
To further into the in your algorithm identify whether the patient belongs to or if he has a component of schizophrenia. If what he is very clear, if there is a component of schizophrenia, if you tell that the patient doesn't belong to us and to the primary or first refer. I think that is a very pertinent question. What you have.
We will put it in the right place.
पेशेंट एग्रेसिव हो रहा है उसको कैसे रेफर करें? हाँ, उसके लिए बताइए।
What can we do to decrease his aggressive behavior?
कैसे क्या देंगे उसको पेशेंट को कैसे हम लोग साइकियाट्री के पास कैसे भेजें?
हाँ बहुत yeah, that thing that could be a totally different treatment algorithm that can be taken into consideration. Like what we are talking of stroke, we are talking of fever. Rather than we can tell that if an unconscious patient present to the PhD, same way we can tell if an aggressive patient present to the PhD, what is the algorithm to manage. So it's not only the schizophrenia. We are presuming that aggressive patient is it can be anything. That thing we have to further explore that possibility. He should not have some meningitis. He will also be aggressive. For withdrawal, he will be aggressive. That can be a totally unique algorithm.
Begin with this platform. These are the selected conditions. These groups will continue to work for next 1 year. So another condition would be added. Your condition which you are talking is a distinct condition. We have to develop a standard.
Share their conditions so we can further explore how to work on those things.
Yes, sir. And it's a separate condition.
The act, there are certain things that can be done in the community. All those things can be taken up in primary care. What we can do for psychiatric emergencies, that can be a different altogether. But nowhere in the this thing, the PhD doctor can actually diagnose schizophrenia. But the centers lower than PHCs, like for example, now the Ayushman Arogya Mandirs are there. They can't diagnose or newly prescribed medications. They are authorized to continue the drugs that are already prescribed by a doctor at the PhD. So the minimum level, public health care system level, where the person with mental illness can be diagnosed is the PhD. Thank you.
You. The team is diversified from the hospital, PSC, and and we have a plastic surgeons and the general surgeons. So we define conditions like acute abdominals, those coming to yes. These are the symptoms only 5 years to
is a algorithm is designed management of the patient. This algorithm can be a habit matrix, may not be. This preference can be localized, maybe generalized. This patient we have to manage according to localized preference. Life can be managed with the if it is available like DSC and patient responded, then we can say. If it is a generalized and patient unstable, at the primary center we can ask treatment like already. I2 should be started and this patient be at least minimally they can and such a patient that can be referred to the centers where this especially those who have like low peritonitis commonly having like and a primary level see X-ray which are these obstruction patient can be managed the treatment. They responded to treatment. And our pediatric surgeon in the pregnancy, after he has heard that the pediatric surgeon should, pediatric patient should be sent to health center after the resuscitation, then waiting for more than 24 hours at the PSCCS. So this is the one topic could have done. Next topic is the injury of the burn patient, which was a on college from the city hospital. And common burn injury are from the flame or fire burn, and second common is electric burn. So we took the commonest one, rest of like chemical burns. Yeah. So that is not so common. So in fire burn or flame burns, we have to like resuscitate the rescue the victim from the accident sites and stop the flame, covering the patient with the blankets or the water to stop the flame. And the cloth of the patient has to be removed. Remove if it is possible. If not possible, then we can leave the cloths. And to stop the further burning, we can ask the patient to hold down. So this way, at the site of scenario, we can stop this flame burn, further extension of the flame. Another cooling of the injuries area by the running water for at least 10 to 15 minutes. So this further ischemic damage can be avoided in the cooling by the cooling. We have to ask that at level primary center level we can cover the area of the pond by gas and apply the remove the dirt or food in the pond area and then transport the patient to the health center where the burn is as per the guidance which I will discuss later. In electric burn, as we know that electric burn, we have to turn off the electric supply prior to touching the victims. So, by the help of the insulated things like wood or rubber, check for other injuries because of fall. That reason that I have to check along with this. And check any difficulty in breathing and assess the severity of the for the treatment part assessment, primary as a for the treatment in case of other type of trauma victim, we consider same here also. The primary survey in the form of ABCD, E Act. In this way, A, B, C, D, E, particularly E for environmental where this happens, and F for food management. These two things are important in the primary survey assessment. Secondary survey, we have to look for the detailed history of how it happens to the patient and the head to toe physical examination of the patient, assessment of vitals, assessment depth of the burn as per the Alexander Bailey's rule of 9, and calculate the total percentage body weight body. You have to determine that. The treatment can be given at the level of the PSC and CSC, minimum at least analgesics and IV fluid if the patient is stable then oral. IV fluid has to be given in the department, mostly acceptable, and that this patient has to be monitored whether you not put that in. And these things easily can be done at the and patient can be started broad, and that can be here certain criteria how we have to transfer the patient to the primary center. The get the treatment facilities for one patient calculated. Like patient will have more than 10% body face area or in general partial thickness or full thickness more than 20%. Partial and full thickness one involving the particularly face, hands, feet, genitalia, perineum, or the major joints. So these patients are required special care. So they should electric one including lightning they have to be because the electric one can have cardiac problems, implications, and most of the time the electric one deep burns. So this cannot be assessed by the external appearance of the one. Okay? Most of the time they are deep burn. Chemical burns, yes, burn injury, so they have to be any listener injury, any burn patient with concomitant trauma because of the fall or fall of some heavy object over the patient, they can be or lesser burn with medical condition like they have to be managed. Panel says that in India scenario, little bit deviation like all pediatric burn patients, so we refer to the specialized burn center unit after the pregnancy. This is the recommendation for this discussion. Another scenario that is non-healing ulcer. Non-healing ulcer being designed with Moria, Dr. Sandeep Jain, GMC, and Prashant Chorachek. For this non-healing ulcer, we have to look at the history, duration of smoking, hypertension, or comorbidity in other diabetes. And the examination like site of ulcer, dry and whether it's dry or wet. Dry or wet, or distal pulsations of that ulcer site and the dilated pain in the protective. This is whether loss of sensation or. Then we have to see for the known or recent diagnosed diabetes, any ulcer because of the over the sole or foot and distal pulsation for it or not. So in this way, we can, on the basis of history, and we can diagnose diabetes or non-diabetes. And other thing for this ulcer can be patient can have a claudication, pain, with a longer duration with smoking, and also over the toes. And this can be in this way with loss of pulsation, peripheral pulsation. This we can exclude clinically. The patient might have a peripheral pulsation, particularly another ulcer like varicose ulcer, this can again be diagnosed clinically, and ST long standing work
and for the work. This the diabetic foot peripheral vascular disease and varicose vein common conditions for the healing ulcer. This can be diagnosed clinically easily. And rest of the things like traumatic ulcers, they can also diagnose with trauma. So then further it can be managed like diabetic foot has to be managed with at least wound care, plastic control, debridement. And then when we refer this patient having complications like not responding, patient develop osteoarthritis, patient need amputation, debridement, then he needs for the centers like the hospital. In peripheral arterial disease, patient initially pain in the without any ulcer. Then we can ask to stop the smoking, which is common cause. And then we can ask him to change in the lifestyle, and then only refer to the health center when there is ischemia further and awareness of gangrene. If this patient come to having gangrene presentation, we can be not particularly further diagnosis. And that is the two for final diagnosis. Varicose ulcer, generally they are also presented with ulcer. We have to tend to initial treatment is like conservative stoppings, antibiotics, and then we can check to higher centers where these are available. Next step in recommendation, as discussed in the panelists today, that we have to have a design continuous medical education for the in the CSC level. Regarding the management of disease commonly present their hospitals.
Then they do the abdominal side. First, you want to trial the patient based on the gender. Should have done with male and female. Male, then the is very important. Very important.
Yes, it is.
Very important. हमारे गांधी patient तो
certain points like non-recommendation, like I mentioned about this I mentioned renal colic and cholestasis, and figure point well taken like not like cholestasis, renal colic, and the over pregnancy, ovarian system, ovarian mass, prostate ovarian system. Thank you. Yes. Definitely, in case of varicose ulcer, we have to treat first ulcer rather than directly went to the varicose vein treatment. So, because it is some first that the complaint of the patient that it is ulcer starting. Okay. So, and we have to go for surgery at the limb also. So, we have to control the infection first. So, and in this way, there's a very patient respond also. So, before going for varicose vein treatment, we have to treat the varicose ulcer first to avoid further contamination. There are also respond very well with the patient. Follow the recommendation like avoid prolonged standing. They usually respond to. But patient already suffered without punishment by long standing, so now you definitely understand how this is. Patient who can understand this has to be treated for.
The discussion on ulcer is as
very advanced in our previous. It is difficult to pass. So it is very pertinent. Actually, what we are focusing, I think we are focusing on ulcer in the lower limbs. So again, the site of ulcer, the acuteness of ulcer, even the history of trauma doesn't mean that it is because of trauma. Trauma would have this is template. Please, I think more work. And if a chronic ulcer in PHC, whether is it worth to treat it there if a long standing ulcer, because we need to rule out many other conditions. It would be better if we focus on the more acute emergencies rather or follow-up cases where the dressing is required and more limb care is required. Very debatable issue.
For this topic, that these are the patients who can be treated properly. Because when they reach to the medical level, particularly in these two conditions, particularly in diabetic foot ulcer and the peripheral arterial disease, at the time of when they reach to the medical college, they have totally lost the limb. Patient might require amputation, particularly below knee, and maybe such a wound which cannot be managed by conservative means like debridement, antibiotics, all these. So, means think if there is such a condition is there, then as it is possible, we have to recognize it. That PSCCS level and send the patient to center. These things can you manage? Most of the time, their patients are neglected and sent it to us with the very bad.
If the patient is very long, we have to educate the patient that they should be only medical. Unless somebody is waiting for this more homework. The patient education, they should be able to detect that part of their limbs. We should educate them. We should not have this more.
Basically, the idea is that the patient didn't know how this can be such a things can spread or become problematic to the patient so early. These patients usually develop like limb threatening ulcer or limb condition.
But more thing others or individual trauma.
Yes, you were right. Since you are sitting in the ends, you can think about trauma. But if you were thinking like medical college, they are managed by the general surgeons, honestly. So that's why I took it.
Thinking for the one path. I need to many times what happens with the emergency patient come with the input, general surgery scene, plastic surgery scene, medicine scene, go home. Now patient go home in PSC. I think we should also sometimes follow up things and some reverse system will also should think this concept. So now what patient come to there. So what we have to identify with a good load from a tertiary center to the district hospital or other PSC level. कौन सा पेशेंट सिर्फ PSC लेवल पे ही थोड़ा और डिसीजन लेके तो भी काम चल जाए ड्रेसिंग से काम चल जाएगा या फिर कौन सा डिस्ट्रिक्ट वो भी
I think you were right. I think department of surgery anywhere, not only AIIMS, who is dealing with diabetic foot, none of the other persons. तो इतना दर्द है हमारे लिए कि we are most of the times doing amputation for pneumonia. These things can be avoidable when detected early. This is the only way to present the idea to present these things. We are doing most of the time amputations for the diabetic or for the disease. They can detect it too early at the level, primary, secondary level, send to the correct centers. They can manage. Limb can be saved.
different that can be the discussion the brainstorming. Focusing on acute care. All these questions, we are going to provoke all these questions in the first question. Will be more mature.
Thank you, sir. Go to the next. But before that, I just want to put one more army thing that on tertiary center, I'm just getting this patient refer from the one medical college
So just directly come to the aim. What is the meaning of that? We used to get from the from Liva, from even the DNC, we used to get this for a lot of patients work. But that also we need to some way kind of policy because this team is here and we make one working. Why they because we there the certificate center. So unnecessarily that patient come to us and just related to the justification, kind of care with what it is, but then also make it crowd. And just, I mean, the trend is just 120% of the increase in emergency attendance. This IPD, OPD, and everywhere the crowd is there. Just getting the medical therapy will happen, something will get and treat. तो ये भी कॉन्सेप्ट बदलना है, चीजों को बदलना है कि जो मेडिकल कॉलेज बाकी बन रहे हैं या हर किसी को बनाने वाले जिसके उपयोग बोल रहे हैं तो फायदा क्या है? तो देखिए एमसी बनाओ
No. Excuse me. Let me interrupt. This is not the mandate of today. Discussion. Let's go to the next.
On behalf of Working Group on Maternal Health, our group comprised the people from medical colleges, AIIMS, Gandhi Medical College, from District Hospital, Dr. Shraddha from District Hospital, Karchu Hospital, Bhopal, Dr. Sunita Kamble, who's traveled from Narmadapuram to be here, and Mrs. Nasima from Nursing College. The objectives we delineated were, we discussed 3 conditions basically to develop standard treatment algorithms, which is implementable at primary and secondary care settings in context of maternal health. In state of MP, for these 3 conditions, we had initially included fever with delivery also, but we have removed it for now because we could not discuss on that, as all other groups told us that we had a vibrant and long discussion, so we limited to these 3. And to involve the stakeholders as were involved today at all levels of healthcare delivery facilities in developing these algorithms, because they do the testing, whether it is acceptable and feasible for implementation at their level. And to emphasize the clinical criteria, because these settings are often limited by the resources, whether investigational or other supports. So clinical criteria are important, which is this thing for referring to next level facility, and very important. We had specially worked out the pre-referral treatment with overall focus on reducing maternal morbidity and mortality. So we have worked out paragraphs or the steps for before referring, and when you are referring, what are the things that the facility should do before sending to the next person. So when I discuss these conditions, my focus will not be on the specifics of what we are doing, but the approach that we have taken. So don't try and read those matter. If we want to read those matter, I can project a bigger picture. But largely what we have done is we've tried to define. We have tried to define here what is the entry point into the algorithm. So when we say anemia, that was, we defined it and accepted it as. And then we took it, once it is diagnosed, what is to be done at primary care level? What are the conditions in which it should be referred? For instance, we agreed that all severe anemia should not be handled. None of the severe anemia should be handled at primary care level. They should all go to secondary and higher. So that kind of diversion we did, and those which can be handled were specified. Then before such a patient or any referrals are sent, what are the things to be done by the primary care facility that we specifically mentioned? Then came the secondary level. What are the things that the secondary level facility can do? And what are the conditions in which they will refer to the next? Also, we built in here again, when secondary level refers to the tertiary level, what are the pre-treatment or pre-referral things they should do? And we specifically emphasized on counseling of the person and relatives and documentation of this thing during the referral, besides other things there. Also, we've inbuilt that in case a person of such a certain condition has to be referred. For example, severe anemia has to be referred, but at PHC, a severe anemia patient comes in labor with imminent delivery. So we've included a box on what should be done should you have to handle such a case. What are the things one can do? Coming to the commonalities of discussion, the points of brainstorming and discussion when we develop, all our protocols have been designed on a similar approach. And the points of discussion was, One was definition. For example, in anemia, the definitions WHO is 11, 10, 10 and first, second and third trimester. Now, do we want to create that divergence at PHC level or not? So after brainstorming, we agreed that we should keep one cutoff at 11. It should be simplified. Number two, when we say PHC, all PHCs, or when we say district hospital, all secondary level hospitals are not equal, neither in resources nor people. So we felt a big gap there because even though we say secondary level, all secondary levels are not equal. So we had to build in secondary levels with such facilities and secondary levels is not without those facilities. So functionality of the level becomes important. So a big amount of discussion was on that. Clarity of terms. Should we bring in the classical academic definitions or should we have working definitions? So we all sided on working definitions, which helps the medical officer, even the medical officer level, to take a decision whether at PHC or a CHC levels. So those were generally our approach. If we need to project a detail and go through the specifics, I can do that. Shall we move to the next, sir? Would you like us to go into detail of any of the algorithms? Okay. So next was hypertension in pregnancy, and again hypertension is a big academic topic when we talk in medical colleges. But one of the big things that we discussed was, should hypertension be handled at PHC level at all or not? So it was a bold thing to come to a consensus that every hypertensive patient must at least visit the secondary level facility. So we have written, refer all hypertensive patients to secondary level facility, because the lab investigational, which is a big part of clarifying what degree of damage has the hypertension done or to what degree it is advanced, is important. So they must at least be once evaluated. So we have come to a point where they refer all patients with hypertension to the next level. At the next level, if they are again found stable, normotensive, no need of antihypertensives after evaluation, they can be sent back for a follow-up. But anytime a BP is found high, they should be sent to the next facility. Similarly, at secondary level facility, while if there is a facility like in hospital in Bhopal, district hospitals are equipped with blood bank, specialists, anesthetists, ICU setups, then they can handle those conditions in the district hospital. But if these facilities are not available, all severe hypertensions, eclampsias, and anyone which is symptomatic for premonitory signs, which we classically say headache, visual blurring, epigastric discomfort, vomiting, those are there, then sent to the next level facility. Again, we have included a point that in case such a patient comes in labor to a lower facility, what are the things they can do? On similar lines, postpartum hemorrhage, the big discussion postpartum hemorrhage is often on definition. The classic definition of 500 ml doesn't work when one is taking the delivery. It is what hemoglobin patient started with, what hydration patient started with, and with whatever be the amount of blood loss. Is the patient deteriorating? Is the patient stable? Or is the patient taking it well? So sometimes it has to be a call of the person taking the delivery or present there to understand that this patient has had blood loss which is more than expected. So we have emphasized that don't go by the quantitative cutoffs. At primary care level, we have also referred to the essential drug list which has been circulated and provided for state of MP in 2020 by the NHM, and that is the key source. So Dr. Archana Mishra had guided us on that should be a good referral document before we plan out any therapeutics. And based on that, we feel a lot of medical management, specifically in atonic PPH, can happen. But at all times, we have emphasized that if it is not responding, don't take more than 15 minutes to 30 minutes at a primary care facility to look for the response. Refer. Anytime the patient is unstable, refer. But we have also spent we have clearly emphasized that when you're referring such a patient, what are the things they must do? Like starting IV line, keeping propped up, or depending on the blood pressure, flat or head low. Then, if a blood has been drawn, it is okay to draw the blood at primary care facility, even if you don't have the transfusion facility, and label it and give it. Because later, maybe sometimes even blood is not accessible for cross matching. So it is okay to draw that and give it. Oxygen has to be given. Uterotonic should be given. tamponade, packing, those measures have been delineated for primary care. At secondary level, whatever has not been handled at primary care, that means early referral, the delay in decision should not be there when to refer. So we've tried to delineate that. And any surgical intervention that might be needed. So some district hospitals are well equipped to handle surgical interventions. Suppose it happens during a cesarean section, anesthetists are there, setting is there, blood is available. Yes, they can proceed with some bit of surgical interventions for control of postpartum hemorrhage. Otherwise, it should be referred to the next facility. Again, a list of things to be done by the secondary level facility during referral and post-referral, including counseling and documentation, besides sending the patient as stable as possible. And if nothing is being done, at least packing tamponade should be done to contain the amount of bleed temporarily. Based on this, so our identification, one of the things we were pitted against were definitions and, more important, functionality map. All PHCs are not equal, all CHCs are not equal, all DH is not equal. So probably there has to be a functionality map of the various setups for maternal health in our state. They are countable and we should be able to have which facility is available where, so what part of the protocol applies to them. FRU training, first referral unit training, and EMOC, emergency obstetric care training, has been in vogue, but we must remember these are something which have to be revised and reinforced. We can't say I've had EMOC training 5 years ago, 6 years ago, and I'm trained. So these trainings require reinforcement and practice because PPH doesn't happen every day. Any other emergency doesn't arise every day. So there has to be some schedule of training. Correspondingly, we have made a recommendation saying that once we just train, there should be some mechanism to assess whether a transfer of training is taking place, whether it is being implemented or not, a point which was discussed in the morning meeting also. So that is something which we can do. And then identify gaps which could be in the service delivery. There could be delays in decision making which our algorithm should address. Human resource availability as well as training level. Infrastructure could include that a certain equipment is supposed to be there, but is it there? Certain drugs are supposed to be available, but are they there? So that analysis needs to be periodic and should be before we can say that institute a certain algorithm, we should know these things. Task force for area specific linkages. Right now, if we look at take an example of AIIMS, so we take an example of Gandhi Medical College. Patient from anywhere and everywhere can come. We can get a patient from Guna, we can get a patient from Bareilly, we can get a patient from Piparia. It will be nice if we have sort of, to some extent, a linkage map that certain facility will refer to this and to this. So there's a chain of referral which can be crossed but is usually adhered to. So those are our recommendations, and I thank our group for brainstorming on this, speaking their mind openly, addressing, objecting, adding, and giving us a very enriched view of the situation. Thank you. We are open for comments and discussion.
As Madam has suggested that somewhere we have to link postpartum. The post-baby female patients are visiting Professor Naveen is there because the postpartum psychosis is a really challenging situation if not diagnosed early. It can add to long-term morbidity. Professor Naveen, can we have some feedback on this when the mother comes to the...
Yes, sir. I think postpartum psychosis is equally eminently treatable, and the PHC medical officers are actually well placed. There are no other complications like gynecological complications or other medical complications. And eminently be treatable, eminently treated at the PHC level. Where of course I think nowadays all institutional deliveries are being encouraged. So I think we need to have another STW for managing postpartum psychosis, which is quite easy, and I think that is what comes to my mind as well.
Because usually if a female mother comes, if we have this in mind and we can identify at early stage,
yeah.
If not treated in timely manner, or permanent.
Yeah, Also, I think, no, it's not like permanent psychosis. 90% of the psychosis that have an onset during the perinatal period go on to develop bipolar rather than schizophrenia. So, unless otherwise known, if psychosis has its onset in the perinatal period, most likely they turn out to be bipolar disorders, which are episodic illnesses. But it can be treated. That's the part I make. Like otherwise, it can lead to homicidal ideas, mother neglecting the baby, and so on and so forth before it becomes complicated. That can be.
Thank you, sir. Thank you.
Good afternoon, everyone. Most of the recommendations and most of the next steps, what we have discussed, are common to most of the presentations or the groups which we have heard. One thing which I want to highlight before I begin the individual condition-specific algorithms or recommendations, I think I agree with Dr. Soni when he said that the referral system is not to be unilateral. There has to be a bidirectional referral because patients who are being referred to higher medical centers for a specific cause or availability of a specific investigation or therapeutic must be down referred as well when that specific condition has been taken care of for maximum utilization of facilities at the tertiary care level. So as far as why I am highlighting this here is because as far as pediatric conditions are concerned, in the state of MP, malnutrition is a very big problem that we face, specifically SAM. So in SAM, we have already established a system of bidirectional referrals where we have up referral as well as down referrals. So when I come to SAM, I'll share that referral system as well. But I think for all practical, the maximum utilization of facilities at all healthcare facilities, the referral facilities should always be bidirectional. And I think that should go as a common recommendation of all the groups that we are, once we are submitting that. Okay, so while I introduce my, our working group on pediatric health, we had 6 members from the AIIMS family, departments of pediatrics, neonatology and nursing college. And we had invited experts from GMC Bhopal, Dr. Manjusha Goyal, who's the current head at Department of Pediatrics, Dr. Rajesh Tikkas, and Dr. Purva Goya from the Department of Pediatrics at GMC. Then Dr. Rakesh Bhargav, an eminent pediatrician from Bhopal, who is also doing very good work in the field of organ donation as well. And Dr. Neeti was invited from GMC Vidisha, but unfortunately she could not be with us. So this was the working group that we had, and we had very good and enthusiastic participation from all the members of the group. Okay, so we know that the objectives of the today's session or the working group was to develop algorithms for common pediatric conditions. So the conditions which we had identified were initially pediatric shock, SAM, acute encephalitis syndrome, which we saw in general medicine also because that is a major chunk of emergencies which presents, and neonatal sepsis, which is a big contributor to our neonatal mortality rate in the state. So before we began developing the algorithms for all these conditions, we realized that it is important to understand the concept of ETAT, which is emergency triage assessment and treatment in pediatrics. So the first thing we did was ETAT assessment, which can be done at the various levels of healthcare facilities. And later, another objective was to identify challenges in implementation of these SOPs, which we are planning to develop for different levels of healthcare facilities. So ultimately, these were the 5 conditions that we debated upon. If we come to ETAT, emergency triage assessment and treatment, every child or every patient who presents to a healthcare facility must undergo this ETAT procedure to understand that any to identify those individuals who need emergency intervention, or if not intervene, can have life-threatening consequences. So first thing is emergency signs. We all are aware of airway, breathing, circulation, and dehydration. So this assessment has to be carried out at all levels of healthcare facilities whenever any child is presenting to these facilities. Then comes the concept of treatment. Now the concept of treatment. So whenever you do not have any emergency signs, point of care investigations like point of care blood sugar estimation and hemoglobin level should be available mandatorily at all levels, PHC and CHC. There was a discussion wherein there was a concern that some of these investigations may not be available at the PHC level, or if available may not be always in a functional state. So the main recommendation is that as a part of this exercise that we are taking, this capacity building must be ensured at the PHC level, that these basic investigations are made available and functional at the primary healthcare facilities, because hypoglycemia and hypothermia are the two major contributors which lead to mortality in children. So ensuring availability at all levels must be mandatory. So as far as other investigations or emergency management was concerned, the establishing an IV access was another concern which the group debated about. So as of now, I think there is a concern that specific to pediatrics at the PHC level or maybe at the CHC level, establishment of IV access is a challenge. So at least at the CHC level, we should have equipped manpower, trained manpower to establish IV access in young infants, neonates also. There was a discussion, every one of us has made a recommendation that ongoing training and reinforcement of trainings is a must. So our group, there was a consensus after a brief discussion that there should be a component of a pre-service induction training for all cadres of health workers, be it nursing staff, be it medical officers, be it feeding demonstrators or ANMs. There should be a pre-service induction training apart from the administrative induction that they have, which should cover these basic essential skills, that they should know how to identify sick patients, how to establish IV access, to stabilize the patient initially, and monitoring and then ensuring adequate and appropriate referral and transport. Now this transport and referral, the discussion covered all the points that we should be having a referral slip with appropriate documentation of the patient's clinical condition at presentation, the documentation of interventions done or the stabilization measures given at that specific healthcare facility, the person who has been contacted at the higher level of healthcare facility, and how the patient is being transported. So ensuring stability, hemodynamic stability during transport, and an informed transport so that the patient, the receiving facility is well prepared in advance to receive the patient and know in what clinical condition the patient is expected to reach there. So this will hold true for all the conditions that we discuss further. So after identifying patients who need emergency treatment, look for priority signs, and those who do not have priority signs, this priority sign assessment also needs to be taken at all healthcare facilities, and administration of parenteral antibiotics, if not IV, at least IM antibiotics should be ensured CHC level onwards, and at district hospital and medical colleges, it has to be intravenous antibiotics or intravenous fluid administration, which must be mandatorily ensured. Another point of concern here was, as in I think adults also, they discussed insertion of orogastric tubes. So specifically for children with SAM or children who present with dehydration, persistent vomiting, wherein at PHC, CHC level, IV cannulation is not possible. So the staff should be trained in insertion of nasogastric tube, and administration of ORS or feed through the nasogastric route for initial stabilization must be ensured at PHC or CHC level. Again, coming to the algorithm on shock in children, not going into the algorithm specific details of the condition, at the we know what are the identifying or entry points for identifying any child with who's presenting in shock, whether it is change in mental status or tachycardia,
heart rate or pulse above the given cutoff for age, weak thready pulse or prolonged CRT. So identification of shock, all staff at all healthcare facilities must be trained to identify this shock early, and the immediate management which is required is an IV fluid bolus. Again, at the PHC level, if IV fluid administration is not possible, insertion of a nasogastric tube to ensure feeding. Ideally, we would want and we would recommend that the child in shock should receive a IV fluid bolus and oxygenation at the earliest point of identification. So building that capacity at the PHC level, I don't know how feasible right now it is, but as a recommendation, we have put it in that at the PHC level, all staff should be trained for establishing IV access in children. Then at the CHC or district level, the appropriate management of shock should be initiated, and after 1 hour, the assessment, if this is not a fluid responsive shock, the treating personnel at the CHC should be able to identify that this is fluid refractory shock, and again ensuring hemodynamic stability and informed transport. The patient should be shifted to a district hospital, wherein other measures like intraosseous if required or addition of inotropes can be done to ensure that the shock is being managed in the appropriate manner. Central venous pressure monitoring, etc. I don't know whether it is feasible right now at the district hospital level. If it is not, catecholamine refractory shock should be referred to a higher medical college, or with multi-organ dysfunction if it is already set in with shock. So these patients can be referred to a medical college for appropriate management there. And coming back to the concept of down referral also, if this is septic shock which has been taken care of, the patient has achieved hemodynamic stability, is on the recovery path, for completion of course of antibiotics, the patient can be and should be down referred to the primary health care or the DH or the CHC from where the patient originally came. Keeping a patient in-house at a tertiary care hospital just for a course of completion of 10 days or 14 days of antibiotics does not justify the maximum utilization of facilities at that tertiary care level. So that bidirectional transport will definitely help us. Coming to SAM, we have well-defined criteria for identification of children with SAM. There are issues with identification of hydration status or shock in SAM. So again, the pre-induction training which we talked of there is a training of structured training for identification and management of SAM across the state, which takes place regularly. But with the new recruits joining in and trainings being done for, somebody being trained 5-6 years ago, there is a need for a retraining also. So timely retrainings, resensitization is a must, and there is a structured protocol available for management of SAM. Now, not only SAM, we have also developed a protocol for identification of non-responder and critical cases of SAM who do not respond to the structured protocol which is implemented throughout the country. So at the PHC level, PHC or CHC level, what we expect is that everyone should be able to identify a child with SAM, prevent hypothermia or hypoglycemia, identify presence of hypothermia and hypoglycemia and initiate corrective measures, advise the mother to continue breastfeeding, administration of parenteral antibiotics, if not IV, at least intramuscular, and ensure proper transport with due communication. At the district hospital or NRC level, ensure correct implementation of the structured SAM management protocol, ensure follow-up, and identify the non-responder and critical cases. This identification of non-responder cases is very important because the structured protocol is a 14-day protocol. So what happens is after 14 days of completing that protocol, all children of SAM are practically discharged without documenting whether these children have been cured or not. They are not discharged from the program, but they are discharged from the healthcare facility. So identifying those cases which have not responded to the structured management protocol and then referring those cases up to the medical college, SMTU or smart unit level for workup of identifying the cause of non-response. So the role of medical colleges comes there where they identify the cause of underlying non-response or the critical morbidities associated with SAM,
ensuring that the investigative workup and therapeutic management of the underlying cause, for example, whether it is a heart disease underlying or chronic kidney disease or an inborn error of metabolism, whatever that disorder is leading to non-response to the nutritional management. So initiate, diagnose that underlying cause and initiate appropriate intervention measures for that underlying cause. And once the patient has been initiated on those measures, down referral can be made once the patient is on road to nutritional recovery. We don't need to keep the patient admitted in medical college till full recovery. I think acute encephalitis syndrome we've already discussed in general medicine. Only specific concerns here was in children, identifying and treating hypoglycemia early, which should be done at the PHC level itself with what we recommended, that we have a point of care blood sugar estimation. So identification of hypoglycemia, inclusion of HIV encephalopathy as one of the causes, especially in children. So HIV testing at the CHC or district hospital level, and the rest of the definitive management to be continued at the medical college level, the neuroimaging, the EEG, etc. at the district hospital level or the medical college level. Neonatal sepsis, again, what we discussed was that we need to have a working definition as to when to suspect neonatal sepsis, what are the symptoms that the staff posted there should be aware of, when to suspect neonatal sepsis in a child who is being brought to the healthcare facility. Again, there was a concern raised by our neonatologists that there are some newborns who are delivered at these facilities and the child may not be brought with any symptoms, but there may be presence of some risk factors per se in the antenatal period, which might predispose the child to neonatal sepsis, like premature rupture of membranes. So for these children, identifying these risk factors to be done at each healthcare facility level, and then at least CHC level onwards, ensuring availability of sepsis screen investigations like CBC and CRP. Again, the guidelines recommend sepsis screen has 5 components, one of which is micro ESR. Now, as far as micro ESR is concerned, even at medical college levels, at present it is not available, it is not being done. So should we keep it included in the guideline or the algorithm? That still remains a question of debate. Otherwise, blood culture facility, CBC and CRP to be available CHC level onwards at least, and blood culture facility from district hospital as well as medical college facility should have all these facilities. Facilities for neuroimaging, lumbar puncture at the district hospital and medical college level should be available. And in those newborns wherein there are risk factors, whether they have to be started on antibiotics or not should be decided after the assessment of risk factors and positive or negative sepsis screen. So identifying those newborns who may have a risk factor but are sepsis screen negative should not be started on antibiotics to prevent excessive and injudicious use of neonatal sepsis also. So coming to healthcare facility wise recommendations, at the PHC or CHC level, identify risk factors or presenting symptoms, stabilize the baby. If required, resuscitation as per the NRP guidelines must be known to all cadres of healthcare staff, administration of parenteral antibiotics and ensuring safe transport. At the district hospital where there are established SNCUs functional, all sepsis screen facilities along with blood culture, stabilization, CPAP, oxygenation, even ventilation facilities are available at the DH SNCUs. Managing neonatal shock, neuroimaging by transfontanal USG, all these facilities should be functional at the district hospital level. At the medical college level, if any child requires total parenteral nutrition, requirement for mechanical ventilation, management of septic shock and complications like septic arthritis, ventriculitis and multi-organ dysfunction, only in these conditions should patients with neonatal sepsis be referred to medical colleges. So next steps and recommendations are similar to what other groups have recommended. Development of training modules or manuals for various cadres of healthcare workers. Trial run across a model district to identify the challenges or bottlenecks. And once those challenges or bottlenecks have been identified, these SOPs can be modified accordingly, ensuring proper transport. And another thing which the group recommended, especially for children who present with seizures like in AES or other conditions, ensuring availability of midazolam spray for control of seizures, because sometimes intravenous anticonvulsants establishing IV access is a challenge. So at least nasal spray or maybe a rectal suppository should be available and the staff trained. Rectal suppository again might have its own challenges. So we are only recommending that at least nasal spray should be available and staff should be trained for that.
At PSC level, there is apprehension to the right. It's very even in other hospitals. How can we manage that?
No, at the village level, if you see, we are training ASHA workers and ANMs to examine newborns. So the medical officer is better trained than the ASHA worker or ANM, so that fear has to go out. I think that pre-service induction training, if we can give them hands-on training, maybe in a medical college, should probably take care of it. As a Indian medical graduate, nobody should be afraid of touching the child. ASHA and ANM, we are asking to identify sick newborns and do all the essential newborn care at the village level. I understand. वो हमारे बच्चे फेब्रुअरी सीजर्स के साथ आते हैं, उनके पेरेंट्स को हम रिकमेंड करके देते हैं, लिख के देते हैं कि एंश्योर दैट दे हैव द स्प्रे विद देम एंड दे नो हाउ टू यूज इट. There are making recommendations.
लर्निंग हो गया ना
हमारा तो फिर भी हम मतलब यहाँ सब एक्सपर्ट अवेलेबल इंजेक्शन भी दे रहे हैं, लेकिन आइडिया होना चाहिए.
Dr. This is action point for you. Yes. ATR आप देंगे.
Yes sir, yes sir. Yes sir. Good point, Miller. I mean, sir, and also.
Permission of house, should I start? Yes. Thank you. Very good afternoon to all of you. We are working groups led by Professor Nitha ma'am, Professor Head Department of FMT, AIIMS Bhopal, Dr. S.D. Garg sir, Dean of Satna Medical College, Head and Professor of Forensic Medicine, Dr. Manish Nigam sir, Professor Head at Department of FMT, Vidisa Medical College, and my friend Dr. Rajendra Pratap, along with me. And after so many wonderful presentation and discussion, I don't think I need some objectives to describe, because where there is a medical case, there is definitely a legal issue. So medical legal issues related to any clinical cases or in an autopsy case, we group members have discussed and recommended, and our recommendation classified into 7 categories. First one is coverage and service, and it's further classified into 5 types. So primary care, in our recommendation, if we adopt that this in our state as one state, one health policy, I think this will be cover up maximum problems and brings the solution. Autopsy, including dissection, should be by doctors at department at designated well-equipped autopsy center. I don't think other than tertiary level center, no doctors they are conducting, they are doing the autopsy dissection. Okay, no doubt they are taking the help of other staffs, but that help or that much of contribution of staffs are much more than the doctor. But while report framing, these all things are on the burden of doctors only. So medical legal case registration and preparation of report by primary doctors. What are the precautions in our service? In this era of this era of electronics, we always all have the forensic digital X-ray, digital XLR camera, so we can take the photographs. So this photographical knowledge for the administration of justice can help us to create any problem further. And proper documentation and preservation, as we know, this photography is one type of documentation along with the comprehensive evidence collection process. That means one policy to document, and that is the uniform one throughout the states. And SOPs, standard operating procedures, and medical legal manual. We have medical legal manuals, we have many SOPs to run our department, to our institute, but many of these are not gazetted. Here we have recommended or we have make it approved from our director sir, but in state level it should be gazetted one so that everyone follow the same thing. In emergency care, emergency service like 24/7 facility for night autopsy. Here only I think any other tertiary care center they can adopt. Mandatory service like immediate short postmortem report. We are giving immediate short postmortem report just after the autopsy and full medical legal report within 48 hours. It is the recommendation from the DGHS. Use of biodegradable body bag to maintain the dignity of dead. We are using here, we are keeping the body in the dead bag. Any death we are keeping in the body bag after the COVID. But we can use any other biodegradable cloths or which can be easily degradable for maintaining the dignity of the dead. So basic embalming facility, cavity embalming, surface embalming, if it will be, then the relatives will be happy and they can easily, they will be agree upon for medical legal autopsy. The use of safe kit for medical legal examination, like sexually asserted forensic evidence kit. These are nowadays prepared by the NFSU, National Forensic Science University, Gujarat, in a cost of 50 rupees. We are also preparing here in a separate form, and that is cost around rupees 150. If anybody they have recommend or they request us, we can also provide them. Networking. The working committee recommend that there should be a recommending to establish the center of excellence, which can train the newly recruited doctors or mid-career doctors. So we not only invite the doctors to train, to take training here, we also invite the resources person to deliver lectures and share their experience here for medical legal facility, how to make the easy facility of medical legal services. The working groups recommend there should be a technology integration that we should all adopt the MEDLIPA. That is the medical legal examination reporting and autopsy reporting. It should be linked with CCTNS and E-code and forensic science lab. We know that जैसे आप लोग बता रहे हैं कि there should be in bi-directional. जैसे पेशेंट का जो genuine cause के लिए आया था, अगर वो चला गया है, patient can refer to the lower center, है ना? तो वैसा ही है. We always send the sample, poisoning sample or any other forensic sample to the forensic science lab, but never we get any report. So there should be linked with MEDLIPA, CCTNS, and E-code and forensics. Working groups recommend there should be regulation and uniform policy like training of doctors and paramedical staffs for evidence collection and documentation. Group of doctors always complaining that we have no staffs. How can we do the evidence collection and documentation properly? So we can use the paramedical staffs. There should be a separate budget allocation for consumables in mortuary. For consumable of mortuary, a huge amount is not required. These are minimum things. It should be there at all the center, not only autopsy center, in clinical departments also, like viscera in saturated common salt solution, blood in NF vial, and for histopathology in 10% formalin solution. If we preserve the viscera or sample in a later time, there is possibility of autolysis. FDA card for DNA test. FDA card means Flighters Technology Associate card. And there should be a public awareness for organ donation. Like we know all about the cornea donation, eye banking, but we forget about the bone bank, skin bank. These are helpful. Okay, so wherever there is autopsy going on, we can also recommend, we can create awareness among the public regarding this organ donation and body donation awareness. There should be, we should take care of environmental care. Means the waste, biomedical waste from the hospitals or mortuary, this can create an infection, and we are disposing the PP kit, gloves and body bag in a proper way. And way forward, we should think of these things like drug overdose, drug abuse cases, poisoning information center, zoonotic diseases, or the disease caused by the animals, especially now the sensitive dog bite, snake bite cases, virus infection like Triple H, HIV, hepatitis B, C, rabies, and we should focus on AIFI, that is adverse effect following immunization, either death or disease. So with this, I want to thank for the patient sharing, and now the house is for open discussion. So any query you can.
Go ahead. Yeah.
There is one recommendation that should the government of India to have for the every many states have already subsidized, and many others who are working. They should also.
Just put that in.
Yes, definitely. Many states have already adopted that. Yes,
it will include it, it will come to the white paper.
Thank you.
Thank you. Final remark from Dr. Bhatt, then we can have this one group photo here. For today. So,
yeah, good evening, everyone. So, as we conclude this session, I'll be just summarizing the events, the minutes of the today's event. So, initially, the event started with the inaugural speech by our director, sir. So, the introduction about the One State and One Health policy by the Executive Director, AIIMS Bhopal, and he emphasized for uniform protocols and SOPs for better and consistent treatment by the healthcare providers. So, he also echoed that this is the first this is the first initiative by the state all over the India which was done. Professor Malik sir, the president of the AIIMS Bhopal, he further emphasized a need for a proper surveillance system and implementation of these guidelines. Honorable Deputy CM welcomed this initiative of AIIMS Bhopal and emphasized that benefit of this brainstorming will be reflected by improvement in healthcare indicators of the state. He further emphasized that the focus should be on strengthening primary and CHC levels. Honorable same further appraised AIIMS Bhopal for providing e-ICU services, which is being reflected in the patient care in various district levels and district hospitals. Further, this was followed by a panel discussion where we have a panel discussion from the public health expert as well as from the various stakeholders. All of were divided into the following four headings. The first is the common health problems or common health conditions in the state of Madhya Pradesh. The second is the readiness of public health care delivery system. The third is why we need these standard guidelines or standard SOPs for our state, and challenges and opportunities. So the various stakeholders, they discussed the first, it was discussed that as we have more of a communicable diseases, but nowadays the non-communicable diseases, they are also increasing. The prevalence is increasing for NCDs, as well as we have many occupational hazards that should be being taken care of. There should be timely referrals, and there should be a timely referral during the golden hours. It should not be delayed. There should be a focus on the IMR, MMR, specifically on the preventive and the promotive aspect. In the discussion, it was brought out that there should be appropriate referrals with communication between the referring and the referral centers, and coordination is required between these different centers. Regarding the need for the SOPs, it was discussed that patient at every health facility should have consistent treatment, and these STGs should be individualized depending upon the level of the healthcare system. Means it should be different from primary health care center, it should be different for the district hospital or for the medical college. Further, a need for the comprehensive treatment for polytrauma and cancer was brought out in the discussion, as well as a need for tertiary cancer care center in the state. Regarding the diagnostic or the blood bank facilities, it was discussed that there is a robust infrastructure in place in government blood bank systems, along with an online portal system to know the availability of the blood bank or blood availability. For the radiological services, an integrated system between the government and private sector was proposed for timely detection of various conditions. For the emergency services, clear indications for the referral should be mentioned. The second, there should be a strictness in the monitoring of the referrals, that why the patient is being referred to other center. Also, it was brought in the discussion that there should be an indigenous manual. So, just to give an example, I am an IAP ALS instructor also. So, initially we used to have a copy of AHA, IAP Indian Academy of, this is AHA's, American Heart Association, Pediatric Advanced Life Support. But from last 3 or 4 years, we are having our own indigenous manual based on our own different kind of sickness, even poisoning, or even different kinds of the conditions which we deal with, like diarrhea, dehydration, and ERI. Okay? So even the BLS, we have our own IAP BLS module which we run as a IAP BLS or ALS. Okay? Then at the end of the panel discussion, Dr. Pankaj highlighted that focus on ABA ID should be done, as many pre-referral investigations can be assessed by the ABA IDs to these different individuals. Following this, the group was divided into 7 groups for brainstorming at various standard treatment guidelines. The group were 7 groups. The first was trauma and injury group. The second was the emergency and the critical care group. General surgical condition group, maternal child health group, medical legal issues group, and the medical and the psychiatrist group. So all of them, they have a debate, and they identified 3 to 7 conditions which should be discussed, and a consensus was reached among various members for the uniform protocol to be followed at various levels such as PHC, CHC, district hospital, or medical colleges. The challenges were also discussed among various groups. The common challenges were implementation of these protocols, the first and most important. The second was availability of the drugs or the equipments, the skilled manpower, and the identification of key signs, whether the person at these different levels will be able to identify these various signs or symptoms which we have mentioned, and the timely referrals. The group also provided the various recommendations. The first and most important recommendation was training of the manpower at these various levels, formation of a checklist for different protocols, the medical audit, which is good, I think it is one of the good recommendation for a debriefing, the task force, the down referrals, and a safe transport. So at the end, on the behalf of the AIIMS Bhopal family, we thank all the experts and guests for participating in this brainstorming session. Thank you.
These are persons behind for.
So I was troubling you all, mainly persons from the working group, since 15-20 days, and I will again travel for a few more days. It's not over. So basically, many working groups were there, and we have deliberated on many conditions, more than 25 conditions. And if we have looked at the group report, that work is almost done. So that is a mammoth task which all of you have done. Amit sir has suggested that we take it as what you can say working group paper, or even we can think of going ahead in our AIIMS journal, the Fortune journal, AIIMS journal. We have one journal, which future journal. We can take out it as a supplement with consent from our ED sir and other steering committee members. So all of you have literally contributed a lot, because I was looking at other stuffs, but technical thing that has been very fantastically done, and 100% efforts have been done. So thank you from bottom of my heart to all of you, and sorry for any trouble or inconvenience during the arrangements. So we will take group photo of whoever is left, and then we will disperse. Thank you very much.
This side or that side? Maybe in the